Good morning, friends. Greetings from Kerala Society of Ophthalmic Surgeons. This is the 11th in the Kerala Society of Ophthalmic Surgeons Scientific Committee CME series, which we started in January this year. And it's become a very, very popular online CME program, with the last one that we had, which was on low vision aids. See, you don't expect huge viewership for low vision aids, but even that has crossed 2,000 views. And the one that we did on refraction, in fact, has crossed 6,500 views. So this shows the extreme popularity of this online CME series, and it's basically because everyone. We have been selecting the best faculty, the topics which would be the most useful to the practitioners and PGs and everyone. And see, what we did was to involve the district ophthalmic clubs totally in this program. So it's Kerala Society of Ophthalmic Surgeons basically guides the district ophthalmic clubs and it just gives them the logistic support. It is basically the district ophthalmic clubs who have been designing the program, getting the faculty, and in fact, all the work is being done by them. So this program, it's being done by Random Ophthalmic Club, Dr. Thomas George, my scientific committee member, and Dr. Harshali have been putting it. Dr. Manoj. All have been putting in their brains to design this program and get the best faculty. So this I'm sure that this is basically an interactive session between the presenter and the moderator and the faculty, and it's basically in a discussion mode, and because it is in a discussion mode, it's going to be going to bring out a lot of practical points which we are used to everyone. So this is basically on the scientific committee CME series program. Just a word on Drishti planning. So we have our Drishti 2022 coming up in Kozhikode in the last week of November, 25, 26, 27th of November. We have received excellent response for our calls for the free papers, instruction courses, and all. And in fact, we have had to increase the hall numbers from 5 to 7. So this shows that the kind of interest ophthalmologists have on our annual conference. And I'm sure that the Kozhikode Ophthalmic Society, for the host, will do an excellent job in being a great host. So with this introduction, I hand over the stage to the MC. Thank you.
Thank you, sir. Thank you for giving us the opportunity to organize this CME. I now request Dr. Thomas George, our Secretary, Trivandrum Ophthalmic Club, to give us a welcome address.
Good morning, everybody. We at the TOC are greatly honored by the scientific committee in entrusting us with the 11th CME, and that too, retina, which is probably one of the most popular topics for ophthalmologists after cataract, of course. And our scientific committee chairperson Harshali has worked on the background for this CME a lot. I thank her also. Now, going on to my responsibility in this inauguration, I take this opportunity to welcome Dr. GopalPillai, our KSOS General Secretary, who has graciously accepted our call to be a part of the inauguration. He is also going to be organizing one of the key sessions in this CME later on. Welcome, Gopal. I welcome our President TOC, Dr. Sushila Nair, to the inaugural ceremony. Welcome, ma'am. We look forward to your address soon. I welcome our scientific committee chairperson, whose brainchild this entire program is, Dr. Sreeni. Welcome to the meeting. I welcome all the eminent faculty and the panelists who have agreed on a Sunday to spare their time for our CME. We're grateful to you. Welcome all of you. And of course, all our viewers, we welcome with pleasure. Thank you.
May I now invite Dr. GopalPillai to inaugurate the CME, sir?
Yeah, thank you very much, Harshali. President of the DOC, Sushila ma'am, Scientific Committee Chairman, Dr. Sreeni, Scientific Committee member from Trivandrum, Dr. Thomas George, all the eminent faculty who are present here, and dear viewers. It's indeed a pleasure to be in any Kerala Society program, because whenever Sreeni or anybody does the program, the quality would be really amazingly wonderful. So KSOS is a vibrant body of about 2,500 members with a lot of activity. We have probably crossed close to about 150 CME programs this year, both online as well as offline. Earlier, what used to happen was only the eye hospitals would do, but currently what we are doing, as Sreeni said, the KSOS has engaged each of the district ophthalmic clubs. And this is the 11th such program where the district ophthalmic club, along with KSOS, is conducting an online program. And no effort is spared in getting the best of the best faculty and the most important of the topics, the most useful of the topics for the practicing ophthalmologist. So here we are today looking at retina. There will be 4 sessions, one on CSR, one on diabetic macular edema, one on proliferative diabetic retinopathy, and the last one on choroidal neovascular membranes. These are the common 4 medical retinal problems that are faced by an ophthalmologist. And by the end of this 4-hour program, there would be a significant take home for each of the person who is viewing this. Ellavarkum Samburna Netra Saksharata enna, that's the eye literacy for all was the motto that we came up with this year. And for that, we have been doing a lot of things. One is, more information to the ophthalmologists, empowering the ophthalmologists by such programs. Then, information transfer to general public by talks by senior ophthalmologists across the state. Even in the World Glaucoma Day, we had about 125 hospitals partaking in free glaucoma screening. So a lot of activities from Kerala Society of Ophthalmic Surgeons, and coming to TOC, which has been always in the forefront, doing programs and conducting CMEs and breaking this information barrier to ophthalmologists. I congratulate the Trivandrum, the TOC for this wonderful program, and declare this program open, inaugurated. Thank you very much.
Thank you, sir. I now invite Dr. Sushila B. Nayak, the President of Trivandrum Ophthalmic Club, to give the President's address.
Thank you, Harshali. A very good morning to all of you. I take this opportunity to congratulate the office bearers of the Kerala Society of Ophthalmic Surgeons, Dr. Arup Chakravarti, the President, Dr. GopalPillai, Secretary, Dr. Sreeni, who is the Scientific Committee Chairman, and Dr. Biju John, the Treasurer. I also thank you for collaborating with us, the Trivandrum Ophthalmic Club, for organizing this CME program. In this program, we hope to cover the common retinal diseases which can be seen in any general ophthalmology clinic. We have sessions each covering one topic in a comprehensive manner and discussed by panelists. My thanks to Dr. Manoj Soman, Dr. Prakash V.S., Dr. Thomas Cherian, and Dr. GopalPillai, who have spent a lot of time and effort in planning the talks and discussions. I welcome all the speakers from all over the country who have kindly agreed to take part in this CME program. A warm welcome to all who are attending the program. My sincere thanks to my team members, TOC, especially Dr. Harshali Kamath and Dr. Thomas George, who have spent a lot of time in organizing this, and that they made it happen. So thank you. Thank you all.
Thank you, ma'am. With this, we'll will come to the end with my vote of thanks. So on behalf of Trivandrum Ophthalmic Club, I would like to thank Secretary KSOS, Dr. GopalPillai, Dr. Sreeni, who has guided us throughout in organizing. So I've troubled you a lot in the last couple of days. Sorry. Dr. Sushila, our President TOC, Dr. Thomas George. I thank all the chairpersons, the speakers, the moderators, and the panelists who have taken time in making this CME happen. I thank all the TOC members for the support in organizing this TOC. I thank all the viewers who will be attending this CME. I now invite Dr. Regina to moderate the first session. Dr. Regina is a consultant at Chaitanya Eye Care, and she's completed her VR fellowship at Retinal. Dr. Regina, please, I hand over the session to you.
Regina, before we go into the scientific program, with the permission of General Secretary of Kerala Society of Ophthalmic Surgeons, Dr. Gopal Pillai, see one of the greatest leaders in Kerala, Dr. Kothari Balakrishnan, passed away yesterday, and see, he is basically from my hometown, Talasheri, and he has been quite supportive to the all ophthalmology activities. And in fact, he was the when he was the Home Minister, he was actually the person who inaugurated the first CME by contrast, and a very affable person. See, you'll always find him smiling. I had the good fortune to operate on him. See, I did cataract surgery in his both eyes, and see, one of the best patients you will ever get. So he was a opposition leader at that time. He came without any fanfare, just came, operated, went off, and after that, see, he was following up with Gopal for screening diabetic retinopathy. So just wanted to pay homage to that departed soul. Just half a minute silence, and then we'll move on to the scientific program. Then Regina can take over. Regina, you can start.
Sreeni, you have told everybody 9 o'clock, so I think the scientific session should start at 9.
Yeah. Thomas or Sreeni can introduce all the speakers in the program.
Yeah.
If you have the program brochure, you can put that program brochure and introduce each and every person. Can somebody share the program brochure? Thomas, you have? Then you can introduce each and every person, so that you'll have, maybe by 8:55 you can start the first session, introduction of the first session.
Actually, I think you'll have to do it because I don't have it on my computer.
Yes, sir.
No.
So actually, Dr. Regina has the first. I can share her. The introduction of the speakers of the session. Can we start with that?
No, I will do that. I will do that. One second. I will put the brochure.
No, I have.
No. First, let the brochure come, so that overall.
The choice of the topics are actually done by Manoj, and he has, in a short period of about 2 hours, come up with these 4 topics, and I think they're the most relevant. So a lot of credit for the actual program should go to Dr. Manoj in choosing the original topics. And of course, the 4 chairpersons, they have chosen very good faculty, and we are very happy. Though TOC and scientific committee does take credit for the CME, the real backbone is the program. And in creating the program, the 4 chairpersons have done an exemplary job in choosing the faculty and the panelists.
So can I share the brochure?
Yeah, please.
Is my screen visible?
Yeah.
You can magnify it. Yeah.
Manoj, if you're there, can you walk us through the program?
Now,
Manoj.
yeah. Good morning, all. So the basic idea of this session will be to introduce everything that you want to know about CSR. When would you like to investigate a patient with CSR, and what are the investigations that you should be looking at? And we know that most of us do not have all the multimodal imaging. So how do we go about investigating a patient in this context, especially when we don't have all the multimodal imaging? Second would be to look at the management of CSR. Though there are certain things which are straightforward, there are still certain areas which require some more clarity, like management of subfoveal leak, especially now that we don't have photodynamic therapy. So how do we go about managing subfoveal leak? When should you manage? When should you observe? And finally, we would like to touch upon mimics of CSR, which these are things that we commonly come across in our practice, and we really want to differentiate from CSR. So these are three main topics that we have three excellent speakers who will be covering these topics. And following this, we will have a panel discussion where we will try to address some specific questions. There is a new classification that has come up. We want to see if this is really applicable in our clinical practice, whether we can actually use it in our clinical practice, and also touch upon a few other areas which are of practical and clinical relevance. So this is the idea. So the format is we have three talks. It will be of 12 minutes each, and this will be followed by a panel discussion of around 20 minutes. So each session will have the same schedule of practice.
Okay. You can unshare, Harshali, and Regina can actually introduce Manoj and the speaker and panelists. So by that time, once that is over, we can start the talks. Start with the first talk.
Good morning, and welcome all to this session of Central Serous Retinopathy, which is our first session in this CME module. So we know CSR is a very simple and common disease that we encounter in our clinical practice. But this simple disease can sometimes be very atypical and complex for us to investigate and to manage. So at this point, we need to know what are the more finer details of this disease, how to go about with investigate these things, and to differentiate this from other mimics. So we have a group of talks which will help you to identify, investigate, and manage. And at the end of the panel discussion, we will have some new thought process how to deal with these cases. So in this session, we have our chairperson, Dr. Manoj, with us. He's the head of the Department of Vitreoretinal Service at Chaitanya Eye Hospital, Trivandrum. He's a very senior VR surgeon and a good teacher and a great academician. And he will be chairing this session. Welcome, sir. And we have three talks in this session. The first one is by Dr. Abhishek. He will be talking about the investigative modalities in CSR. And, he's a senior VR surgeon from the Pink City, Jaipur, and a lot of experiences in different areas. And he's a well-known faculty and speaker in multiple international and national retina interest groups. And here he will discuss about the investigation. And our next talk will be by Dr. Sunil Ganekal. He is a very prominent person in the Karnataka Ophthalmic Society, and with a lot of publications and presentations. And he will join with us to talk regarding the latest treatments of central serous retinopathy. And we have a third talk by Dr. Divyansh Mishra. He is from Shankara Eye Hospital, Bangalore. He's a senior VR surgeon there, and he has got a very good and great experience in ocular oncology. So he will be talking regarding the CSR mimics, how to identify and deal with it. And after our talks, we will have a panel discussion, and we have Dr. Unnikrishnan, Dr. Natasha, Dr. Rajesh from Perinthalmanna, and Dr. Ashok Nadarajan to discuss the common difficulties and how to tackle all these things. So I welcome all the speakers, panelists, and now we will move on to the first talk in this section. So I welcome Dr. Abhishek sir to share his screen and talk to us regarding the investigations of CS. Welcome, sir.
Abhishek.
Yeah. Good morning, sir. And a special thanks to KSOS for inviting me. Basically, it's always a pleasure to be, associated with KSOS. There's a very interactive crowd, and I think a very useful session. So I'll talk. My talk is basically on investigations in central serous retinopathy. Is my PPT visible?
Yes, Abhishek, we can see your slides. Yeah.
Right. So central serous retinopathy is a very common disease, and I think it's the fourth most common retinopathy that presents in the ophthal OPD. And we usually consider it as a minor irritant rather than a serious disease, but in certain cases it does progress to cause visual loss, permanent visual loss. Now, how do we have a wide array of investigations available to us as retina surgeons, starting from the fundus photograph, going on to Octa and certain advanced electrophysiology. How do we tailor our approach to investigating a CSR patient? So in the clinic, most of the CSR that we see is either acute, where they come with the first episode. Now this, the patient may come very early on in his first episode, or may come a little later, maybe say a month or a month and a half later. This is probably one of the most common presentations that we see in our clinic. We also sometimes see recurrent acute episodes in a patient that has had a previous CSR, or sometimes we see chronic CSR, simple bilateral ones, or with an additional pathology like a CNVM. Also, sometimes we see multifocal CSR. And the fourth category that I would say is the treated CSR, where we have done some, we've employed some kind of a treatment, either medical or laser. And then we basically want to see the treatment response. So we are going to look at the investigations with these things in mind. So now, what are the goals of our investigation? The goals of our investigations, the purpose, if you see the top row, one is to demonstrate the presence of SRF. The second is to have an idea about the volume of SRF. Also to look at the RP status. When we want to treat, we want to localize the leak. We also want to, find out the presence of complications. And of course, we want to sometimes document the disease. So on this side, I've on the first column, I've put these situations as acute CSR, recurrent CSR, chronic CSR, and treated CSR, and we'll look at which investigation is going to help us. Now, coming to the first, that is the fundus photograph or the color red-free. It really does not have too much value except for documentation. The best part is that it is easily available. It gives you an NFAS 2D view of the extent of the fluid, and it is very useful for documentation and patient counseling. Now, here I would like to point out that the red-free images are always better than the color images to identify the extent of fluid. Now, autofluorescence is again a very useful modality because it shows us, one, it is non-invasive, it demonstrates us the RP health, the physiological status of the disease. RP tracks and atrophy are easily seen, and it can alert us to active areas in cases of multifocal CSR, sometimes where the fundus picture is not that great. OCT is readily available. It is a non-invasive cross-sectional imaging modality with quantification. It can be easily repeated. Anatomical derangements are very well seen, both with intra and subretinal, fluid are clearly identified and the extent can be seen. And also you can quantify the fluid volume and provide temporal trends when you do sequential OCTs. Now I'll go a little bit in detail about the OCT findings. OCT demonstrates fluid, and also most of the OCT findings have a prognostic value. Initial larger volume of fluid points to a larger improvement. If you would excuse me, I will just shut off the phone 1 second. Sorry for that. Now, again, a shallow fluid in a chronic CSR patient also is basically a marker for a poor treatment response. When we see CSR and we see a lot of material shrem or basically fibrin accumulation in the subretinal space, this is again a manifestation of a severe leak. And intraretinal fluid in any case of CSR points to chronicity and a poor prognosis. That is the almost 50% of these cases have an association with the CNV. RP defects are very clearly demonstrated by the OCT, and PEDs are very frequently seen. Also, they increase the risk of non-resolution with simple observation. And the higher the number of PED, the worse the response. The lower number of PEDs correlates with a better response. Also, RP atrophy predicts a poor response to the medical management. A lot of us now give eplerenone during in certain cases, but RP atrophy points to a worse response. Also, outer retinal findings are important. Discontinuity in the ellipsoid zone, the ELM and photoreceptor layers, all correlates with poor visual outcomes. Choroidal thickness, as we all know, now CSR is considered to be part of the pachychoroid spectrum, and a thicker choroid actually corresponds to certain a good response with certain therapies. A thinner choroid with RP abnormalities points to a poor response to your intervention. Also, future complications can be predicted, like CNV can be predicted with OCT. Like I said, that the initial hyperreflective foci in the retina, initial inner choroidal attenuation, and presence of macular complication in the other eye on the OCT points to a higher risk of development of CNV. We can also do a 3D volume analysis and basically find out what the fluid volume was. Now, coming to FFA, this has been the workhorse of our investigations in the past, and for CSR, it still continues to be one of the most important investigations. It points to the dynamic status of the defect. It identifies both the site and the type of leakage, and it is essential for treatment planning. Now, anytime, whether it's acute or chronic CSR, if you want to plan treatment, and the only treatment right now, active intervention available to us, since PDT is not there, has been focal laser therapy, and for that, FFA is a must. You may see the smokestack kind of leakage that you see very clearly in these angiograms, or you may see the ink blot kind of leak that you see in this particular angiogram. Now, in certain cases where you have minimal SRF, FFA can point to the presence of a sick RP syndrome or the RP epithelopathy. And this is seen in this particular case. Also, FFA, I'm not going to talk too much about this, but FFA can point out to certain masquerades of CSR. Now, this is a fluid pocket with obviously no leak on the angiogram, but we could make out that there is an optic disc pit. Now, what is the role of ICG? ICG has been touted as another important investigative modality in CSR. As far as the demonstration of leaks is concerned, most of the leaks seen on FFA are also seen on ICG. However, there are a lot of areas of choroidal hyperpermeability that are also seen on ICG, which are not seen on the fundus fluorescent angiogram. Like you can see these widespread areas in a case of multifocal CSR. This is the other eye of the same patient, where you see the multifocal leaks on the FFA. You can see most of them on the ICG also, but along with that, you can see a lot of areas of choroidal hyperpermeability. Now, Octa is the new kid on the block. However, in CSR, it has a very limited role to identifying the neovascular complications of CSR. It is not routinely needed in every case of CSR, but if you suspect that there is a RP irregularity on the OCT, or there is no response or limited response to your treatment, you may want to go for an OCTA, and it will demonstrate the CNV quite beautifully. Now, this again is a case of a CSR complicated with CNVM, where you could see in the left eye, there were typical CSR leaks also. And the center, there is a hyperfluorescent area which you may want to, somebody may call a PED. But on the OCTA in the bottom panel, you can see that there is a CNV coming up, and this particular patient responded to a combination of focal laser and anti-VEGF treatment. So now coming to this chart, which I showed in the beginning. Now, if we reveal this in an acute CSR, you want to demonstrate the presence of SRF and have an idea about the volume of SRF. In a recurrent CSR, you would want to early identify the presence of SRF, the volume of SRF. You would also, in a recurrent CSR, want to look at the RP status, and maybe you want, in a recurrent CSR, you want to treat early. So leak localization is also important here. In chronic CSR, presence of SRF, the RP status, leak localization, and presence of complication, identification of all these factors is important. And in a treated CSR, you would want to monitor the disappearance of SRF. So if you look at what investigation is best in which particular case, if you want to document the presence of SRF or the volume of SRF, OCT is the best possible investigation modality, the routine OCT. For RP status, there is no doubt that autofluorescence gives you the physiological health of the RP, and that is the investigation to go for. When you want to localize the leak, it's only fluorescein plus or minus ICG angiography that will give you leak localization. So in chronic CSR and recurrent CSR, I would want to go for an angiogram. And in chronic CSR cases where you want to identify the presence of complications, then OCTA combined with OCT gives you a complete picture of whether there is a CNVM or not. For documentation at any stage of the disease, whether it is acute, recurrent, chronic, or treated CSR, a color fundus photograph and OCT usually suffices. So this is the basic chart which I usually follow when I think of what investigation to order for my CSR patient. And this helps me tailor the investigation pattern for a CSR patient. Thank you.
Thank you, Dr. Abhishek, for that excellent talk. Can I just ask you a quick question, please?
Sure, sir, please.
Dr. Abhishek, I mean, now that we have this newer, we have this newer classification of CSR, and this seems to be very heavy on multimodal imaging. So in that context, when you say acute CSR, now you need to OCT seems to be the most important investigation according to your presentation. So in this context, the newer classification coming up, don't you think that we may have to? How do we know? Sometimes it's possible that for me, what is acute may not be really acute because this patient probably had some pre-existing disease, and now it appears for the first time a patient coming to me, and it appears like an acute CSR to me. So to understand that, don't you think that multimodal imaging would help to understand that there has been some process before?
Right. So quite correctly pointed out, sir, that sometimes what you may, I mean, from the history, it is not always obvious. But then most of the times when you do a clinical examination, the presence of RP defect, the presence of pigment, the presence of subretinal gliosis would point out, and especially the other eye findings would point out to you whether this gentleman has a simple first episode of a CSR or there is something else involved. So you can tailor your investigations. There is no harm in doing a multimodal, imaging. If you go through the whole gamut of investigations, there's no harm. You will definitely sometimes get some certain information that you may not have found. But then, if a patient is under follow-up, CSR is not something which goes bad all of a sudden. So you always have, the next visit to analyze what is happening and then go for investigation rather than ordering the whole area of investigation the first go. Also, a lot of us may not have access to all the investigations. So what I tried to present was, how do you optimize it so it is both economically feasible for the patient, and sometimes in an acute CSR you really don't need to do anything except monitoring. As we all know that almost 60 to 70% of CSR disappears without any thing much that you need to do. So there, I would probably limit in the multimodal imaging package. Also, I will go for certain investigations only, not all of them at the very beginning.
Okay, Dr. Abhishek, that's a point well taken. And then just one more last question before we get into the next talk. Do you have any experience with multicolor imaging? Does that add more, multicolor photography? Does it add more information than the traditional clinical photographs?
Yes, definitely. In a multicolor imaging, though it is a pseudo color and basically sometimes a false color representation in the SLO photography, you sometimes appreciate the fluid and the RP changes better than you would on a standard NFAS camera-based photograph. Certain especially the RP changes are very obvious, or rather I would say pronounced by what the software, and you can see it a little better. Definitely. And for the same purpose, I think if you ask me, even better than the color fundus photograph is the red free. The red free identifies the boundaries of the fluid bulla much better than routine color fundus photograph does.
Thank you, Dr. Abhishek.
Manoj, if I may, my query as a pure anterior segment surgeon to you all, retinal surgeons, are you is there any change in the age at which you're seeing CSR now when compared to maybe 5 or 10 years, or are you seeing more CSR now these days? Any comment on that?
So very, very nice question. And I think it's my mistake that I actually, in the answer to Dr. Manoj's question, I did not say this. When you choose an investigation, an age at presentation is also quite important. In an older individual presenting like a CSR, we may want to investigate a little more than we would want to in a younger patient. As regards to your question, whether we are seeing CSR coming in a different age group or a little later on, I really have not noticed that too much in my area, but I don't know what is the situation in Kerala. We still see maximum CSR in younger individuals or early middle-aged individuals, not usually in older individuals.
I think the same is the experience with us also. I don't think there's been a major shift in the number of patients that we see in terms of age. It's almost the same we see predominantly, but at least now that we have all this multimodal imaging, we would investigate an older patient more vigorously, as Dr. Abhishek clearly pointed out, to look for some other etiology. Mimics or some other atypical form of CSR than typical. But otherwise, I understand, in spite of all this, all the current pressures in life and all that, the incidence of CSRs, I don't think there's a major change that we see, in my practice area.
I think one thing I've noticed is, many a time when you say CSR, you just mean there is a patient coming with a central serous macular detachment. See, many of these patients may not have an obvious CNVM. If you look at the, FIPED area, there'll be an opaque FIPED only. And you will not see an actual CNVM membrane. So many of these patients in the older group who come with just subretinal fluid and opaque FIPED, they usually have a CNVM rather than a CSR. Probably they were having CSR for a long time and they've developed secondary CNVM, as a result of which, they have developed SRF. So I think that is one group of patients where we mistake them for CSR in the older age group, even though there is no presence of obvious CNVM membrane. And in such cases, I think Octa is the gold standard. Because many of these patients, even if you do FFA ICG, you just see occult leaks and you're not very sure whether it's because of CSR or CNVM. And when you do an Octa, it beautifully demonstrates the CNVM membrane. And these are patients who need anti-VEGF therapy. And many of these patients are labeled as chronic CSR and they keep on getting medicines and they never get into this anti-VEGF mode. And if you give an anti-VEGF, many of these patients, the lesions get resolved also.
So I think the take-home message here is that whenever we see a typical CSR, we know that the natural history of CSRs is that they kind of resolve or a period of 3 months or not beyond that. When you have something which is extending beyond 3 to 6 months, then it's time for us to reinvestigate these patients, try and find out if we are missing. So I think there the role of multi-modal imaging comes in. And that's when we would try to call it a chronic CSR and recurrent CSR, and such patients need more investigation. Otherwise, most of the patients, natural course, they do well. They do not need multiple investigations, and OCT evaluation is enough. We need to rule out whether the patients are on some drugs like steroids and agents to understand. So these patients may require earlier intervention. They may tend to become more chronic, and therefore we need to understand that group of patients. I think with this,
if I may add just a last comment, or rather a question to you. The older teaching in the textbooks used to be that we consider a CSR chronic or non-resolving only after 6 months. Has that changed in your practice? Do you now treat it a little earlier, or you still follow the 6-month rule?
No, and I wouldn't go by this duration. At least in our practice, we actually we will try to get a baseline FAF in most of these patients, because I've realized that I miss a lot of these chronic patients. I would diagnose them in the busy practice. You would diagnose them as just acute, and then just send them off, and then you see later that they have persistent disease. So what I do right now is try and do a baseline FAF, autofluorescence, in these patients, and try to understand if they have got more RP damage than what is clinically obvious. And if that is so, then if there is a patient with extensive RP damage, then I would call the patient straight away chronic, even though it's like an acute on chronic. So I think that is how I look at it. So the definition of chronic is still, I think there's no consensus on that. The newer classification has done away with this term chronic. They have not called it chronic, they have called it complex. So that is adding more confusion to the terminology. So I think looking at the RP would give us a good guide as to how much of extensive disease the patient has got.
I think now the term is persistent, more than 4 months instead of chronic, which is kind of similar to a chronic CSR. And as Dr. Manoj said, this is the outer retinal changes and follow up. What is the vision? Whether the vision is deteriorating, how the patient is doing, that determines whether you have to intervene or not. I don't think that typical time, 4 months or 6 months, that really matters.
Okay.
So now we come to the end of the first talk. Now I thank you, Dr. Abhishek. Now I call Dr. Sunil Ganekal, sir. Welcome, sir, to the session.
Yes. Am I audible? Yeah.
Yes, sir. You're audible.
Let me share my screen. Yeah, my screen is visible.
Yes, Dr. Sunil. Yeah.
Good morning, everyone. Let me talk to you regarding the treatment of CSCR. When you see a patient with CSR, one thing is couple of things you should look into is one is the disease duration, which may you get it from the history, how long the disease may be persisting. Ask for any history of similar reports, episodes which gives a clue to whether the history is the disease process is recurrent. Look at whether the disease is unilateral or bilateral. Ask for any associated systemic diseases. For example, the patient may be having an asthma, arthritis, or some autoimmune disorders, which patient may be on treatment. So ask for an history of previous drug history and the previous any treatment history. And ask for any history of intraocular surgery also. There are various definitions, which classical definition based on some of them are based on the duration, but the most relevant for the treatment purposes would be chronic, the recurrent, as Ashok rightly pointed out, persistent CSR, which is very relevant, where non-resolving SRF persists for more than 4 months without any previous treatment. Sometimes if the persistent CSR persists for too long, can lead to the RP atrophy and leads to the inferior gravitational tracts. So these are the things which helps you to plan your treatment accordingly based on the duration and the duration of the disease. You can plan it. So the most important question is now why we should treat the CSR. One is as we know that the recurrence occurs almost to 20 to 50% of the patients within the first 1 year of the disease process. And as we know that the chronic neurosensory detachment or presence of SRF can damage the RPE as well as the photoreceptors. So the visual function may be compromised. So you need to treat that. There are certain diseases which mimics like CSR. As we know that now the CSR is a part of the pachychoroid spectrum. Yeah, in old age patients, AMD can mimic the inflammatory disorders, which the Divyanshu will be covering in his topic. There are certain mimickers, the optic disc anomalies, posterior scleritis, certain cases like the drugs, which are some patients may have an MEK associated retinopathy, which is shown in the picture here. If so, the drug history sometimes gives a clue to whether the patient has got a CSR, SME, or any other diseases which mix like a CSR. The first and foremost thing when one should do in treating a CSR is remove the risk factors which are associated with the CSR. For example, if the patient is on any form of steroids, please ask them to stop it. Ask them for lifestyle modification to avoid stress and other things. If the patient has got an obstructive sleep apnea, try to take a physician evaluation and try to treat that. Manage associated risk factors like hypertension. There has been an association of H. pylori infection. Even a patient to rule out whether the patient has got a Cushing syndrome, which has got an endogenous steroid overload. In atypical cases, kindly rule out the tuberculosis also. So the goal of any treatment, Abhishek also has highlighted in his imaging talk. The one is we need to improve the visual acuity. The retinal sensitivity needs to improve. You should need to get rid of the symptoms of the patient, which are basically the scotoma and the metaphormopsia, which are associated with this, and aim for the resolution of the SRF for the PEDs. Since, as we all know, that it's a more of a choroidal pathology, the treatment should be aimed at reduction of the choroidal thickness also, and basically to reduce the complications which are associated with this. Some of the red flag signs which indicate that the patient may land up with a chronicity in if a patient sees the CSR. One is if a patient present in the older age, that's more than 40 years of age, if the subfoveal choroidal thickness is more than 500 microns, PED height is more than 50 microns, shallow irregular PED with the disruption of the outer retinal layers, photoreceptor atrophy, and the presence of hyperreflective dots, some of the signs which indicates that the patient may end up with a chronicity. These are not a good prognostic factors. So when do you observe and when do you treat? Usually acute CSR is a self-limiting, so you can wait up to 3 to 4 months in most of the cases, but make sure that you need to closely follow up these patients because some of the acute CSR patients may have a fibrin and have a visual compromise. So active treatment should be considered when the symptoms persist more than 3 months, where the rapid recovery of vision required. For suppose some patients has got a professional demands which needs an early treatment, has to be treated. Sometimes the patient had a bad treatment history in the other eye and has lost vision due to CSR in the other eye, then you need to treat them early. So what are the treatment options available for CSR? The first and foremost is a laser photocoagulation. There are two sorts of laser we tend to use. One is the conventional organ laser photocoagulation. Other is a modified subthreshold or a micropulse laser. The next modality of treatment I'll be discussing is a transpupillary thermotherapy, PDT, anti-VEGFs, oral medications, and some of the rare treatments I'll be covering in the subsequent slides. Coming on to the conventional laser photocoagulation, when you tend to do it is when the CSR has got a discrete, solitary, or multiple extrafoveal leaks with persistent leakage, then you tend to do an organ laser photocoagulation. The mechanism of laser is simple. It acts by thermal sealing effect on the RPE defects. It stimulates the surrounding RPE cells and ascends the resolution of neurosensory detachment. But laser rarely alters the final visual outcome or rate recurrences. So you should choose the cases accordingly while treating with laser. But if you do inadvertent laser, sometimes patients can have a permanent scotoma, enlargement of the scars, rarely CNVM, and someone can cause a foveal burn if care is not taken. The recently navigated laser has improved the results and the safety margins have increased after the introduction of navigated laser. So the study by Teblani et al. Has shown that navigated laser works very well in CSR with a complete resolution is almost 75 to 90% of the patient. If you look at the another study where they combined the organ laser with no treatment, they found no difference with respect to the recurrence rate, visual acuity, and the contrast sensitivity with the patients who treated with laser photocoagulation. Photocoagulation treat to see the one thing is the basic pathology as we discussed is more of a choroidal pathology. The laser tends to act at the level of the RPE. Whether how much is the modifications in the choroidal changes which occurs post laser needs to be looked into. Another modification which can be done to avoid some of the complications of the conventional laser is using a subthreshold or a micropulse laser. Various wavelengths have been used starting with 810 nanometer diode laser, yellow lasers, 577, 532 and 527. So various wavelengths of the laser can be used for subthreshold. Here you can adjust the duty cycle, the power, spot size, and the pulse duration. Basically here Here is a patient who underwent a subthreshold laser. You can see the complete resolution. This is a conventional laser. This is a pulse laser, so that you will have on and off time for the laser treatment. The purpose here is to treat the RP and choroid without any visible burns, clinically visible burns. There will be reduced risk of structural and functional retinal damage when compared to the conventional laser. The most effective in CSR with focal leakage, this works very well when compared to patients with a diffuse leakage. Another modification is using a diode laser, which can be considered an alternative to PDT. Sometimes is effective in, it's a cost-effective thing, can be planned in chronic CSER, where you tend to use 8-10 nanometer long, low energy, long pulse laser. Initially start with a 40% threshold of the extramacular test burn, and gradually, if there is no response by 4 to 6 weeks, you can increase the power of the threshold, the test burns by 20%. And the results are almost as comparable as the off-fluence PDT. Studies have shown that by around 6 to 7 weeks, the complete resolution is seen in 75 to 80% of the patients. Here is a patient, the study which shows that the subthreshold micropulse yellow laser works very well in CSR patients. The next and the important treatment is the photodynamic therapy. The various modifications has been done in the standard or the conventional photodynamic therapy also. The one is the standard, other is off dose, and the next is the off fluence. I'll be discussing one by one. So when you would like to do a PDT is when there is a non-resolving or a persistent CSR for more than 4 to 6 months. Subfoveal leaks or a juxtafoveal leaks, one can consider this. If the CSR is recurrent, you can use it. When there is an obvious hyperpermeability and you know that you have already tried out some of the medical line of treatment like MRA, that is mineral receptor antagonists and other drugs which have been tried out, if there is no response, you can consider the PDT. Mechanism of action, basically it acts on the choriocapillaries, decreases the perfusion of the choroid, and as well as brings about the vascular remodeling of the choroid. But one should be very cautious when you're using a PDT when the visual acuity is very good. Sometimes when there is an associated fibrin or intense protein exudation, one should be very careful with the conventional or a standard dose PDT. The PDT spot size you can decide based on the hyperfluorescence, area of the hyperfluorescence seen in the mid phase of the ICG. Success of the PDT basically depend upon the degree of hyperpermeability on ICG. You can do an ICG, both ICG guided as well as FA guided PDT. But conventional PDT sometimes can cause RP atrophy, choriocapillary ischemia, and rarely can cause a CMEs. So to avoid these complications, we thought of shifting over to either off dose, off fluence, and off time to avoid these complications. Sometimes post PDT, you should counsel the patient there could be an abrupt decrease in the visual acuity, which could be due to the reattachment of the photoreceptors, or sometimes a temporary increase in SRF as well as the increase in the choroid. So the transient decrease in vision should be explained to the patients and should be counseled accordingly. And preferably the changes in choroidal thickness and SRF height usually typically stabilizes by 1 month post PDT. So what are the poor prognostic factors, or the where we say that the PDT may be ineffective or the chances of high recurrence is there? Whenever a patient is present with a poor baseline visual acuity, absence of an intense hyperfluorescence in ICG, shallow irregular PEDs on OCT, there is an entity which has been described in a chronic CSR which is known as PCRD, that is posterior cystoid retinal degeneration. If one tend to see that, then there is a response to PDT is very poor. Outer retinal changes like disruption of the EZ and choriocapillary ischemia. If you see any of these things, you can tell that there is a less chance of PDT being successful in these patients. As I described, this is an entity that is a posterior cystoid retinal degeneration patient. It is a patient who underwent this mimics like a CME, but there won't be any leakage. This patient underwent a PDT but recovered well, but you can see after 10 months there is a gross recurrence after the 10 months of the half dose PDT. So this entity has to be ruled out in a chronic CSR when you consider a PDT option. So other thing is you can repeat a PDT, but the success of a repeat PDT is questionable sometimes, and you need to monitor the patients every 3 months to look for the response. The off dose, definitely you can consider to avoid the complication. You can use a 3 milligram per meter square instead of these things. There was another study which compared off dose with the 30 dose. Even though the response got with both the dosage, 1/3 dose of PDT had a higher recurrence rate when compared to the off dose. Interestingly, the rate of recurrence after off dose PDT is higher among the patients with bilateral CSR when compared to the unilateral CSR. The next another modification you can do in safety enhanced PDT is a reduced fluency. Using an off fluency of 25 joules per centimeter square, the studies have shown they are comparable with the standard PDT at 12 months. Off dose PDT less likely to cause retinal atrophy when compared to the off fluence PDT. More recurrences are seen with off fluence PDT than off dose PDT. There is another study which shows that the yellow micropulse laser can be an alternative to the half-dose PDT. This is another place trial where half-dose PDT was shown to be superior to the high-density submacular threshold razor in chronic CSR. This is another important study. Suppose you want to do a crossover treatment or a sequential treatment. Suppose patient has undergone a half-dose PDT after a previous unsuccessful submacular threshold razor, it works well. But if you look at the other way around, if patient has undergone an earlier this thing and you do an half-dose PDT later, the chances of success rate is less. So sequential treatment should be planned accordingly. So suppose if somebody has got the poor response to PDT, the response to other modalities may not be as great as shown by this replace trial. Anti-VEGF definitely has got its specific indications like subfoveal fibrin, in which the focal laser or PDT is inconvenient. One can use this, or when the CSR is complicated by CNVM, you can use this as the changes in choroidal thickness are also seen after anti-VEGF treatment. You can see the pre-treatment and post-treatment, there is a significant reduction in choroidal thickness also. Hypertension and a thinner choroid thickness are important factors which shows that there could be a poor response to anti-VEGF indications. As already discussed about the CNVM, the most often it is a type 1 CNVM which will be associated with this. The one should suspect when there is a 5-ped or on an octa, you can see a choroidal neovascular network. And 2/3 of the patients with CSC with CNVM will have a polypoidal component. So ICG is a very important investigation. And sometimes the CSC with CNVM or CSR with CNVM, anti-VEGF has to be supplemented with PDT. So the various studies have shown variable response to treatment. Some studies have gone up to the treatment of saying that even the extended anti-VEGF therapy of almost up to 6 injections have to be required in patients with but a variable response occurs, but one need to rule out a CNVM before injecting a thing. And this is a study which shows the role of bevacizumab. They've found a good result, but almost a 50% recurrence chance with this treatment with bevacizumab alone in chronic CSR. The another treatment is a transpupillary thermotherapy. Here you tend to do a 8-10 nanometer laser. The study has shown that almost 96% of the treatment eyes had a complete resolution at 3 months. The visual acuity improved in 92% of the cases. Like modifications of PDT, you can do a modifications of the TTT also, like a subthreshold TTT. We initially use a 60% of threshold power and then increase it to 80%. This is by George's paper, which indicates almost 80% at a complete resolution. So side effects sometimes can occur due to TTT also. Sometimes macular infarctions and RP atrophy have been, you should look into it. Other thing is compared to PDT, these TTT patients requires longer intervals and repeated sessions when compared to the PDT. These are the patients who had a successful treatment secondary to transpupillary thermotherapy. So when to consider oral medications in a CSR, one is when there is a chronic and a persistent CSR. The drug of choice, first one should consider is a MRA, that is a mineralocorticoid receptor antagonist. And the drugs which have been tried out are either ketoconazole, mifepristone, rifampicin, finasteride, spironolactone, eplerenone. So the most commonly used drug is eplerenone, but it needs a certain chronic therapy for the beneficial effect. Patients with widespread RP damage may not respond so well to that. But studies have shown up by 3 months, the most of the CMT and SRF reduces. But another large prospective randomized trial, there is a VC trial which compared eplerenone with placebo, shows that eplerenone clinical efficacy in chronic CSR was not superior to placebo. So one need to take it with a pinch of salt, when to use it and how long to use it. The other drug which has been compared on head-to-head is the spironolactone with eplerenone. Even though spironolactone efficacy is 40 times more than the eplerenone, but the thing is there has got a lot of side effects. So people tend to shift it towards the more eplerenone than the spironolactone. Both drugs had a similar outcomes in absorption of SRF. Because of the side effects, one tend to look at the other things. Most of these drugs, either eplerenone or spironolactone, tend to increase the serum potassium levels. So one need to look into the renal function tests as well as the potassium levels before starting the patient on these drugs. The ideal dosage is around 25 to 75 milligrams. If the potassium levels is more than 5 millimoles per liter, then reduce the dosage. For stopping, you have to gradually in a graded manner, you have to reduce the dosage to get an optimum efficacy. The recurrence can occur if treatment is stopped abruptly. In chronic cases, the treatment should be kept for years. In cases of pregnancy, it should be stopped. It can be also used in children. This is another study, the case report which has been published in the IJO, where it shows that eplerenone given for a longer duration of time in a patient with an exudative RD with a large macro RP, there is almost a complete resolution of the PED as well as the SRF, and scarring process also was very well, and there is a continuity of the RP which noted. So some atypical cases also, chronic therapy of oral medication helps. Oral ketoconazole, another drug which has been tried out, especially is a patient with obstructive sleep apnea, treated with oral ketoconazole 400 milligram per day. You can see the excellent response of over a period of 6 weeks. Topical carbonic anhydrase like oral, you can try it out, but leads a long-term therapy. But these are all should be considered as a second line of therapy rather than the primary line of treatment. Various other drugs which have been tried, aspirin, beta blockers, treating an H. pylori infection, methotrexate. The rifampicin should be used with a pinch of salt because there is always in India, there is a concern of multi-drug resistant tuberculosis in these patients. So before starting a rifampicin, one should be very careful and take care of this aspect. Another rare modality of treatment which has been published is you can use an episcleral brachytherapy, but you need to titrate the dose of this radiation which you give because it can damage the choriocapillaries, can worsen the disease process. These should be used in only in refractory cases than in the primary treatment. Surgical options, definitely yes. Things like scleral thinning surgeries or scleral resections have been tried out in chronic CSRs, especially associated with exudative RDs. You can see the post-scleral resection, there is a complete resection resolution of exudative RD has been noted. External drainage, definitely an option in a chronic persistent exudative detachments in a chronic CSR. One can think of an external scleral drainage also. So in conclusion, the gold standard of care for CSR is to be defined. Choose treatment option based on the duration of treatment, the photoreceptor changes, presence of fibrin, and the presence of location sites. The PDT offers good results. One can consider off-dose, off-fluency when compared to the standard PDT. Supplementation with MRA drugs and subthreshold macular laser is beneficial. Choose anti-VEGF wisely. Sometimes you may miss the CNVM in many of the cases of chronic CSE. So anti-VEGF does have a role in chronic CSE. Surgical options should be considered in atypical, chronic, and non-responding cases to get a better outcome. Thank you. Thank you for your patient hearing.
Thank you, Dr. Sunil, for that very elaborate presentation. I think you've covered everything about treatment from A to Z. So, I think I'll just leave with one quick question to you, Dr. Sunil. So, when you see a patient with CSR, do you always, say initially when they come to you, you need to offer them something. You know that they're acute and then they're going to self-resolve and all that. But do you actually put them on something? You need to put them on something. Do you put them on a topical? I know there are people who put them on topical NSAIDs. Or what do you really give these patients when you see them first?
Placebo, definitely yes in some of the patients, but I try to avoid giving any treatment. Counsel the patient that is self-resolving and wait for it, and advise for a modifications of a lifestyle rather than anything else. But placebos definitely yes. But how far they work in improving the disease process, I'm not sure.
I think these are patients now who are like very stressed and people and who when they come to you with this problem and then you tell them, you make light of their situation. Now you tell them, this is my experience. You tell them that no, you're okay. I mean, we keep seeing this. It'll go away in 3 months. He is not happy. He's not happy because he's already stressed with this problem, and then he is so you give him some placebo. I think the placebo effect actually helps in these patients. Is what I think. I mean, what I do in my practice is to give them actually dorzolamide. I give them, I know MPSR. Divyansh can actually throw some light on it. MPSR gives topical dorzolamide. So I actually give them these days. Topical dorzolamide, and definitely if I think that they are kind of stressed, I put them on a small anxiolytic, and then call them after say 3 or 4 weeks to see.
Definitely worth trying it. There's no harm.
Sunil, Manoj, this is where the Ayurveda physicians score over us. See, we tell okay, everything is fine. You just leave them. See, they're going to. We know that they're going to get better. But if you give some drops or some placebo, as Manoj says, they know that we are actively intervening there, and you're telling, okay, you take this, it's going to get fine. So psychologically, they know that you are actively trying to. You know that you're not. Maybe Divyansh can add on to it. The medications that you people are doing in Shankara.
Yeah, thanks, Manoj sir. And so I just wanted to give a different perspective. Sir has included so many things I do not deny. So we have completely changed our practice in Shankara right now after reading one of the papers from AIMS. So our sir is suggesting they have utilized yoga therapy in that. So in that yoga therapy, it's a like meticulous yoga therapy for a month, and they have shown that the choroidal thickness decreases by 100 microns, and the CMT and the SRF is in 94% cases or so they have resolved. So we ourselves are conducting a small study, which it has been just started, I think 6 months back. The recruitment is not too good because when we try them to go for a yoga, they tell, okay, why we have one issue and then we are asking us to join a yoga. But then what the patients, whoever are joined in that therapy, we have seen that the response is very good, and the recurrences, as we know, the recurrence of CSR is the main cause. So once they come with one attack, there are recurrences. So what we are seeing that the recurrences are also much lesser. And as Sir was suggesting, yeah, probably before this, probably last year, we were treating either with DOSDox or an NSAID. But right now, Sir and most of us are probably trying them to push to this non-conventional treatment, and we are finding good results in that.
Yeah, don't tell me you have a yoga center in Shankara. You ask people to come. You can do that. I mean, you still
So
keep.
we are trying to, yeah. So we have.
One question. Yeah, one question. Like, we find that hypothyroidism is very, very commonly associated with CSR. It's something very, very underreported because majority of the patients of CSR, I mean, do you have any experience where we have treated hypothyroidism and their CSR goes off,
No, sir, we don't have. Sorry, sir.
No, personally, I'm, though it is reported in literature, I cannot recollect any patient where I have realized that there was a significant change. Maybe it has a role. I'm not sure.
If I have to rephrase what Dr. Sreeni sir was saying, that a disease that has a good natural history and has a very high rate of resolving by its own, when you give something, you're seen, you will take the credit. If you let nature take the credit, you will actually be discredited for doing nothing.
Yeah, exactly.
So you may as well give something and take credit for what is going to happen anyways.
And the other situation, sometimes you're following up a patient, an acute CSA, just following up, and over you call the patient after a month, and then you see that the SRF has gone up. His visual acuities are almost the same. This visual acuity does not correlate exactly to the fluid, and the fluid is going up, and the visual acuities are the same. Now, what do? It is an acute CSR. The fluid seems to be increased on the OCT. Because now we rely on OCT heavily. We tell the patient, show the patient, tell him a value. You tell him that now it's 350 microns. The next time he'll remember the value. The next time he comes to you, say, I want to know what the value is. And now if it is 400, now you are in a fix. You have to decide what to do next.
Why do you tell it in the first place?
No, generally, when we explain, we tell them that, okay, the normal is like 250 to 300, and now you have a fluid. And this is the measurement. And these people, they're very highly stressed people. They make a note of all these small things. And this, from my experience, they keep a note of these things. They'll definitely come and ask you next time, okay, what is the value now? And now, if the value is more, but the visual acuity is the same, then what do you do about these patients?
I think, we should go for investigation. At least a baseline FFA at that point of time we should do. It'll serve two factors.
I think FFA, I would defer here, boss, because I think FFA will only serve a purpose if you are planning to treat. Now, to answer Dr. Manoj's question, if there is a patient who comes, say, 350 in the first visit and 400 in the next visit with the same visual acuity, I would definitely give the option to the patient whether he would like to wait a little more or we want to. Now, especially in the case that you described, if there is a 50 micron increase in the SRF, I would definitely, if he asks my opinion, I will tell him that since it is not really started to reduce, say maybe you would call him after a month, then I would lean in favor of treating, and then maybe, go for a FFA and a laser if the patient accepts that he's going to get a laser. Otherwise, just doing the FFA, yes, it may show you leaks, it may show you something which you are not going to do anything about. So Whether to go for treatment or not is the treatment is the decision that the patient will make depending upon what you counsel him. So once that decision is made, then the further investigations, especially the invasive investigations like FFA or ICG, should follow that. Because if the treatment decision of doing laser or not is already taken, that the patient wants to observe, then doing an FFA does not add anything much to either your understanding of the disease or to the treatment of the patient.
On the other hand, Dr. Abhishek, what I thought was like what I would do is I might consider FFA in certain situations, but my thought process would be that so this is the patient's CSR. He should have done well with the conservative management and acute CSR. Now he's not doing well, so there is something which I have not picked up. Something that that I have not identified. Is there a mimic or is there something else that I have failed to understand? And that is when I would look at the OCT again carefully. But we know that Octa may not give us much information, especially in a CSR with all the segmentation problems. And therefore, I would sometimes consider in certain situations, I would consider, so for example, if it is a one-eyed patient.
One-eyed patient, older age group. I mean, these are patients who definitely we will consider investigating thoroughly.
Yeah. Okay.
Manoj, I think we'll move to Divyan's presentation.
Or we'll just move on to the last talk.
Now I welcome Dr. Divyansh Mishra. Welcome, sir, to the CME. On to you to talk regarding the CSR limits.
You're muted, Dr. Divyansh, you're muted.
So yeah, good morning everyone, and thank you Manoj sir and thank you Srini sir, and thanks Kerala Ophthalmic Society and Trivandrum Ophthalmic Club for this opportunity. So a very near and dear topic of CSR and mimics. So coming to more commoner ones, so as you were discussing, if we see a case of a lesion at the fovea, the most important thing we need to think that whether it has any associations. As in this case, we can see there are some associations like hemorrhage or some yellowish color material, and when we see an OCT we need to correlate that what that yellowish color material may be. So in this case, if you have an OCTA, we can easily pick up a neovascular network and we can identify an idiopathic CNV, and the treatment would continue depending upon that. In certain cases, like as you were discussing, where we see a case where clinically the foveal reflex is dull, and there are some yellowish lesions at the fovea. The age is borderline around 48, 50. In these cases, OCT is there to help us. And if we see this FIPET or a fibrovascular PED, which we are seeing, most importantly, we can see that the PED is having a stepladder kind of a pattern. There is some kind of a double layer sign. So OCT is again here to help us. And we can see that the SRF is also there. So it is directing towards having some kind of a network. And depending upon the network, then the treatment can be managed. Certain cases, the diagnosis is very obvious when we see the fundus photograph or either in the clinical examination. As in this case, we can see there is a hyperreflective pigmented material at the site of the fovea, and there is one blood vessel which is entering inside. So what is it suggestive of? It can go in favor of something which is called as a type 3 CNVM, where we can see that the lesion may enter from the retina or either from the choroid into the retina, and it can have a PED or an intraretinal fluid and a subretinal fluid, and there would be an area where we would see that the migration of the intraretinal segment into the subretinal segment. And as in cases of FFA and ICG would be helpful in such cases to give us a better understanding, as we can see that this blood vessel is dipping inside, and we can see the choroidal network also with the retinal communication. And Octa, this is a different segmentation where we have used a pan segmentation from the superior till the choroidal phase, where we can see the blood vessel entering into and then forming a choroidal network. In certain cases, we may see that the hard exudates would be there close to the macula. So again, these are little telltale signs that this is not towards CSR. So not all fluid is what the CSR would be. If we see any kind of a strength, there can be sometimes a long-standing CSR can produce something which is called as fibrin. So in this case, most important is again something which is called as a pearl sign, where we can see into the PED that there are some roundish lesions in the PED. And if we have an OCTA, it helps us to identify the lesion. As in this case, we can see the lesion or the polyps have migrated into the subretinal cavity, and we can see the flow signal above the PED, which is in the outer retinal slab. FFA ICG would give us a furthermore better understanding in such cases. Certain cases you would see that the fluid is there, but clinically there is no signs at all. So as in this, if a clinical examination is done of this patient, there is no drusen, and clinically it just looks like there is a dull foveal reflex. So if we see this case, the OCT again helps us to identify better signs. As we can see, stepladder PED, a tall peak PED with a pearl sign, where we can see some kind of an hyperreflectivity within the PED, very highly suggestive of polyp. And in this cases, the ICG would give us a better understanding to come to a treatment and conclusion. Certain very rare cases, what we can have is cases which are having angioid streaks. If they have pseudoxanthoma elasticum or other associated conditions, they may have this angioid streaks where there is already a break in the Bruch's membrane. So that Bruch's membrane can have a formation of a neovascular network, and that needs to be treated. So this is one of the mimic which is would be very helpful to identify and manage having an OCT association. As you can see, this is something which is called as an FCE, or focal choroidal excavation. So again, the examination would give you some yellowish color lesion which is there at the macula, the paramacular area. When we pass the OCT, this is the first OCT at the presentation which is called as a conforming FCE, where we can see the retinal layers into the FCE, or the focal choroidal excavation. But over years, probably 5 years later, the patient presented with a fluid at that point. So whether this is a CSC, probably an FFA or an ICG would be a better understanding, because we have to always rule out a neovascularization at the base of this. You can have very, very minor or very subtle fluid in this FCEs. Again, clinical examination would give you a just minimal understanding, but multimodal imaging like OCT and Opta would give you a better understanding out of it. As in this case, we can see the similar yellow kind of lesion when we clinically see OCT showing there is some kind of a conforming FCE, but there is a most important finding which is called as SHREM, a subretinal hyperreflective material. So when we do a multimodal imaging, either in FFA or FFA ICG, we can see that it is showing that there is some kind of an leakage in that FCE. And the Opta is also showing that there is a flow signal within that. It's not very well picked up in the choriocapillary slab, but probably in the deep retinal slab, we see some kind of a network. Most important differential, right now, the terminologies are interchanging or probably dynamically changing, as we are seeing that CSC and peripapillary pachychoroid are two different spectrum, but yes, you can see the similar spectrum if the patient is of a little older age. So this patient is around 45, 50 years of age, where we can see autofluorescence, which is having geographic atrophy and heterogeneous hyporeflectivity and hyperreflectivity. Such cases, if you do an OCT, it gives you a very good understanding that what kind of problem it is. So in peripapillary pachychoroid, you would see more amount of intraretinal fluid, which is less common in cases of CSR. As we can see, the intraretinal fluid starts very close to the peripapillary area. In this case also we can see, and there is dilated choroidal vessels, which are more common towards the macular area or the nasal area rather than temporal. If we pass an OCT at the disc, you may see the fluid is on the nasal side also. So as we can see, an FFA is showing a window defect, multiple areas, certain areas of very ill-defined leakages and disc staining. So this is one of the important signs of peripapillary pachychoroid. ICG shows an hyperpermeable choroid, dilated choroidal vessels, and more towards the macular or the nasal area is what the diagnosis of peripapillary pachychoroid is. So some differentiating points as we are into the lecture where we are understanding the mimics of CSC. The most important is choroidal folds, a little older age, and a smaller cup disc ratio, and there would be a leakage from the disc as we are seeing. There is no leakage from the disc in cases of CSC. Younger age and choroidal folds are less common in CSC. So this is a comparative image where we can understand how a peripapillary pachychoroid case would look as and how a CSC case. As you can see, the CSC, the whole choroid is thickened. There can be dilated choroidal vessels. there may be focal leakages, and there can be subretinal fluid. But in peripapillary pachychoroid, as we were discussing, more important is intraretinal fluid, loss of outer layer, and more dilated choroid in the peripapillary or the macular area. Very important differential other than CSC is something which is called a DSM, or a dome-shaped maculopathy. So how do you identify a dome? As you can see, if you pass a scan horizontally, sometimes you may miss the dome. So you need to do a vertical scan where you may see that the central retinal area is elevated, where the choroid is much more thicker as compared to the other areas. And there you may see some kind of an SRF. In certain cases, this may also develop some kind of a neovasculopathy. So in this case, as we are seeing, there are small polyps associated with it and dilated choroidal vessels, which are more in the macular area. Most of the DSM cases don't respond very well to most of the treatment what we have right now. PDT is one of the plan of management, but lack of availability is an issue in that. So if a case comes to you like this, where there are multiple yellowish dots in the retina, autofluorescence is of the best help. As you can see, autofluorescence gives a starry kind of an appearance. This is a very, very typical of something which is called as autosomal recessive bestrophinopathy, sorry. And OCT gives you not a very clear picture, but the autofluorescence is the clinching at this point, we can see. So OCT would show you dilated or thickened outer retinal layers or photoreceptors, and there can be some hyperreflective deposits, SRF. So this is not CSR. How, as we saw, autofluorescence would help you. So multimodal imaging in cases of a case where it doesn't clearly fit all criteria of CSC, or it gives some red flags, should be done. As in this case, again, the best disease can present at various presentations, either vitelliform, pre-vitelliform, or vitello-eruptive, and sometimes in the scariform. So in this case, as you can see, it is somewhere in the vitello-eruptive stage where we can see that autofluorescence is again helping in this patient. Actually, the patient was suggested that he was having a CSR, then he came for the second opinion. Just the autofluorescence gives us very nice understanding. In one of the eye, we can see some kind of a pseudo hypopion, inverse hypopion also. So autofluorescence in such cases are very helpful. OCT is not very clearly diagnostic or understandable, but as you can see that autofluorescence was very helpful. So if we just see the OCT, we may miss out on it. So autofluorescence was of a great help in such case. And we can see that in OCT, you may see, okay, there is an SRF and the outer retinal layers are thickened. It looks like CSR, but autofluorescence was a clinching at this point. It can also present in this vitello-eruptive stage, but in this case, the patient has also developed something which is called as neovascularization. So in this case, he presented with some kind of a minimal SRF with thickened outer segment and loss of outer segment in the. So we may think it's a chronic CSR. But as you can see, the autofluorescence is of help, where we can see the speckle kind of an hyperfluorescence and moth-eaten kind of an hyper and hypoautofluorescence. FFA gives us a small area of leakage in the center. And this is where the issue had started. So this is where the patient has had a Brooks membrane breach, where the patient had developed a CNV. So again, as we were discussing, a multimodal imaging in this case made us understand that the patient had a neovascular network where we had treated it. Adult onset adult onset vitelliform deposits are again one thing which is a different spectrum of West disease. We can see that when we clinically examine the patient, you may see some kind of a yellowish colored areas or lesions in the macular, submacular areas. Again, autofluorescence is of a great help. As we can see, the hyperautofluorescence at that areas, and OCT shows some kind of an SRF or a neosensory detachment, but this is not CSR. How, as we were discussing, most important is to look for multimodal imaging. In this case, autofluorescence, second is OCT, and we can see some kind of deposits in the subretinal area. Usually, this kind of deposits would not occur in an CSC, and Octa would give us an understanding whether we would want to do a FFA in this case to rule out if there is any CNVM network at that point. But the Octa would give us a big understanding. If it shows a good vascular signal within this SREM area, then we can consider it. Some kind of other differentials, if we treat the patient with laser, and if the laser is very close to the macula, as you can see here, we can see that the laser has come very close to the macula. And so that we can have this inflammatory response where we can see the laser has come up very close to the macula and caused a neurosensory detachment. And this after managing either with topical steroids or with NSAIDs, usually it responds very well. So acquired neurosensory detachments, which is one of the differentials of CSC, as we are seeing over here, this patient is having a coloboma of the disc. Along with that, there is a disc pit. So the patient can have neurosensory detachment. But yes, in such cases, whether to operate, not operate, treat or not to treat, if you are in a dilemma, because why the patient has directly developed a neurosensory detachment without any intraretinal fluid was a doubt. And that's why we did an FFA. As you can see, the FFA is not showing any leakage. So this is not actually a CSR. This is probably a traction associated disc papillopathy because of optic disc pit. Sometimes if we are concentrating only on the posterior pole, as you can see over here on the posterior pole, there is some fluid over here. So is this CSR? No, actually the lesion is far away. As you can see the fundus photo, if the scans are larger scans like a 12 by 12 mm, we can see that the periphery of the retina has some issues. And here we can see in the edge of one of the edge of the scans, we show that we are seeing that there is some subretinal hyperreflective material with some elevated area. So what is it? It is actually a peripheral PEHCR where the lesion was treated with anti-VEGF and focal TTT, transpupillary thermotherapy, and then the SRF resolved. So as you can see, so we should not only get constricted at the macula, what is happening if it's a CSC, we should try to see if there are lesions in the periphery. Inflammatory lesions are the other differentials, most important VKH, where you may have bilateral involvement, disc involvement may or may not be there, hemorrhages, sorry, bacillary layer detachment, subretinal fluid, choroidal folds, ILM folds. FFA would have us give us an understanding about whether it is any other type of inflammation or not. B scan would be again helpful in this case to understand whether there is a choroidal thickening. Some cases you may see that there is some kind of an SRF on the posterior pole, but anti-segment examination would give you a telltale sign. As in this case, we can see there can be congestion on the lateral or the temporal fornixes where we can see the congestion. And if you try to touch over there, they may have a little tenderness. Also, in such patients, we may see that there can be disc edema, hemorrhages, neurosensory detachment, and again, as we are seeing, choroidal folds. So this patient, FFA, as we can see, there are no other lesions except the disc leakage, what we are seeing, and choroidal folds in certain areas. And B scan is showing that the choroidal thickening is there, and certain areas there is suprachoroidal fluid, and even in the subtenons area. So not always you may see that the posterior scleritis may show a subtenons fluid or a T sign, but yes, the disc leakage itself is a good indicator in this case. Some cases, as in this case, we can see the disc is just looking hyperemic, and we can see there is subretinal fluid and intraretinal fluid. And when we do a B scan, we see that there is a T sign or some kind of a fluid into the subtenons fluid, which suggests that there is some kind of a disc inflammation or posterior scleritis. There can be very obvious lesions like this, where you see yellowish colored lesions over the retina on the posterior pole or on the periphery. There can be associated choroiditis, bacillary layer detachment, or intraretinal or subretinal fluid. So clinical examination and telltale signs are very important to look for the mimics. And fever-associated retinopathy would show you some area of retinitis or healing retinitis. They may show either thickening of the retina, or some areas you may see even the retinitis lesions, SRF. More important lesions are something which are more sinister. So this is a case of a choroidal hemangioma, where we can see the hemangioma is on the superior nasal side of the disc, but we are seeing a fluid which has tracked at the fovea. So this is not a CSR, but this is a tracked fluid because of the choroidal hemangioma. As you can see, the FFA is showing hyperfluorescence at the area of this choroidal hemangioma, and the Opta is helping us to identify whether actually the normal versus abnormal choroid, where we can see bag of worms or either club-like appearance of the choroid. And if it's involving the posterior pole, we can see some kind of an orangish mass, and this yellow lesions are because the RP changes into the retina. And if you do a very small scan Opta, as you can see, I have done a 3.5 or 4.5 Opta, where we can see the choroidal architecture is abnormal in this case. So that again helps you to identify it's a kind of a choroidal hemangioma, which gives you an indication that this is not what we are looking at CSR. And if you perform an ICG in such cases, you may see something which is called as a washout phenomenon. B scan would show you hyper surface, which is hyper, and internal, which is again hyper, with very high reflectivity. Choroidal osteoma is one more differential diagnosis. We may see some kind of a yellowish lesion in the subretinal space. If we perform a B scan, we may see that B scan would give us a hyperreflectivity, like a second disc appearance. Certain cases may have some kind of a neovascularization associated with it. Much more sinister differentials to be considered. In this case, as we can see, there is a large area which is a little darkish brown in color with yellowish colored lesion. In this case, this yellow lesion, as we can see, is nothing but some kind of a shrem which has deposited. And if we can see the OCT here, all the choroidal architecture is completely obliterated. So this is a choroidal melanoma which has converted right now and got activated. And subretinal fluid is one of the signs which is towards melanoma. And if it's an intraretinal fluid, it is against melanoma. This is one of the very interesting cases where you may see a fluid, but in this case, as you can see, again, complete obliteration of the choroidal architecture. This case had a breakthrough melanoma which had gone into the vitreous cavity. As you can see, this is the area of the breakthrough melanoma. Much more sinister, something which is called as a B dump or a bilateral diffuse uveal melanocytic proliferation. So these are just the kind of presentations which you may see where the patient can have intraretinal fluid, loss of outer layer, and autofluorescence would be like a pretty vague kind of an hyper and hypo autofluorescence. In this patient had a history of bronchial carcinoma, and that's what we are seeing at this point, that this is one of the sinister side effects of the systemic carcinoma. This patient had bronchoalveolar carcinoma where the patient has metastasis. As you can see over here, we may see multiple yellowish colored lesions. These can be yellow, orange, sometimes creamy in colors. This can be unilateral, unifocal, bilateral, multifocal. As in this case, the choroid gets involved, and then you see lumpy, bumpy choroid with subretinal fluid, and you may see the retina may be elevated, and one eye is involved than the more than the other eye. So the take-home message is what we know is what we see. So try to do a multimodal imaging for the diagnosis which we are considering. And yes, obviously, if there is any doubt, get a second opinion for considering much more rare problems which we are seeing. Thank you. Thank you again.
Thank you, Dr. Divyansh, for that elaborate presentation. I think he's covered it all. There's nothing much to discuss in terms of mimics. We'll go on with a very quick panel discussion. I would like to invite Dr. Uni, Dr. Adesh, Dr. Ashok, and Dr. Natasha. So we will just go through some of the common scenarios and try to. First, I'd like to ask Dr. Adesh. Dr. Adesh, we know that FFA is the most important investigation that we do in a patient with CSR. Can you tell us what are the abnormal FFA findings that would question your diagnosis of CSR?
Thanks, Manoj. Yeah. See, as Divyansh pointed out, there are many different diagnoses for CSR. And many clue regarding the other different diagnoses of CSR can be actually made out from the fluorescent angiography finding itself in many cases. So one important area that we should concentrate is look at the disc. So the optic disc is usually silent in CSR, but in a patient who is having an inflammatory pathology like a leakage or a scleritis, you can have. So in an inflammatory pathology like scleritis or leakage, we can have a leakage as well as staining of the disc. It says that it is not CSR. Then another.
Okay. There you go. It's
okay.
Sreeni. Sorry.
So if there is a leak from the disc, if there is a staining of the disc, then it is pointing against the diagnosis of CSR. Then you can also look at the vessels. So the vessels are not involved in CSR. So the retinal vessels are showing leakage or staining, then again it could be an inflammation that is responsible for the detachment. The third thing is that look at the pattern of leakage. So we know that usually the acute CSR shows the small stack point of leakage or the ink blot pattern of leakage. But if you see a different pattern of leakage, just like a starry sky appearance of leakage, where you have early fluorescence followed by pinpoint areas of fluorescence with late cooling. It may be suggestive of inflammatory pathology like VKH or scleritis. Then some of the white dot syndromes can also have the similar appearance, early hyperfluorescence with late hyperfluorescence. And then another important differential is, as Divansh was pointing out, is choroidal hemangioma and metastasis. In choroidal hemangioma, you can have early hyperfluorescence with late leakage. And again, if it's a metastasis, you can usually see early hypofluorescence followed by late leakage. So the pattern of leakage tells us that it could be a condition which is different from CSR. Then ink blot pattern of leakage, sometimes a patient who is having a very small CNVM, that CNVM leakage can be confused with the ink blot pattern of leakage. So if you are seeing, in addition to the leakage, if you are seeing a block fluorescence in association with the leakage, which is suggestive of, which is because of the presence of subretinal blood, then that again says that it is not CSR. You can actually confirm it with the help of structural OCT as well as the or even if you can Octa. Then very rarely, very late stages of branch retinal vein occlusion, macular branch retinal vein occlusion can have just fluid in the area. You may not be able to see the retinal hemorrhages there. So a fluorescent angiography, when you do that, you can see the foveal ischemia because of the venous occlusion. Then that again tells you that there is no ischemia as such in CSR. So it is a different pathology. Then in addition to this leaking pattern, absence of leak itself is a sign which says that it may not be CSR. Of course, you can have no leakage. The leakage can spontaneously resolve in CSR. But if there is no leakage, then we should think that it may not be CSR. It can be some other condition, as something like a vitiliform dystrophy, especially when all the subretinal material has disappeared. On OCT, it may look like CSR, but you may not be able to see any leakage on fluorescent angiogram. In such cases, the fundus autofluorescence may help. Then there are many other conditions like dome-shaped macula, then optic disc pit. So it's also important to look at the disc. We can see the staining along the edge of the optic disc pit. So it's not just the pattern of leakage, even the absence of leakage has to be given importance. And this might make us think in terms of conditions other than CS.
Yeah, thank you. And next, I would like to ask Dr. Unni. Now we all know that CSR is primarily a choroidal disease. But then we all resort to FFA because that is the most common investigation we have. Many of us don't have ICG. And also we know that we don't have PDT now. So we don't actually require, do we actually require to do an ICG? What are the situations when you would do ICG, or do you do it in all cases? You're muted. Unni, you're muted.
So thank you for the invitation and the question also. So Rajesh has given a very, very elaborate answer. So I'm going to use that answer and not say much. My answer is that whenever you do an FFA, you have to do an ICG along with it for the information part. You also answered the question when you said that since you don't have PDT, you don't have a definitive indication for ICG nowadays. But whatever Rajesh has said regarding mimics, regarding variants, regarding suspicions, regarding everything, there is no role of doing an FFA alone nowadays. Whenever you do an FFA, the information has to be unearthed by the ICG studies also. There are a few, newer indications of doing an ICG. And the most newer indication is when you consider that CSR to be the new concept of a venous overload choroidopathy or a venous overload disease. It is not the ICG that is not to matter in the future. It is going to be the wide field, ultra wide field ICG. The diagnosis, the possibility of a surgical management of CSR is looming. Basically, it is looming in the future. And when that comes, our dependence of ICG to find out the extent of vortex vein, the extent of peripheral choroidal venous dilatation will be important. So that's probably my thought process now and my thought process for the future.
Okay.
Manoj, I think the time for the session is over. We'll move on to the next session now.
Can we ask one last question? One last question.
Yeah.
Dr. Natasha, can you just give us some idea about chronic and atypical CSR? There is an entity called atypical CSR. When do you call a CSR atypical?
So chronic CSR usually from the history, sometimes the patient will give you a long-standing defective vision and multiple episodes where he has been told there is fluid in the retina. But most of the time, this chronic CSR, the importance of it comes when there's cataract and the vision is not corresponding to the amount of cataract. Then and the retina looks like there are some multiple RP changes. That is when you can suspect that there is a chronic CSR there. One of the on examination, you will only find multiple atrophic areas and sometimes a telltale track. And but one of the best investigations to bring that out is an autofluorescence, in which you will see the extensive damage to the RP that has happened. And the OCT, of course, will show you the foveal thinning as well. And atypical CSR is when it is not that straightforward, the sensory neural detachment at the macula that we see generally, what we call the typical CSR. It can be multiple bullae, in which case you should be looking at whether there's any steroid use, whether there is any, and when I ask for steroids, I usually ask 3 questions: inhaler, skin cream, and oral. It's not just the oral steroids. So we have to be careful about that. Any presence of intraretinal fluid, which can be either the pachychoroid spectrum or because of a CNVM developing. Then extensive RP changes that look like a leopard skin, which will then lead us to all the other differential diagnoses like a bidump or something else. And presence of hemorrhage or hard exudates. These are all atypical things, and we should be like aware that we are looking at maybe some other differential diagnosis as well.
Thank you, Dr. Natasha. I would like to thank all the speakers and the panelists for being part of this session. I think we had a wonderful discussion, and I think we overshot the time considerably. So we'll move on to the next session and invite Dr. Prakash to take it.
Thank you, Dr. Manoj. It was a very wonderful session on CSR, well conducted. So I welcome you all to our session on diabetic macular edema. Diabetic macular edema, as we all know, is the most common problem we face as a retinal surgeon, and that's where probably the eye meets the body. The systemic issues we have to tackle along with the visual requirements of our patients. So this is going to be a very important session, and we have a good array of speakers here. And I invite Dr. Ashok to moderate the session and introduce our speakers as well as the panelists. Dr. Ashok.
Thank you, Dr. Prakash. Today we have a stellar group of people presenting various aspects of diabetic macular edema. Now let me introduce the session participants. Just a moment. We have Dr. Prakash, who is the chairman of the session. Dr. Prakash is the director of Comtrust, medical director of Comtrust Hospital, Calicut, and he's a senior vitreoretinal surgeon who has had additional training in uveal diseases also. And then we have Dr. Rahul Menon. Rahul Menon is the senior consultant retina at Comtrust at Chaitanya Eye Hospital, Ernakulam, and he has finished his training from Shankar Nethralaya, Chennai. And we have Dr. Ghana, who was a former consultant at Comtrust Hospital, Calicut, and now she is presently a senior vitreoretinal consultant at Rani Menon's Eye Hospital at Thrissur. And we have Dr. Sunil, who is one of the prominent faculties in the Karnataka Ophthalmic Society also, and he's professor in the Medical College at Davangere, and he is the director of the Davangere Eye Care at Davangere, and he's a senior vitreoretinal surgeon. And we have an array of panelists also for panel discussion. And now I invite the speakers to go on with the talks. Thank you.
Start, Dr. Rahul, you can start your first talk. Yeah, you're audible and you can share your screen.
So at the outset, I would like to thank Dr. Prakash and the KSOS Scientific Committee for giving me this opportunity. I'll be talking about the pathogenesis of diabetic macular edema and the newer insights, and also a bit about the newer drugs in the pipeline. So diabetic macular edema is the leading cause of blindness in middle-aged population. The prevalence is about 35%.
Rahul, can you make a screen full?
It's full, sir.
Is it?
It is full.
I think you are sharing the other side.
Not here. I think there's a problem with sharing.
You share the full. You have two screens there. Share the one which is full screen. You unshare now.
Just one second, sir.
Yeah.
Is it full now, sir?
Yeah.
Just one second, sir. Just one second, sir. Yeah, sorry for the interruption. So it is the leading cause of blindness.
Now it has gone back to the old one.
Old one, is it?
Yeah, the other one you had in between shared full screen. You have to unshare and go back.
Is it full screen now?
No, it is not. Okay, you can continue. I think it's okay.
Okay, sir. So, so the normal retinal capillaries are has a lumen enclosed by endothelium, surrounded by a pericyte and basement membrane. The pericytes envelop the endothelial walls of capillaries.
Also, the slides are not moving.
Now?
Moving.
It's moving now?
No. Yeah, now it is perfect.
No, but is it moving now? Just check.
No, it's not. Is it moving now, sir?
You're not shared. You're not
now
shared.
You're not sharing.
Prakash, can we go to the next?
Yeah, I think.
No, Rahul, you can do one thing. Instead of trying to move by the.
Is it sharing now? Is it sharing now?
It's sharing, but I don't think it will move. You try to move. No, I don't know. You go to the side, pick up each slide and then present. You go to the side. That way you do it. Now try the next slide. No, it won't move on.
Yeah, now it is.
Yeah. Okay.
You can do that way. Yeah.
Yeah. Whatever you're doing now, you can do.
Okay, fine. So, what was I? Yeah. So the retinal capillaries are made up of the lumen surrounded by endothelium, which has a covering of pericytes and basement membrane. So the pericyte envelop the endothelial walls of capillaries, venules, and arterioles. These pericytes are connected to the endothelial cells by three major types of intercellular junctions, basically the PEG socket type, gap junctions, and adhesion plaques. So alteration of the blood retinal barrier is the hallmark of pathogenesis of diabetic retinopathy. In diabetes, three changes occurs at the blood retinal barrier, namely the selective loss of pericytes, loss of endothelial cell-to-cell junctions, and thickening of the basement membrane. So the pericyte loss causes focal weakening of the vessel wall and focal endothelial cell proliferation, which leads to what we clinically seen as microaneurysms And also it leads to apoptosis of the endothelial cells, which leads to capillary non-perfusion. So once the blood-retinal barrier breaks down, it leads to intraretinal hemorrhages, hard exudates, and macular edema. So also there's an increased activity of four major biochemical pathways, namely the polyol pathways, advanced glycation end product pathways, protein kinase pathway, and hexaminase pathway. So all of them finally lead to increased production of the reactive oxygen species, which leads to mitochondrial dysfunction, inflammation, and hypoxia. And there's an upregulation of vascular endothelial growth factor. So normally there's a balance of the angiogenic and anti-angiogenic factors. So the various angiogenic factors are the VEGF, basic fibroelastic growth factor, insulin-like growth factor, angiopoietin 2. And the anti-angiogenic factors are the pigment epithelial derived factors and endostatin. So the VEGF levels are significantly elevated in the vitreous of diabetic macular edema patients. So what really happens is this VEGF usually attaches to the VEGF receptors and causes increased angiogenesis and inflammation, eventually leading to breakdown of the blood-retinal barriers. And this anti-VEGF, which we give for the treatment of diabetic macular edema, blocks this VEGF and causes signal blocking. Now, we all know that many of the times when we treat these patients with anti-VEGF, the diabetic macular edema, some of them don't respond the way which we expect, because it's not just the VEGF that is leading to the diabetic macular edema. There are other many inflammatory markers, inflammatory factors which lead to the DME. So a lot of new treatment modalities have been tried looking at treating the various other inflammatory markers. So I'll be limiting my talk to the integrin inhibitors and the cytokine chemokine inhibitors. So integrins are the cell surface receptors. They dictate the communication in the extracellular matrix between the cells. So if I have to put it in a simple term, we all in our OPs, hospitals, and our home, we have the comfort of the air conditioners. So this air conditioner has a sensor. So whenever the temperature outside goes above the set limit, say suppose we set the air conditioner at 24 degrees temperature, and the temperature outside is higher, the sensor actually detects it and gives a positive feedback to the air conditioner and turns it on. At the same time, when the temperature outside is lower than the set temperature, it gives a negative feedback and shuts down the computer. So integrins is something like that. It's like the sensor. So a lot of therapy has been tried. It has been investigated thoroughly. The various inhibitors have been tried for the treatment of DME. So we have abicipar, pegol, ASP8232, and risankizumab, which have been integrin inhibitors, which have been tried for the treatment of DME. So abicipar pegol is a non-monoclonal antibody anti-VEGF. So abicipar is the anti-VEGF portion, and the pegol is a polyethylene glycol D. Now it is based on the designated ankyrin repeat proteins, that is DARPins. Now abicipar is a very low molecular weight structure and has no immunoglobulin component. So it is rapidly cleared from the system circulation, so from the systemic this thing. So that is why the pegtail has been added. So PALM trial was done to study the effect of the abicipar pegol, in which it was compared with ranibizumab. So abicipar 2 mg given over 12 weeks and 8 weeks showed an improvement of about 7.2 letters and 7.1 letters, whereas 1 mg abicipar over a period of 8 weeks gave an improvement of 4.9 letters. But what they found was there was a high rate of intraocular inflammations in patients treated with abicipar. The reason on investigation, what they found was during the manufacturing process of DARPins, there was a potential impurity which was developed from the fragment of E. coli. So in the phase 3 study, they remodified the manufacturing process, and what they found was there is a reduced intraocular inflammation. Another integrin inhibitors is the vascular adhesion protein 1. So the VD study studied the effect of ASP8232 with ranibizumab, but it was not found to be very efficacious in treating central involvement diabetic macular edema. The only thing was it was administered by an oral route. So future research could target local delivery to the eye. Another integrin inhibitors is the addition molecule inhibitors, basically risankizumab. So it antagonizes 4 different integrin heterodimers. So in the 2 arms, one arm was treated with initial bevacizumab followed by 3 monthly risankizumab, whereas the other arm was treated with monthly bevacizumab and sham injections. So what they found was that it was non-inferior, effective through 12 weeks after the final dose. 48% of the patients gained more than 8 liters in the treatment arm compared to 7% in the sham. It's a short-term study, so long-term results are still awaited. Another integrin inhibitor is THR687. It has shown a good promise in animal models, and integral study is underway, which will evaluate the efficacy and safety of this drug against aflibercept. Now, coming to angiopoietin pathway, there are multiple angiopoietins which we know of, that is ANG1 to ANG4, but ANG1 and ANG2 are the key cytokines. So it interacts with the transmembrane receptor tyrosinase kinase receptor, that is TY2 receptors. So basically both VEGF and ANG2 are very similar, but not very so. But what they do is basically activation causes an increased angiogenesis and vascular destabilization. So in the VEGF pathway, there's there's an induction of the endothelial cell sprouting and primary capillary network formation, whereas the ANG2 TY2 pathway causes remodeling and maturation in the later stages of the angiogenic process. So in the pro-angiogenic state, there's upregulation of ANG2, which completely binds to TY2 and causes endothelial destabilization, inflammation, and breakdown of the BRP. So faricimab is a new antibody targeting both ANG2 and VEGF-A. It is developed on cross-map platform. So what happens is, because of this technology, we can create two different antigen binding domains into a single structure. So the anti-ANG2 antigen binding domain reduces the inflammation and enhances vessel stabilization, whereas the anti-VEGF causes reduced permeability and leakage. Now, along with that, this modified FC segment over here, what it does is it prevents the formation of undesired side chains, and eventually what the end point is that the chances of intraocular inflammation is reduced. So in the Boulevard study, the safety and efficacy of faricimab was compared with ranibizumab in diabetic macular edema. So in treatment-naive patients, the BCV gain in faricimab group was more than ranibizumab at week 24. So faricimab 6 mg gave an improvement of around 13.9 liters compared to ranibizumab 10.3 liters. So what it did study showed was that there's potential clinical benefit when simultaneous inhibition of ANG2 and VEGF-A is done. So after this study, a phase 3 study was done, Yosemite and Rice study, where they compared it with aflibercept. So in the Yosemite study, the patients were divided into 3 groups, in which the faricimab group 1 was treated with faricimab every 8 weeks. The other was second group was treated with faricimab on a personalized treatment interval, that is PTI. I'll be discussing about the same later. And the third arm was treated with aflibercept every 8 weeks. So the incidence of ocular adverse events were almost similar in all the 3 arms. The visual gain was more in the faricimab, which was treated with personalized treatment interval. In the Rhine study, 951 patients in the same were divided into 3 arms. Faricimab every 8 weeks. The second group was with a personalized treatment interval, and the third arm was treated with aflibercept. The incidence of ocular side effects were a little higher in the arm that was treated with every 8 weeks, but the visual gain also was higher in that group. So this is a rough idea about the personalized treatment interval. So what they do is they treat the patient with 4 loading doses. They usually, whenever we treat, we give 3 loading doses. Here it was treated with 4 loading doses, and after that, the lowest central CST take was taken as a baseline, and also the best BCVA was taken as a baseline. And on basis of that, the treatment interval was increased by a period of 4 weeks, up to a maximum of 16 weeks. So this is Vabysmo, which has been faricimab, which has been recently approved by the US FDA for the treatment of CNVM and diabetic macular edema. This year it was approved in the month of Feb 2022. Thank you.
Thank you, Dr. Rahul. It was a wonderful talk. I think DME is always, we are not happy whatever current drugs we have. There are a lot of unmet needs, and any newer drug to this armamentarium is most welcome. And always we have to go back to the clinical, the basic pathogenesis of this disease, which we have never understood fully, to get the newer drugs. And we are waiting for faricimab to be launched in India also. so that we have one more new drug to treat this difficult disease. So the next talk I invite Dr. Sunil already has been introduced, and he will talk on the role of biomarkers, OCT biomarkers, how will it help us in treating diabetic macular edema. Dr. Sunil?
Yeah. My slides are visible, Prakash?
Yeah, it's visible,
yeah,
full screen.
Yeah. I'll be talking to you a little bit about imaging, and then I'll talk about the biomarkers in DME. As we all know that 40 to 20% of all diabetics are affected by DME. So why to treat? In untreated patients, 50% of the eyes with DME will lose more than 2 lines within the 2 years of diagnosis. So need to look into this complications of diabetes and diabetic retinopathy. And it may lead to permanent photoreceptor dysfunction and loss of outer as well as inner retinal layer integrities can be lost. So imaging modality complement the diagnosis and treatment of DME. So what are the imaging options available? Color fundus photography, the fluorescent angiography, including the ultra wide field fluorescent angiography, fundus autofluorescence, OCT, as well as OCTA. The color fundus photography definitely helps in screening the patients for DME. It helps in the assessing the disease severity and progression. Definitely helps in counseling the patients and as well as for the documentation purposes. The gold standard fluorescent angiography, one can know the leakage pattern in DME, whether it is a focal or a diffuse leakage. You can plan the treatment accordingly. In a patient with diabetic macular ischemia, you can assess the degree of macular ischemia. If you're planning a focal laser treatment, it can act as a guide for the treatment of focal laser. But what are the shortcomings of FA in diabetic macular edema? One is delineation of all microaneurysms and hyperpermeable retinal capillaries in the deep capillary plexus is not possible. We know that now the most of us are looking into the deep capillary plexus for the majority of the changes which occurs in diabetic macular edema. Delineation of FAZ sometimes can be confounded by the leakage, and delineation of submacular detachment is not possible with the FA. All we know, we are looking at now ultra-wide field fluorescent angiography. We are talking about peripheral retinal ischemia and its association with DME. Studies shows that there is an almost increased incidence of DME by 3.75 to 4 times in a patient who has got a peripheral retinal ischemia. Studies have also shown an association between a recalcitrant DME and the peripheral retinal ischemia. Like in vein occlusion studies, in DME studies have also shown that if you do a targeted laser to this peripheral retinal ischemia, it can act as an adjunctive treatment in the management of DME. Apart from that, in an ultrafield FFA, you can look at certain indices like ischemic index, leakage index, and even the microaneurysms count. All these tends to be associated with the incidence and severity of the DME. And studies have also shown that higher ischemic index was associated with DME statistically significantly. The another entity which has been described in ultra wide field FA, that is a peripheral vascular leakage, which also tends to correlate with the DME. OCT basically it helps in assessing the qualitative and quantitative parameters in diabetic macular edema. You can assess the structural integrity of the retinal layers. You can look into the retinal thickness. You can look into the treatment response, whether it is a medical or a surgical plan of management. And you can look at the retinal thickness change analysis over a period of time for the treatment response. There are various OCT patterns which have been classification has been done based on the morphological patterns. One is the first is a diffuse retinal thickening, then there is a cystoid pattern, then there is a neurosensory detachment or a submacular detachment, and there is a thickened posterioid with or without vitreomacular traction. These are some of the morphological patterns one tend to see on this thing. The OCT definitely helps us in deciding whether to go ahead with the treatment. For example, this patient with the VMT will require a surgical intervention. This is a patient with a DME with a taut posterioid. Still, one can consider the intravitreal injections. One entity of the DME which I would like to highlight is a serous macular detachment. These patients tends to have a systemic biomarkers or an uncontrolled hypotension, nephropathy, anemia associated with this thing. They tend to have a sick RP and tend to have a poor prognosis. En-face images definitely helps in ruling out the fluid presence, especially in the presence of fluid in the outer nuclear layers. What they divide it into the retina to segment 1 and segment 2. If you tend to see a fluid in the segment 2 on en-face images, they tend to be less responsive to anti-VEGF drugs or steroids. So en-face images mainly helps in looking at this fluid segments in the segment 2. The OCT angio, basically you don't see any leakage pattern. Sometimes if there is a severe fluid segmentation and artifacts is a concern in a DME, you can know the capillary non-perfusion and vascular flow patterns. The vessel density will be lower in both superficial capillary plexus and in deep capillary plexus in DME. Microaneurysms, Definitely, we should look into the internal reflectivity of the microorganisms, presence of flow, the morphology, and the anatomical location. All these helps in predicting the risk of DME in 1 year and the treatment response. Hyperreflective microorganisms tends to do better response with anti-VEGF for steroids. Looking onto the foveal avascular zone in the macular ischemic group ischemia, one can assess the area, circularity, its perimeter, and the vessels intensity. All these parameters adds value to the management of DME. And enlargement of foveal avascular zone is seen in both superficial capillary plexus and the deep capillary plexus. And FAZ circularity index significantly increases as the DME progresses. And if you look at the FAZ area in the DCP is associated with the deep capillary plexus is associated with worsening of visual acuity. FAZ area in the superficial capillary plexus as well as vessel density in the superficial capillary plexus tends to correlate with the retinal sensitivity over a period of 1 year. Another important investigation is a fundus autofluorescence. Basically, you look at the hyperautofluorescence, increased hyperautofluorescence in the foveal area in the patients with DME, which tends to be associated with worsening of visual acuity and increased macular thickness. You can see here various autofluorescence patterns have been described. One is a single spot hyperfluorescence, multi-spot hyperfluorescence, plaque-like hyperfluorescence. These are the patients, multi-spot and the plaque-like hyperfluorescence tends to be associated with serous macular detachments and tends to have a poor prognosis when compared to the other patients. So thus the hyperautofluorescence in DME correlates with the OCT pattern in the microperimetry. The sensitivity of fundus autofluorescence is around 81% and specificity is around 69%. The other thing is the macular, you can assess the macular pigment optical density also in DME patients, and it has got a low sensitivity in detecting extrafoveal as well as the diffuse diabetic macular edema. Now coming on to the imaging biomarkers, how they help in the management of DME. The biomarkers are nothing but the measurable objective indicator which helps in assessing the prognosis and treatment plan. It helps in assessment of the health of the retina and choroid. Severity of the DME can be assessed and you can plan the treatment and the response to treatment. Various biomarkers which I will be discussing one by one in subsequent slides. When you look at the thickness and volume on the OCT, the 2 or 3 things one should look for. One is the mean central subfoveal thickness, which is in the central 1 millimeter. And if you look at the 6 by 6 cube, you can look at the cube average thickness and the cube volume. Most of the studies takes into consideration central subfield thickness or central subfoveal thickness, but one need to know that there's got a modest correlation with the visual acuity. It is not a prognostic or a predictive of final visual outcome. Apart from looking at the central subfoveal thickness, one should look into the other parameters of DME like pattern of DME and the layers of retinal involvement and whether inner or outer layer involved in assessing the prognosis rather than looking at the central subfoveal thickness alone. The other entity is the presence of SRF or a submacular detachment. It is an important biomarker seen in as around 15 to 30% of the patients which are associated with disruptions of the ELM also. When you look at a DME with serous subfoveal neurous submacular detachment, one will have an association of greater choroidal thickness. They tend to have a more hyperreflective foci. There will be disruption of ELM as well as decreased retinal sensitivity. Continuing with the submacular detachment, the SMD or SND, SRF is associated with higher visual gains. The restore and post-hoc analysis of restore and rise studies have shown the SRF has got a protective role. VISTA and VIVID studies have shown that greater effect of aflibercept in these patients with baseline SRF. And they tend to respond very well to the steroids when compared to the anti-VEGF, and eyes with SRF tends to need fewer injection over a period of 1 year. The another biomarker is the intraretinal cystoid spaces. One need to look into the size and location of this cyst. Larger cysts in the outer nuclear layer in the late stage of DME have a negative impact on the macular function because they tend to damage the photoreceptors. So with anti-VEGF therapy, there will be decrease in the size as well as the number of outer nuclear cysts with improvement in best corrected visual acuity. Larger intraretinal cysts are associated with macular ischemia. One should not look into the cysts alone. They should look at the bridging tissues in between the tissues cysts, which contains basically the Muller cells and the bipolar cells. If there is enough bridging tissues are present, that indicates it's a good prognostic factor, and the visual acuity also will be in better. If there is an absence of bridging tissue, they end up with either retinal thinning or atrophy. The another entity within the cyst, you can see an intracyst hyperreflective material. This is a poor prognostic factor or a poor outcome in this patient. And if somebody sees in this intracyst hyperreflective material, they tend to require more intravitreal injections for a resolution than those who do not have a hyperreflective material within the cyst. If you consider the response to treatment with the various morphological patterns, the spongiform or a diffuse retinal thickening responds better to treatment when compared to the other morphological patterns of diabetic macular edema. So CME, VMT, and neurosensory detachments tends to do poorly when compared to the DRT. The other the biomarker is the hyperreflective foci. These are nothing but extravasated lipoproteins or degenerated photoreceptor segments or activated microglial cells. The correlation has been found with respect to the presence and density of hyperreflective foci with the severity of the DME. They can be associated with any pattern of DME, and usually they decrease with treatment and they correlate with visual acuity. The hyperreflective foci in the outer retina tends to correlate with distortion of the ELM and EZ. Steroid implants tends to show a better response in a patient who has got an hyperreflective foci than anti-VEGF. The more the number of hyperreflective foci, early recurrence of DME after post-treatment. So we need to look at the number of hyperreflective foci also. So those one who has got a more number of hyperreflective foci tends to have a frequent follow-up and early intervention. If you tend to see an hyperreflective foci in the subretinal space, please rule out the systemic associations, like if there could be an associated hypertension or diabetic nephropathy. And the hyperreflective foci also tends to correlate positively with the glycosylated hemoglobin also. So one need to differentiate between hard exudate as well as an hyperreflective foci. Hard exudates, the size are a little bit larger, more than 30 microns. They will have a back shadowing, and they will have a reflectivity similar to the RPE layer. That will be hyperreflective. And the intravitreal steroids are more effective in reducing hard exudates in diabetic macular edema when compared to the anti-VEGF. Here is the patient with an hard exudate with back scattering. These are the patients with the hyperreflective foci. So need to differentiate. Another entity which has been described is a Pearl-X sign. This is nothing but the arrangement of the hyperreflective foci within the cyst wall. It looks like a ring of pearl or a pearl necklace sign. The relevance of this is when this is situated subfoveally. If you inject the drugs and post-treatment, sometimes they can form a subfoveal hard exudate plaque and can have a poor prognostic factor. So one need to be careful in these patients. The other thing is sometimes an hyperreflective material within the intraretinal layer could be an heme. It not be anything else though. So they may not respond to the fibrin or heme, which may not respond to the anti-VEGF. So one need to look into this entity also. Another entity is the drill. This is a disorganization of inner layers. You tend to see in chronic DME. Here you will not be able to, there will be loss of boundary between the layers. These are nothing but damaged cells within the retinal layers, and disruption of drill is also will be associated with poor visual outcome. So within the central 1 millimeter, you look for the continuity of these layers. If there is a lack of boundaries, you can measure the extent of drill. So those who got drill has got 8 times greater risk of poor visual acuity, and they tend to do poorly with the anti-VEGF injection also. The association of drill extent with the visual acuity change is a significant and consistent robust parameter when compared to any other parameter. The other biomarker is the vitreomacular interface abnormalities. They tend to have a poor visual outcome. VMA, if it is there, may show a good response to anti-VEGF when compared to the VMT. The taut posterior hyaloid phase may be associated with recalcitrant DME. The patient with taut posterior hyaloid membrane will benefit from past plan of vitrectomy than the medical line of treatment. Outer retinal biomarkers, one need to look at the thickness of the outer retinal layers and the association with the visual acuity, and you should look at the ELM as well as the ellipsoid zone. There are various ways which you can grade the ellipsoid zone and the ELM disruption, whether it is completely present, partially, or completely disrupted. These grades correlate very well with the logmar visual acuity. Here is a patient with a gross cystoid spaces but an intact ELM and EZ, so the visual acuity is good. But in this patient, you can see that the edema is resolved. There is a foveal thinning. There is a discontinuity of the ELM as well as EZ. The visual acuity significantly drops. So this is the significance of ELM and EZ in these patients. Another biomarker is a parallelism, where we look at the subfoveal area for the photoreceptor layer was keratinoids, and orientation of these were noted. These also tends to parallelism significantly lowers in DME. Of course, you should look at the photoreceptor outer segments. The short photoreceptor outer segment shortening is seen in the entire macular grid. If you tend to see, they tend to have a poor visual acuity. So one need to look into this biomarker also. Outer retinal tubulations can be seen in DME like AMD. If it is in a closed sort of ORT, it mimics like an intracystoid intraretinal cyst. If it is an open form of ORT, which mimics like a fluid, either intraretinal or a subfluid retinal fluid. Choroidal biomarkers, there is an entity of diabetic choroidopathy nowadays, though there will be choroidal thickness changes associated in a DME. as well as one lead to look at the choroidal vascularity index. The patients with PDR tends to have a significantly lower choroidal vascular index. So choroidal vascularity index is useful in monitoring the progression of diabetic retinopathy. Similar to hyperrefractive foci in the retina, choroidal foci have also been described. These have got a poor prognostic markers. These occurs because of whenever there is a disruption of ELM from the retina, they tend to move towards the choroid. The OCT biomarkers, you need to look at the FAZ and the vessel density. Poorer vessel density in both the layers are associated with poorer best corrected visual acuity. Another thing we should look for in octa is a suspended scattering particle in motion. So what does it indicate is suspended scattering inner motion particles within the inner nuclear layers was most greatly related to the treatment response. Here you can see one of the patients who responded very well to the steroids rather than the anti-VEGF. You can see the suspended scatter particles reduces after treatment on treatment with triamcinolone. So they sometimes tend to do poorly with anti-VEGF and well with the steroid treatment. And here is another patient. There is a significant correlation with the capillary loss in the deep capillary plexus with the outer plexiform layer integrity. Here is a patient where there is a significant loss of foveal capillary loss in the deep capillary plexus, but there is a distortion of OPL. This patient did poorly when compared to this patient who did very well with the response to the treatment. So in conclusion, biomarkers are surrogate tools that help us to detect the patients with who needs a prioritized treatment. And you can also assess the patients who may not benefit with the extensive treatment in DME. Type of treatment may vary depending upon the presence or absence of certain biomarkers. You should look into the pro-inflammatory markers, which gives a clue whether to go ahead with the steroids or the anti-VEGF. One need not look at only the ocular biomarkers. You should correlate them with the systemic biomarkers for the better management of DME. Thank you. Thank you for your patient hearing.
Thank you, Sunil, for that exhaustive coverage of all the imaging modalities as well as the biomarkers. I'll just ask you one single question, because most of us as practitioners have access only to OCT. We can forget about most of the other who are dealing with diabetic macular edema. So one single prognostic, it's very important to differentiate between chronic versus acute DME to predict the treatment response. So if you look at one single biomarker which can be easily interpreted and which can be easily seen on regular OCT, what will you choose? What will you suggest for a practitioner?
Biomarkers, definitely the central macular thickness is one thing. The other thing is the presence of fluid, whether it's the intraretinal fluid or the subretinal fluid.
Also. Okay, I think drill also can be one important biomarker, I think, because diabetic retinopathy being a maculopathy being an inner retinal disease, the disorganization of inner retinal layers is easily accessible and easily quantifiable. Only thing is you have to look, just not look at one single scan that is given to you, one single printout that is given to you. Always go through the entire OCT cube that has been done, the raw data completely, before you decide on whether drill is present or not. So sometimes you may miss the larger extent of drill that is there, which if you just look at one horizontal scan. So that is the only thing. And that is, I think, very easily can be assessed. Okay, thank you, Dr. Sunil. We'll come back. We'll have the rest of the discussion later. I'll now invite Dr. Ghana for her talk on a practical treatment protocol based on all that. We have a lot of clinical trials, a lot of material, which what to take and what not to take is the main thing, because we are confused with a lot of clinical trials. So I think Dr. Ghana will give us a practical treatment protocol, how to go about, how to take the cream out of these studies and use it for our patient benefit. Dr. Ghana.
Good morning, everyone. Thank you, sir. So at the outset, let me thank KSOS and Dr. Prakash for giving me this opportunity. And I think I'll share my screen now. Am I audible?
Yeah, you're audible. You're audible. You can share it.
Okay. Okay. It's full screen now?
Yeah, it is full screen.
Okay. So my topic for the day is current treatment protocol for diabetic macular edema based on newer clinical trials. So let's get to a practical, as Dr. Prakash has mentioned, how to go about this in a practical manner. So treatment, as we know, we have all of these categories or tools available to us, starting with laser, intravitreal injections that include anti-VEGF and steroids, and vitrectomy, and of course, metabolic control, which is important as well. So we have a wide range of clinical trials, and to get into everything in detail will be quite difficult in a 15-minute session, but let's get to what all are available to us. So laser photocoagulation initially studied through ETDRS and DRS, which followed by vitrectomy in diabetic retinopathy vitrectomy study, metabolic control, and then intravitreal injections. So DRCR net is our current, what we now base most of our treatment on DRCR net. Other trials include Resolve, Restore, and Ride or Rise, and they were dealing with ranibizumab, and Darwin C. Vista Vivid with aflibercept, Kestrel and Crite with our new kid on the block, rolosizumab, and Bolt with this bevacizumab. So over the years, in the beginning, 1985, that is when ETDRS came to us and gave us clinically significant macular edema and told us when to treat clinically significant macular edema. That is, if there are treatable lesions, do a focal laser within this area, within 2 diameters of the center of the macula, as seen on fundus fluorescent angiography. One other point that they shared with us is in eyes with DME and PDR, immediate focal followed by delayed PRP is the strategy of choice, unless there is HR-PDR, in which immediate PRP should be the first one to be done. So, so it also showed us grid laser and focal laser. Now, the newer classification, that is International Clinical Disease Severity Scale for diabetic retinopathy. So it showed us, it classified into diabetic macular edema. Is it present or is it absent? And if it is present, is it mild, moderate, or severe? Mild, if it does not, if it is in the posterior pole but is distant from the center of macula. Moderate, but is approaching the center but not involving the center. And severe, that involves the center. Now, RCR net is the multi-center, as we all know, clinical research initiative. What is so important about this is it gives us high quality collaborative clinical research, and its principle is to improve vision and quality of life. It has been conducted from 2003 onwards to 2022 ongoing, 38 multi-center studies and 124 publications. These were the completed DRCR net protocols, and these are the ones ongoing. So so coming to a practical treatment protocol, what we would do is what is relevant to us and what can we use in our day-to-day practice. That is what we're looking at. So I'm picking up certain trials that I feel will help us in our current treatment protocol. So in 2008 came protocol B. Over 2 years, they said that focal or grid photocoagulation is more effective and has fewer side effects than 1 milligram or 4 milligram triamcinolone. So focal and grid is effective. It does treat macular edema, but it is better than triamcinolone. That is what protocol P told us. But 50% still had evidence of central edema even at 2 years. Now, what about 2007? What about peribulbar triamcinolone? It is not effective in cases with DME with good visual acuity. And this is what protocol E told us. 2015 came protocol R. That is, do we use topical 0.1% nepafenac? In cases with non-center DME and good visual acuity, maybe this does not have a meaningful role on OCT measured retinal thickness or on visual acuity. So we have a non-center involving DME. There is practically no point in giving topical nepafenac. That is what protocol R told us. Now, vitrectomy, as we have heard, diabetic macular edema with vitreomacular traction. What about vitrectomy? Yes, it helps us in reducing macular thickening, but the visual acuity results were less consistent with some eyes. This is what protocol D told us. Now, the landmark protocol I. This is what changed. So at that time, around 2010, all of us were going towards intravitreal injections, but we needed more evidence on this. So this is what it gave us. 2010 protocol I, it compared intravitreal sham injections with prompt laser versus intravitreal ranibizumab 0.5 milligram with prompt laser versus ranibizumab with deferred laser at 6 months and triamcinolone with prompt laser. So 854 eyes were studied, and in this trial, ranibizumab was found to be superior to focal laser in DME. They were the four arms. So when sham injection was given with focal laser, within 3 to 10 days of injection, the focal laser was given within 3 to 10 days of injection, monthly sham for 3 months, and then PRN was given. So sham injections were given monthly for 3 months, and later PRN as and when. Similarly, with the ranibizumab arm injected and then focal within 3 to 10 days, and monthly ranibizumab for 3 months, monthly, and then PRN. The one with ranibizumab with deferred injection, the focal laser was deferred beyond 6 months later. That is, the 6 months, no focal laser was given. Then again, monthly for 3 months. And the triamcinolone was given, and it was given first injection, focal laser, and after 4 months only was the injection repeated. So when we look at the data, this is the these two arms refer to the ranibizumab arm. The one is with deferred laser, the other one is with prompt laser, and these are the arms showing sham injection and triamcinolone arm. So what it showed us at 1 year compared with sham or prompt focal laser and the triamcinolone or prompt focal laser group, the intravitreal ranibizumab with prompt or deferred laser focal growths showed better visual acuity scores from baseline. The 2-year visual acuity outcomes were also similar to the 1-year outcomes. Intravitreal, so protocol I told us that intravitreal ranibizumab with prompt or deferred laser is more effective. This gave us the monthly ranibizumab monotherapy. It all helped us to move away from the focal laser and go more towards a monthly anti-VEGF treatment. What did the 5-year extension show? It showed us that the deferred laser arm may be even better than the one in which prompt laser was given. A subset also showed that xerophakic eyes appeared comparable to triamcinolone with prompt laser and ranibizumab groups. So that was protocol I. So now we know that we should go from focal to anti-VEGF injections. What did protocol T tell us? It told us which drug to select. So in this 2015, central involved diabetic macular edema in eyes with visual acuity of 2030 to 2320. That is from good vision to poor vision were included in this trial. 2 milligram intravitreal aflibercept, 1.25 milligram intravitreal bevacizumab, and 0.3 milligram intravitreal ranibizumab was given. So injections in this study, this protocol T, was given at every 4-week visit for 6 months until it improved or worsened. So what is improved? Improved means any greater than 5-letter change in ATDRS chart or less than 10% CST or greater than 10% CST change on OCT. So if the OCT comes down and the vision comes up, that's improved. If the OCT does not improve or is having a less than 5-letter change, that would be worsened. So if either of these are present, we have to continue injections. Suppose the vision is 20/20 or better and OCT strength is below 250, the CST is below 250 microns, at or after 24 weeks, we can stop injections. This is what they told us. Or if the visual acuity and the OCT stable of the past 2 consecutive injections, at that point, we can stop treatment. Rescue or focal laser was also initiated at or after 24 weeks only if persistent DME is not improving after at least 2 injections after 24 weeks. So the group studied were aflibercept versus bevacizumab, aflibercept versus ranibizumab, and bevacizumab versus ranibizumab. These were the 3 groups studied. So when we looked at vision with 20/50 or worse, we looked at these arms, we found that the aflibercept had a plus 18.9 letters more improvement in terms of visual mean change in visual acuity score than ranibizumab and bevacizumab. This was at 52 weeks or around the 1-year mark. And when we looked for 2 years, that is of the worst vision, that also shows that aflibercept is better, but the ranibizumab is catching up. But the aflibercept is still better than bevacizumab. This is what poorer vision intravitreal injections told us. What about patients with 2032 to 2040 or better vision? When we looked at the mean at the end of say 1 year, they seemed comparable. And what about at the end of 2 years? They were still comparable. So at 2 years, there was no difference, and with ranibizumab, at 1 year, aflibercept performed better than ranibizumab. Definitely, both of these perform better than triamcinolone. This is what bevacizumab. That was what was given to us by protocol T. So visual outcomes, so if it is with better vision, the visual outcomes were similar among treatment groups for eyes with baseline good vision. So now we know which drug would we prefer when we start injections. What is protocol B? So when we think about in 2019, should we treat an eye which has a center involved diabetic macular edema and a visual acuity which is good, which is 20/25 or better? So at that time, what do you choose? Do you choose an anti-VEGF? Do you give focal or grid laser, or do you do observation? So the data that is at 2 years with a greater than 5-letter loss showed that they were comparable. There were really not much difference between any of these groups. So among eyes with CI, center involving macular edema and good visual acuity, there is no significant difference. And observation without treatment, unless visual acuity worsens, they may be a reasonable strategy for center involved diabetic macular edema. Now we know what to treat and when to treat. What about, can we prevent this? That was the next question asked. That is what protocol W tried to answer in 2021. This is to determine the efficacy of aflibercept versus sham in preventing progression of PDR or DME in eyes with moderate to severe NPDR without DME. So basically, is there a side-threatening diabetic retinopathy with diabetic macular edema developing? What did we see? So aflibercept versus sham. This is what was studied. We see that sham has a greater chance of developing diabetic macular edema or PDR in comparison to sham. This is at the 2-year mark and study is still ongoing. But what about the visual acuity? Actually, the visual acuity shows not much gain in both of these groups, they remain. So does this justify starting aflibercept to prevent diabetic macular edema when the visual acuity is not much affected? That is a question that remains to be answered. Now, Protocol S in 2015 gave us a treatment of intravitreal ranibizumab versus PRP over 2 years of PDR. Thus, what is relevant? If the patient has PDR with DME, maybe ranibizumab monotherapy may be a good treatment approach. In India, with the concerns and the multiple injection, how far we can go forward with this still remains to be seen. Now, short mention on some trials, Protocol G, 1/4 or 1/2 of eyes with subclinical DME, that is DME that is not clinically seen, only detected in OCT, how will they progress? There seems to be an increase in definite thickening at 2 years. It is seen. So subclinical DME seems to be progressing a more clinical DME. What about Protocol G? When we are doing PRP with DME treatment, that is, if they were given focal or grid, if you add an intravitreal triamcinolone or ranibizumab, it seems to be beneficial both for the visual acuity as well as decreasing macular edema. Protocol Q, in eyes with DR without concurrent center involved DME, presence of non-central DME immediately prior to cataract surgery. That is, if they have a non-center involving diabetic macular edema and patient is going for cataract surgery, would you give injections? Yes, it would be better to consider treatment either before or after, because the history of this may increase the chance of developing a center involving macular edema. This is what Protocol Q told us. Now, the new kid on the block, as I've said, brolucizumab. So in Kite and Kestrel, they compared brolucizumab 3 mg, 6 mg with aflibercept 2 mg. So what they showed was brolucizumab 6 mg showed a robust visual gain and anatomic improvement. This may be an alternative, a newer drug for us to use in DME. Just rush through the ride and rise. So it gave us ranibizumab as a major frontline therapy. Reed gave us the multiple the doses, as well as which there was not much difference in whichever dose we use. 0.5 mg is fine. Restore showed that aggressive first-year treatment reduced the number of injection, along with the how to start PRN injections. So now we have this whole studies that tell us what to do. Now, practically, what is the treatment algorithm that we follow? So when we see a patient with diabetic macular edema, first we do an assessment, that is slit lamp fundus biomicroscopy. Look at the amount of macular edema. Is it mild to moderate? Do an OCT and look whether it is center or non-center involved diabetic macular edema. So non-center is defined as thickening above the threshold of around 320 microns and a central subfield thickness that is less than normal. So this is a non-center involving diabetic macular edema. So at that point, we will look whether the vision is good. If the vision is good, we just will observe without treating. But if there is a drop in vision, to consider fundus fluorescent angiography, look at the leaking microaneurysm, treat with focal laser. So now, what if the patient had a center-involved diabetic macular edema? We will look whether the vision is better or a good vision. So in which case, again, we will do an observation only. What if the vision is worse? That is when we will start anti-VEGF therapy with the various drugs available to us commonly right now. 0.5 mg ranibizumab, 1.25 mg bevacizumab or aflibercept. So initially, we start the treatment with monthly doses for 3 months. Then we assess 1 month after that, and we'll look whether the DME is worsening or improving. As we know, the OCT greater than 10% decrease or visual acuity greater than 5 is said as DME is improving. So if indeed a DME is improving still till it gets to a stable vision, we will re-inject and return in 1 month. Suppose it has remained stable, that is, there is no change over the last 2 consecutive injections, that is when we will not inject, but we will keep reassessing in 1 month to see if DME will worsen or recur. If so, we will keep on injecting. So what happens if there is a recurrent DME after completing? What has been recommended is to keep continuing the injections till we get a progressive decrease in EST. What about non-responders? The most common cause for non-response is possibly an inadequate treatment as per the above protocol. But if there is persistent DME and vision is less than 612, you can consider a switch to another anti-VEGF injections. When do we start steroids? So when there is response to anti-VEGF, but it is difficult to maintain follow-up, that is when I would consider pseudophakic patients with a persistent fluid, patients who have persistent edema and they are needing cataract surgery, occurrence of a systemic vascular event or associated features such as extensive hard exudates and presence of hyperreflective dots and eyes post-vitrectomy. Rescue laser, as has been given to us, will be done now with persistent CME with visible microaneurysms, or if a switch to steroid is not possible. Vitrectomy would be considered, as I mentioned, recalcitrant DME. They may benefit from vitrectomy surgery. Thank you.
Thank you, Gana, for that wonderful. You covered the protocol very well. I think it's a real eye-opener for all of us. So I'll just quickly go through our panel discussion. I now invite Dr. Unni, Dr. Manoj, Dr. Ashok, and Dr. Rajesh, in addition to our speakers, to join us on our panel discussion. I hope my screen is visible. I'll just share some common clinical scenarios. We have had Rahul talking about the basic pathogenesis and newer understanding of newer molecules, and Dr. Sunil talking about imaging biomarkers, and Gana giving us a good protocol for the disease. But there is a big gap still between what, as a clinician, you daily face, because many of the issues are not addressed in most of these clinical trials. We don't know, because most of the clinical trials enroll patients when vision is only below 6/12 or something, other than protocol V, of course, which Dr. Gana showed. And we don't address the systemic, because most of the trials enroll only patients who are HbA1c better than 9. So, but we face patients who are always HbA1c. So what is the role of systemic status of the patient? We don't look at PVD, whether PVD is present or not, is it going to affect our management? So these are things which are not looked in clinical trials. So there's a big gap there. So I'll just go through some of this. This has already been addressed by Dr. Gana. We have all the panelists here, no, Dr. Unni? Yeah, Dr. Ashok. So I'll just give you a few clinical scenarios. This was a patient with vision is 6 spots and center involving macular edema with 350 microns. So I would ask Dr. Manoj, because Dr. Gana was telling as per protocol, we have 3 options. We can either observe, we can treat with lephocalizer, or we can inject. So what would you choose, Dr. Manoj, in such a scenario?
In this patient, the visual acuity is good, is very good, 6 spots. And even though the central foveal thickness is thicker, the visual acuity is good. So directly there is, I wouldn't consider giving anti-VEGF, but I would also look at other characteristics. I would try to understand if the patient, one thing is like the patient is one-eyed, how the other eye of the patient, or like, and also how the systemic control of this patient. Does he have any other disease, comorbidities, which can worsen the macular edema, like hypertensive or nephropathy? So I would look at all of these, but I think I would start off by being conservative and educating the patient. I mean, that is what I would be doing, educating the patient that he is very likely to worsen, and then following up closely and decide on anti-VEGF.
What will be your follow-up protocol?
In such a patient, I would.
If you decide to observe this patient, what will be your protocol?
I'll probably call him on a monthly review initially, at least 1 or 2 months initially, to understand how. Well, it could be something acute has precipitated this macular edema. So that if that is the case, over the next 2-3 months, when I see him monthly, and I can understand that it is worsening rapidly. Or it could be part of a little older process now, which we are seeing at this point of time.
Yeah, that's really important, because protocol we also use similar follow-up pattern, initially 1 month, then extended 2 months, then 3 months. So if it is very important that you follow up closely these patients, if you decide to observe, you may have to. Now my second part is, if this patient is symptomatic for vision, patient is complaining of some symptom, metamorphopsia or something, would your observation pattern, decision to observe change, or would you like to address the symptom, Dr. Manoj?
No, I think I would still stick on to them. In spite of the patient being symptomatic, I think I would still give it some time, because I would also look at the flip side of anti-VEGF. What if he develops cardiovascular, even though it is not strongly associated, what he develops and something like this. So I think considering all the ocular events and other systemic events, I would still be conservative even if he's symptomatic. And unless there is a documented vision drop, I wouldn't think of injecting.
Thank you, Dr. Man. So this was other aspects which I wanted to discuss, but already has been covered. If he has a poor systemic status, we may favor sometimes background retinopathy. If a patient already has a severe NPDR, will it affect your management, Dr. Manoj?
Severe NPDR, no, if there are no other criteria and I would decide not to do a pan-retinal photocoagulation, if I would just, if I'm planning to just observe him, then it would be the same. But if I'm planning to do an pan-retinal photocoagulation, I would warn him that his macular edema is going to increase, and therefore now we may have to be more aggressive in managing the macula post PRP. Regarding HbA1c, I know that there is the data is a little confusing. We have the RISE and RIDE, which have shown that there is no relationship to HbA1c. They had patients up to 12, which were part of the study. But then we also had the Vivid and Vista, which talked about the beneficial effect of good control, especially with aflibercept. So that's a little confusing area. But generally, I think all of us would convince our patient to have better HbA1c levels, not only for the macular edema per se, we are also thinking in terms of the background diabetic retinopathy, which can worsen.
Thank you. Any other panelists have any other take on these issues?
I think, many of these patients with macular edema, it's a good idea if you give a home amsler to them, and, and they can only monitor their visual problems. Many times they may not recognize. And if you call them after a month and ask them whether you have distortion or something like that, and if their symptoms are severe, I think it's worth treating them.
So we'll move to the second scenario where I have a patient whom I was injecting, and the patient now starts developing a small epiretinal membrane here. So Dr. Rajesh, still you would like to go ahead with injection, or do you think of vitrectomy at this point of time?
When you have a vitreomacular interface problem, then this edema is very unlikely to go away with injections alone.
This was happening. Actually, edema was worsening after injection.
So I think that anti-VEGF agents definitely is not going to work most of the time. Maybe my first option, I would always like to do a surgery in these patients, but then the patients are not willing to accept surgery in the first go. So I may give an intravitreal steroid injection a try, because my observation is that when patient has got vitreomacular interface disorder like an epiretinal membrane, with steroid sometimes the edema goes away. And if still doesn't go away, then you can convince the patient regarding the need for surgery. So surgery maybe after 1 injection or 2 injections.
So I also gave an intravitreal steroid, but now you can see that temporarily there is that vitreous detachment now. It is the temporal side. So Dr. Unni, at this point of time, you would go ahead with surgery?
Yeah, probably it's a surgical decision of this. What was the vision of this patient?
I think some 636 or something. I'm not.
Yeah. So when we had evidence of non-response to anti-VEGF, when you have evidence of the formation of a structural change in the retina, surgery is an option. There are 2 considerations that we have to do. This wouldn't be an ideal patient to do an OCT angiography for the foveal vascularity before any decision on surgery, point number 1. And point number 2, is there any indication for steroids after surgery? Because you will often need to have some agent to reduce the residual edema after you do a membrane peeling. So, and as we know, after a vitrectomy, the longevity of anti-VEGF is less. So I have had patients who have had advanced discs where we had to do this, and then we were stuck for not being able to put steroids after the surgery. So as a practical point, looking at what drug you are going to use post-vitrectomy is one point. The second point, the vascularity before an epiretinal membrane removal.
So during vitrectomy, will you peel the ILM, or if at all you peel, will you do a fovea sparing?
It all depends. The point is, it all depends on how critical the fovea is. If there is a large cyst at the fovea, then we have no other option other than to do a ILM sparing peel. but often we do not have any control. The moment these are not membranes that come off like idiopathic membranes. When you start peeling on one side, sometimes you do not have control over what you peel, because it is a mixture of the posterior hyaloid, a formative membrane, and the ileum is one tight structure.
If at the end of the surgery, do you give an intravitreal injection, steroid, or what is your preference, anti-VEGF?
Yeah, sometimes we utilize IVTA during surgery. In that case, I make sure that a little is left inside. I do not usually actively put a lot of IVTA inside after surgery.
Okay.
I think the
Post
most
surgery, this patient had a Manoj.
No, I was just saying the most important thing would be to rule out macular ischemia, because some of these, sometimes when you have central perceptual cysts, these are eyes which have a strong association with macular ischemia. So before we talk about surgical option, I think that is something that we need to do.
So if this patient actually post vitrectomy, improved macular edema, then had a recurrence. Now in a vitrectomized eye, what is your drug of choice? Is it steroid or anti-VEGF? Anti-VEGF has theoretically has a higher clearance rate in a vitrectomized eye, so may not have a desired effect. But also there are studies which show that once they block the receptors, there is no issue whether they remain inside the eye or not. It doesn't matter. So will you go for steroid in such a case? What is your take?
Can I take this?
Yeah, take one.
Yeah. So practically, there is one mindset that we have to change, that you have to give anti-VEGF every month. There are places, there are people who have protocols of giving anti-VEGF every 2 weeks, and in a vitrectomized eye, if you see escape from, you can afford to give it a week earlier, give it at 3 weeks also. But my drug of choice would be a DEX implant.
Is there a risk of migration in a vitrectomized eye for an implant? Especially pseudophakic eye.
Pseudophakic eye, yes. I mean, if a wonderful cataract surgery has been done and the PC is intact, it is unlikely. But yes, it has happened. It is not unheard of. Another complication that that we have to keep in mind is that there is. I have had a patient who has had a hemorrhage after the DEX implant, in which the force or the direction was such that it has probably hit the retina or a vessel inside. So whenever you do it in a vitrectomized eye, it's always good to have a look inside immediately after you inject it inside.
Okay, point well taken.
Migration is, I recently had a patient who underwent a scleral fixated IOL and vitrectomy for diabetic disease. And I put in dexamethasone implant for chronic macular edema. And this kept on coming, the small area superiorly. Some of these things, they've kind of flown up and they keep coming into the AC. And then we pushed it back through this opening back into the vitreous cavity. It broke into two, and then one half came back again. So sometimes this can be messy. So that is something that we have to keep in mind.
Yeah, I had one case where post vitrectomy OCT showed macular edema, and we gave intravitreal Osidex. After 3 weeks, patient came with a posterior pole break and SRF. Now I'm just postulating whether this implant has gone and hit the retina or something and created a break, and I had to redo a vitrectomy and put oil, and Osidex was still retained. So as you said, it's a very interesting observation.
What is your Dr. Ashok? What will be your treatment of choice for center involving macular edema? You still do focal laser?
Yeah, non-center involving macular edema, I do focal laser. But many of the non-center involving macular edema, like with all these studies, you can wait for the edema to come to the center and then give intravitreal injection also. That is also another option.
Dr. Manoj, any difference of?
I would agree with Dr. Ashok. I would do definitely a laser. I'm still a little old school. I still do a lot of laser. Even when I give anti-VEGF, I do give. I don't like protocol eye, because I basically think the protocol eye is flawed, because their early laser arm had too early laser. They gave laser in as early as 3 to 10 days. So that's the time that the macular edema don't go away. And considering the fact that they were all center involving macular edema which underwent this therapy, deferred laser obviously worked, and it was too much of a defer. I feel that now we should doing laser a little earlier could have done that. I think the Asia Pacific guidelines say that no, you should be thinking of doing laser by around 3 to 4 weeks after anti-VEGF therapy. So I think I would definitely do laser in this situation, and even in center involving, add laser whenever there is a chance.
This is another scenario. You have lot of microaneurysms, hemorrhages close to macula, but OCT is totally normal. There is no thickening. There is no indication to treat. But this patient is undergoing a cataract surgery. This patient needs a cataract surgery. So will you give a prophylactic injection along with cataract surgery, or you will wait for edema to reappear? Dr. Ghana?
Hello, sir. Yeah, so in this case, because I'm seeing a perifoveal thickening, I would go ahead and
Assume there is no thickening. Assume there is no
there is no thickening. Then no, sir. Then I would not go ahead and inject. I would just educate the patient at this point that there is a high possibility of developing. We'll keep a close follow-up, good glycemic control, and then go ahead with that treatment there.
Will it change if you have the patient has a poor glycemic control or patient has another eye with chronic DME already? Will your decision change, or will you still observe this patient? You won't inject?
Along with yeah, possibly if he has a chronic DME in the other eye and his status is not going to improve, I will still give him the option. I will probably just give him the option and then continue to treat after he does.
Any difference of opinion among panelists?
I think more important would be to look at how this patient is doing before this. I mean, if there is a history of patient having a central and involving macular, he was treated, and this is like a post-treatment state. Versus now somebody named who's coming to you for the first time. So the management would differ based on this. I would still agree with Dr. Ghana that I wouldn't want to give unnecessary injections. Whatever the trials may say, that I think he did mention about a trial where this thing. I also know that there is a meta-analysis which have shown that at least 5 trials have shown that giving an anti-VEGF earlier on in these paramacular edemas. Where there's a known documentation of progression to seeing helps. But in practice, I think we should refrain from over-injecting these patients. We could actually educate these patients and follow them up and then take a decision based on the first topic.
In a PRP eye, we know that already PRP has undergone and there is a macular edema there sitting there. How will you your approach? Because it's going to be very difficult to treat. We know the response is very poor. Unni?
No, see, whenever we look at macular edema, we have to keep in concept there are 2 mechanisms basically. One mechanism is a focal cause of macular edema, and the second mechanism is the global effects inside the eye of anti-VEGF. The laser has been done, the anti-VEGF suppression has already been started, but that in this particular patient, you can say it is not enough. So we treat this like you would treat this like most patients with DME and give anti-VEGF for this patient, irrespective of the laser you have done. Now, the point here and all throughout this discussion, one of the things that we have not looked into is peripheral vascular lesions and peripheral neovascularization and their effect on causing an anti-VEGF surge. So that would be an additional point to look at when you have persistent edema after laser. The second point is, as I said, the focal lesions. Now there is a whole new concept of retinal capillary macroaneurysms, focal posterior pole neovascularization that can cause significant edema in the posterior pole. Whatever the status, the diabetic retinopathy status, be it be PDR, let it be status post PRP. So considering macular edema as having a focal cause and a global cause would be a very nice mechanism to establish treatment protocols. In this patient, it's quite obvious that the patient needs anti-VEGF further therapy.
The last question to Dr. Sunil, with PR with macular edema, will you start PRP first and inject, then inject, or injection first followed by?
Yeah, since the macular edema is showing a significant SRF there, first look at the systemic parameters. How is his systemic status? It was all under parameters were under control?
Assuming it is controlled.
Yeah, if then that is the case, then I'll go with an intravitreal injections first, try to control the macular edema to the extent possible. Unless it's an high-risk PDR, then probably I'll go with the laser as a second sitting rather than the primary.
Any other thoughts, Dr. Manoj or Dr. Rajesh?
I would inject because anyway we have a lot of data on anti-VEGF in PDR. So taking clue from that, now giving an anti-VEGF here takes care of both the problems. So
Okay.
I would definitely start off with an
So not start off with anti-VEGF and then follow up with the
Yeah.
PRP. So some studies also show lesser number of injections needed when you start off with anti-VEGF rather than starting.
I think,
So
Dr. Prakash, we are overshooting the time.
Yeah, I know. I'm just concluding, so that's all. We thank you all the panelists. Sorry for overshooting a bit on the time, and I think it was useful for all the practitioners of diabetic macular edema. Thank you all. Thank you, Srini, and thank you, Gopal.
Thank you. Thank you.
I now invite Dr. Biju to take over for the next session, the proliferative diabetic retinopathy.
Yeah. Thank you, Dr. Ashali. Am I audible?
Yes, Biju.
Yeah, okay. So welcome all to the next session on proliferative diabetic retinopathy. So I'll be just sharing the screen. Okay. So well, first at the outset, I will thank Sushila Madam, Thomas George, and Dr. Ashali for having me here. And let me introduce our chairperson of our session, Dr. Thomas Cherian, who is well known to all of us. He is a senior consultant in Retinal and Vitreous and Little Flower Hospital, Angamali, and he's also a senior consultant Retinal and Vitreous in Kochi, Eye Care Center, Aluva. And he's also very active in KSOS. We know that he's the vice president of Kerala KSOS, and he has occupied almost all the other posts in KSOS. He's also active in AOS, and he has won extensive awards both in the state as well as the national field. And he has published a lot of articles in most of the peer-reviewed journals. And he has done his Retina fellowship from Delhi Prasad Eye Hospital, Hyderabad. Then moving on to our speakers, we will be having Dr. Unnikrishnan Nair, Medical Director of Chaitanya Eye Hospital Research Institute, as our first speaker. He will be speaking on the role of imaging in proliferative diabetic retinopathy. He has completed his MBBS from Government Medical College Trivandrum, and he is a alumni of RIO Trivandrum, where he completed his MS and DO. And he took his VR fellowship from Shankar Nethralaya, Chennai, 2005. And he has won a lot of awards in the state as well as the national scenario, and has presented papers all over the country as well as in the international scenario. And he has got a keen interest in the retinal imaging, and we all look forward to his retinal imaging congress every year. He is an excellent CME where we all come away with a lot of information and a lot of updates. And the next we are having Dr. Divya Balakrishnan. She is a senior vitreoretinal surgeon currently working in LF Hospital, Angamali. She will be speaking on the pathogens of PDR, role of anti-VEGF in the management of PDR. She took her DNB in ophthalmology from LF Hospital, Angamali, and she is also widely publicized. I've got a lot of publications in national, international journals, and has made a lot of presentations in the state as well as the national scenario. And her main areas of interest are pediatric retinal disease, complex retinal surgeries like pediatric retinal surgeries, diabetic retinal surgery, include IOLs, etc. And the final topic will be on the surgical options in PDR, which will be presented by Dr. Vasumati Vedantam. She is presently working in Retinal Nethralaya, Chennai, Tamil Nadu, India. And her main areas of interest are diabetic retinopathy, AMD, narrow-P. And she has publications in almost most of the peer-reviewed international and national journals. And she has authored several chapters in several textbooks. She is also a principal investigator in an international trial on AMD. She has won a lot of awards, as we can see here. And yeah, and we are also having our own faculty as a panel discussion. We'll be having Dr. Mahesh G, who is a towering personality in the VR scenario in Kerala. He's also very active, our former General Secretary of the KSOS. That we have got Dr. Natasha Radhakrishnan. She has already been introduced. She's working in Amrita Eye Hospital and doing excellent work in retina there. And we're also having Dr. Sindhu as a consultant retina specialist in Lafangamai. I will hand over the session to Dr. Thomas Cherian for the rest of the proceedings.
Thank you very much, Biju. After diabetic macular edema, proliferative diabetic retinopathy is the sight-threatening diabetic eye disease. And most of us in our retina practice every day face a lot of cases of proliferative diabetic retinopathy, some which need laser, some which can go through injections. Many of them need a surgical treatment. And how do we investigate this diabetic retinopathy? What are the markers? Let us hear it from our esteemed panel. I'll invite Dr. Unnikrishnan Nair for his talk on imaging in proliferative diabetic retinopathy.
I hope the screen is visible now.
Yes, very much, Unni.
Okay, thank you. Thank you for the invitation. And we're just going to the talk about imaging in proliferative DR. See, one thought about it and you say, what is there to image in PDR? Everything seems to be very black and white, pun intended. So the current modalities that I would like to be discussing is the SLO-based photography, multicolor imaging, FFA and wide field, ultra wide field OCT and OCTA. So these are the basics. So all of us know that PDR essentially is a clinical diagnosis. In all the studies that we have done so far, there are well definitions for high risk, early advanced diabetic eye disease. And in all these images, all of these are images of PDR. We can see from the images there are areas of neovascularization in which you can clearly see the presence of neovessels, and here is the presence of an NV in a lasered eye. So for all practical purposes, when we see an image like this, there is hardly any need to further make any quantification about the disease. But if you see an image like this, in which you're not sure whether it is an SN PDR or a PDR, then it is a point where you go to the next step of evaluation. And one of the steps is to the use of a device called the multicolor imaging, or a CSLO-based multicolor imaging. Here you can see slightly different color codes where you see the attached retina being red in color. Anything elevated of the surface gets a green differentiation. And the advantage of a multicolor is that it has superior penetration because of the SLO through opacities. It can be used in undilated pupils. There is a different color understanding, and the eye tracking technology and the incorporation into multimodal imaging will help you do real-time comparisons with the OCT, OCTA, and the fluorescent platforms. There was an interesting study basically about the use of multicolor as a screening tool, and it had about a 77% effect of diagnosing the absence of NVD, and a worse result for the diagnosis of the absence of NVE. So per se, though being significant for diagnosing or discriminating the absence of NVD, it wasn't as good as NVE because with the multicolor, larger areas could not be distinguished. And sometimes it was difficult to differentiate between an NVE and an IRMA. So let's go to the FFA. The FFA, I don't want to spend too much time on the FFA per se, but it's a very classic appearance, the presence of, this is what we've studied since our postgraduate days, the presence of large areas of capillary non-perfusion with leakages which increase in the late stage, which are very classical of neovascularization. But this is what is capturing everybody's imagination, that is ultra wide field. So ultra wide field is defined as an imaging technique where you can get in the excess of nearly more than 120 to 160 degrees of capture in one field that is beyond the vortex veins in all quadrants while centering around the fovea. And this is what I'd like to say is important. In the early house classification, the ETDRS study circles, the study circles could capture only 35% of the retina, while currently with ultra field imaging, we can capture about 82% of the retinal area, which is extremely important. It's a very important image to keep in mind. And the latest new 3-zone classification of the retina is now divided as a posterior zone is a 10 mm circle. There's a mid periphery between 10 to 15 mm and a far periphery, which is anything beyond a 15 mm radius centered around the fovea. One of the most seminal studies that was done by Silva et al. Basically, they defined something called predominantly peripheral lesions, or PPL, which included microaneurysms, hemorrhages, leakage, and obviously neovascularization. And what it said is that these people had a 3 to 4% increased chance of developing PDR, especially. What does that mean? That when you go for your routine evaluation, your routine examinations, the possibility that you have missed these lesions and therefore missing a rapid progressive diabetic retinopathy. Another terminology used was by Oliver et al. Called peripheral vascular leakage, or PVL. So PVL also had an increased risk factor of retinal neovascularization. This is what PVL means. This particular patient had lesions centered around the posterior pole. It does not look like a PDR, but when you go to the periphery, you see vascular leakage from the peripheral vessels, and this particular patient would be at a high risk for evolving PDR in the near future. So as compared to a standard 7-field and whatever angiography we do, the ultra-wide field angiography detects double the amount of NV and 4 times the amount of non-perfusion areas. And on the whole, 17% of neovascularization was outside the purview of your regular angiography. This is a very, very telling statistic. So of the studies, again, the presence of identifying hemorrhages and microaneurysms as being the predominant peripheral lesions, all were more outside, that is nearly 4 to 5 times outside the typical ETDRS fields, which would be missed by a standard angiography. Counting the number of microaneurysms and hemorrhages, there were 21.3 times more chance of these lesions in the periphery, and these lesions, according to Srinivas had a greater distribution and more likely to progress towards PDR. Also assessing the total non-perfused area in the periphery and having an area more than 77 millimeters square was significant in the risk analysis for PDR. So why assess the peripheral retina? Contrary to some of the things we heard at present, it is not proved that peripheral retinal treatment or targeted retinal treatment of an ischemic peripheral retina has any role in DME management. I just took a screenshot of this is Dr. Sunil's slide he talked earlier, in which he has given absolutely the right things, except we are not very sure whether treating recalcitrant DME is possible by targeted laser in the periphery. So this is a common thought. A PRP is more durable than anti-VEGF. There are 2 studies on the contrary. One is a Clarity study and the Proteus study. In the Clarity study, most of the patients requiring who had PRP required additional PRP, and in the Proteus study, patients who had a combination of ranibizumab and PRP had better regression than PRP alone. What do both of these point to? Both of these point to maybe the fact that we are not picking up, or there is more sufficient non-perfusion in the extreme periphery, which could be contributing to escape of these patients from the control of PRP. And hence, an ultra-wide field FA guided anti-VEGF PRN regime is being evaluated now. The basic key line here is that we are under-treating PDR, and therefore more monitoring and more anti-VEGF on a PRN basis could be the key, instead of extensive, instead of laser, just in the mid-periphery. Coming to the OCT and PDR, this is a section through typical neovascularization, where you see an elevated frond sitting on the retina. And you can imagine that in a patient that you're not sure, here you can see it again through a typical front, you can see an elevated lesion in the ILM over there. But in this patient, which does not look like a PDR, you can also see that this has a small amount of pre-retinal tissue there, and this could be a PDR. Again, all these were just a few photographs that showing you the presence of a neovascularization, and what this looks on OCT is a clump of hyperreflective material associated with on the undersurface of the vitreous on the top surface of the retina. Coming to ADED, so for surgical decisions, we have all these mechanisms that come into play. On the color photo, you can see fibrous tissue and you see elevations, which help you take surgical decisions. Here, the surgical decision was this, the macular involvement and involving the fovea. Again, another patient, you see the fibrous tissue very clearly in the CSLO picture. You can see the elevation and stretching of the retina. Again, indication for surgery is a foveal involvement. Again, white tissue, the periphery seems there's nothing much damaging the periphery, all the tissue. This is like a crunch phenomena happening. The upper arcade is being drawn to the lower arcade because of the fibrous tissue. And again, here you have blood, you have back shadowing, but here also you see the beginning of a extremely high detachment component where the fovea is detached in this patient, and that's the indication of surgery. Here the threat is extrafoveal. You can see that the fovea is attached, but the fibrous tissue is encroached in the arcades and the retina at the arcades. So here the indication would be a macular threat, though extrafoveal is it could progress to the fovea pretty soon. And these are other similar cases, and I would like to show you this patient in which the fovea seems attached, but if you go superiorly, you'll see the configuration of the retina on the OCT, which the convexity shows that it is likely to be a regmatogenous component or a combined retinal detachment mechanism. So now coming to the OCTA, this is a beautiful picture showing all the vasculatures using the angioplex. And this is a very telling picture in which this is a patient who has no diabetic retinopathy, but you can see the amount of non-perfusion areas or the amount of dropout on the left eye on the OCTA, which tells you a lot. This is how you can use the OCTA instead of FFA. You can see a beautiful front. Again, you have the flow correlation over here, and you see the tissue on top of the retinal surface. And these are all examples of small NVEs that are picked out purely on the OCTA. This is a larger NVE on a major arcade. And this is the angioplex, which has a larger view. This is an 18:8 slab. And you can see in the periphery of the slab, you have all these small neovascular tissue. And again, you see a large neovascular tissue. This is how it looks like, with the flow on the surface of the retina, on the ILM area, pre-retinal area, which tells you that this particular vessel is pre-retinal or sub-ILM in location. So identifying IRMA may be slightly more difficult on the OCTA. They look like loops or dilated vessels near the areas of choroidal non-perfusion. And this is the importance of the differentiation between the neovascularization is that you will see disruption of the ILM with a flow signal above the retina or above the ILM. That's how you differentiate an NVE from an IRMA. Sometimes the OCTA has advantages, like in the presence of, in an FA, the leakage would obscure the size and the shape of the NVE, which can be picked out of OCTA because you're seeing just the vessels and no leakage. These are images I've got from Dr. Darius, which are on the plexolate. You can see there's a color coding in which you see the orangish lesions are the lesions that are elevated from the surface. Here you can see a beautiful montage where you see retinal vessels, and the purplish lesions are the NVE elevated from the surface. So the use of the OCTA in monitoring the treatment response to DI would be to monitor the regression of the neovascularization. And sometimes you can also see the choroid capillary density increases after anti-VEGF therapy. On the top pictures, you can see the color-coded the lesions on the FA and the lesions on the NVE, and after laser and anti-VEGF, the proper with PRP, you can see proper regression of the lesions. As you can see in this particular lesion, you can see thinning out of the pre-retinal tissue on the structural OCT. Again, here I'd like to point to you picture B, in which you see flow signals in the tissue, the pre-retinal tissue, and after lesion, there is no flow signals, which show that there is regression of the NVE. Here, this is another picture to show the flow signal, which is regressed after laser, and another picture to show you that the major coils and small vessels have gone away. Assessing the FAZ is also a part of the PDR assessment, because the larger, sometimes the larger FAZ irregularities associated with the worst type of diabetic retinopathy. There's a new classification for NVE, which is divided into type 1, type 2, and type 3. Type 1 is loosely held on the hyaloid surface, and it's on the venous side. Type 2 is a capillary network neovascularization, and type 3 is an erythema progressing through the retinal tissue, strongly attached to the vitreous into the pre-retinal space. So the takeaway messages would probably be that we are currently underdiagnosing PDR, and ultra-wide field will help us diagnose people with 15% more chance NVE or peripheral lesions. Second point is we are undertreating PDR, in which the incidence of the retinopathy level is nearly 15% more when you use an ultra-wide field imaging system to characterize the neovascularization. There are newer morphological characteristics of NVE which have different outcomes. The chances of having more fibrous tissue formation, the chances of having larger bleeds or anterior segment bleeds are there. There's a newer disease concept in which we could say that there is a peripheral component to the disease which we are currently not taking into consideration, which may have an effect in both DME and PDR. Even the risk of a post-vitrectomy bleed can be higher in eyes with a greater peripheral lesions. And there are newer treatment concepts like targeted retinal photocoagulation or ultra wide field FA guided anti-VEGF treatment. So with this, I'd like to say that the imaging is just not simply identifying the white on the black in an FFA, and now we have a lot more tools. Again, thank you for a patient listening, and I'd like to extend image courtesy to Dr. Manisha, Dr. Darius, Dr. Rahul, and Dr. Indu, who have helped me with this presentation. Thank you very much, and for a patient listening.
Thank you, Unni, for taking us through a wide range of cases and images. Since our panel discussion might have to be cut down for paucity of time, let me ask you one question before we go to the next talk. Many a time we see in our day-to-day practice, proliferative diabetic retinopathy patients who have been lasered, PRP has been done, and they report to your OPD. The PRP might not be to your satisfaction, it might not be tight enough, and you always have a tendency to fill in the PRP. So at this point of time, would you do an imaging? If so, what is the imaging and what do you look for before you tighten the PRP?
So I would probably look at two things. One is that if the PRP is obviously very loose and very, sparse, or the marks are not good enough, the imaging becomes a slight moot point, because if there's a rebleed, there's an indication that there's an NV. Now the only question I would be asking myself is that, is this truly an unstable PDR or is it a PVD induced bleed? So if in a tight PRP also, once the PVD comes off, there could be a tug on the blood vessels and you can have a bleed. So this is a question I would be answering. If the nature of the PRP or the strength of the PRP is not enough, I would add. And if I have any doubts, I would definitely go for imaging. And now currently we have wide field imaging, and that would be the way I would go.
Thank you, Unni.
Thank you.
For of time, we'll go to the next talk. Let me invite Dr. Divya Balakrishnan. She's a consultant vitreoretinal surgeon from Little Flower Hospital, Angamali. I invite Dr. Divya for her talk on pathogenesis of proliferative diabetic retinopathy and the role of anti-VEGF in treatment of PDR. Over to you, Divya. Divya, are you unmuted?
Yeah, can you hear?
Yes, please.
Yeah, at the outset, I would like to thank Dr. Thomas Cherian and KSOS for giving me this opportunity. So I'd be discussing about anti-VEGF in the management of proliferative diabetic retinopathy. So around 6.1% of the patients who has diabetes can have vision-threatening diabetic retinopathy. And proliferative diabetic retinopathy is characterized by development of new vessels on the retina or the optic disc. It may be associated with pre-retinal or vitreous hemorrhage. And it also may be associated with tractional or combined retinal detachment. The key predictor for the development of these new vessels is the total area of retinal capillary non-perfusion. And this may lead to the production of factors like VEGF, which is a key angiogenic agent that stimulates retinal neovascularization. In the management of proliferative diabetic retinopathy, any diabetic retinopathy, the first thing is the control of the systemic factors. And coming to proliferative diabetic retinopathy, the gold standard or the standard treatment of PDR has been pan-retinal photocoagulation. And this is from the evidence by diabetic retinopathy study, which showed that PRP in PDR and high-risk PDR reduced the severe vision loss in more than 50% of the patients by 2 years by treatment with PRP. PRP actually does what? It destroys the photoreceptors, which are the metabolically active cells, and it reduces the need for oxygen consumption, which reduces the induced hypoxia. And hypoxia is one of the factors which causes release of VEGF. So thus it downregulates the VEGF and results in regression of PDR. But it comes with the cost. The common complications of PRP is it causes permanent peripheral vision field loss, decreased night vision. It may cause secondary membrane proliferation and the worsening of diabetic macular edema, especially in the immediate post-laser period. And even despite timely treatment with PRP, 5% of the eyes still can lead to severe vision loss. So is there any alternative to pan-retinal photocoagulation to overcome these problems? So there comes the role of anti-VEGF, as VEGF is one of the factors which is responsible for these changes. So we need to see whether it works better. Does it cause any disease modification? Whether it causes any changes in the visual outcomes or DR complications? Does it preserve the peripheral vision? Does it has an additional role when we treat it along with diabetic macular edema? So various trials which have looked at the role of monotherapy of anti-VEGF or in combination with laser. And the first one, after which we started using anti-VEGF for the treatment of PDR is Protocol S. So here it looked at the comparison between ranibizumab of a monthly injection with a PRP, and initial 3 months monthly injection were given, and subsequent 3 months, if the NVE was still persistent, the subsequent injections were given. And if no active NVE was present, at least for the last 3 visits, then the injections were stopped. On reactivation of neovascularization, 2 more injections till the NVE regress was considered. And what it showed was, on follow-up of 2 years, 93% of patients who underwent ranibizumab attained a sustained stability. That means like they could stop anti-VEGF injection at one point of time. And of these, 16% of the patients did not receive another injection over 2-year period. But of these patients, 62% of them, after stopping the injection, required re-injections once the injection were deferred on a follow-up of at least 16 weeks. And to compare between the anti-VEGF and PRP, so this group actually included patients with diabetic macular edema and PDR. So those patients who had diabetic macular edema, almost 14 injections were required over 2-year period, and without diabetic macular edema, 10 injections were required. And you could see that the complications in group which received anti-VEGF injection was less, which requiring the vitrectomy, that was only 4%. While in PRP group, it required anti-VEGF in 15%, either for worsening of neovascularization or because of associated DME. And the risk of vitreous hemorrhage was again less in anti-VEGF, but still it was 27% in anti-VEGF group, and it was 34% in PRP group. And you could see that the tractional retinal detachment occurred in 6% of patients with anti-VEGF and in 10% with PRP. So hence, from this study, it was shown that anti-VEGF was non-inferior to pan-retinal photocoagulation in treating PDR. And in ranibizumab group, there was an improvement in best-corrected visual acuity, reduction in the diabetic retinopathy severity, and occurrence of less of vitreous hemorrhage or the need for vitrectomy. So this recommended use of anti-VEGF for proliferative diabetic retinopathy. Now, from the study, actually, we looked at what we do if the diabetic PDR has a center involving DME. Then anyways, you will be treating the patient for DME with anti-VEGF. Hence, anti-VEGF monotherapy works better in those conditions. When there is a non-centrally involving diabetic macular edema, again, anti-VEGF can be considered as a first-line therapy as it reduces the chances of diabetic macular edema or secondary complications. When there is no diabetic macular edema and only PDR, then both the options can be considered, even though the anti-VEGF results by this 2 years, it has shown that it causes less field reduction or improvement in the visual acuity. But in coming to the cost consideration, PRP actually is good enough to control PDR when there is no evidence of diabetic macular edema. But we need to keep a watch on the systemic, even though the studies have shown that no significant systemic risk factors are there, still we need to take a special concern in these patients. So to put it into a clinical practice, after 3 injections, you assess the patient after 1 month of 3 injections. And if there is still neovascularization, then you have to re-inject and ask the patient to come after 1 month. And if there is regression of neovascularization, then you need not inject and call the patient after 1 month. If there is a recurrence, then again you need to re-inject. And if there is no recurrence, you can double up the follow-up. So over 50% of the eyes had resolution of neovascularization by 6 months. So we should keep in mind that of the patients, only 50% had complete resolution of neovascularization. And on follow-up, it was seen that only 7% of the eyes had lost more than 15 letters. These were a few examples how the anti-VEGF had affected the neovascularization. So in the upper one, you can see it has resolved. The second figure, it shows that the neovascularization regressed, but there was a persistent fibrous tissue. And you can see that in the third one, the NVD has remaining stable with no treatment over 1 year. And in the last one, you can see that NVD has worsened. So it showed that anti-VEGF was better in treating PDR. Now look at the outcome of the same group after 5 years, comparing pan-retinal photocoagulation and anti-VEGF. So 46% of the participants in the ranibizumab showed group reduction of 2 or more steps in diabetic retinopathy severity scale at 5 years. And 75% of the eyes still received at least 1 injection each year through 4 years, and 63% still required 1 injection even in the 5th year. And by 5 years, 37% of the eyes in the ranibizumab group did not require any injections. But the total number of injections over 5 years in ranibizumab group was 19.2 when compared to 5.4 in PRP. And the probability of developing vision impairment DME by 5 years was 22 in ranibizumab when it was 38 in PRP. But when we look at the visual acuity improvement, which was achieved with anti-VEGF at 2 years, when you look at the visual acuity improvement at 5 years, the marginal gain or the improvement which was seen with the anti-VEGF was not seen at 5-year follow-up. So in both the groups, the visual acuity improvement was comparable between these two groups. And when we see the one of the advantage of anti-VEGF considered was the preservation of the peripheral field. So when we looked at the visual field in these two groups, the advantage which had at 2 years, the visual field loss and on an average progressed in both the PRP and ranibizumab group from 2 years through 5 years. So the difference between these groups in this aspect was also reduced. So this the protocol has looked at ranibizumab and PRP. Now Clarity was the next trial which looked at aflibercept. In this, they looked at the regression of the neovascularization and the best corrected visual acuity improvement. So this showed, but in the study, they excluded patients with diabetic macular edema, but they included patients who were previously treated with PRP, but still has active NVE, which require either a PRP or anti-VEGF treatment. But this showed that aflibercept was non-inferior and in fact superior to PRP in achieving the best corrected visual acuity by the study. And almost 50% of these patients included in this study had previously received PRP before the treatment. And at 52 weeks, the mean injection number of aflibercept was 4.4, and whereas 65% in the PRP group required supplement PRP, which was 1.17. And in those patients receiving PRP, 31 required more sessions. So from this trial, aflibercept was found to be superior to PRP in improving BCVA and also non-inferior to PRP in regression of neovascularization. Now, when they looked at the topographical response, that is what kind of neovascularization or whether it was NVE or NVD, they showed that NVE was more prevalent and the response to NVE was better with aflibercept when compared to PRP, and NVD was resistant to both aflibercept and PRP. And this was another trial which looked at aflibercept on diabetic retinopathy severity and visual function, wherein the patients received monthly and quarterly aflibercept, and they had taken the ultra wide field imaging in these patients. So this showed that there was a clinical improvement in the diabetic retinopathy severity in both the groups over a period of 12 months. So these trials have shown that PDR is improving with anti-VEGF injection. Does it actually cause a disease modification? So this was looked into the subgroup of patients in the Clarity sub-study. They looked at the intravascular oxygen saturation and areas of non-perfusion between these two groups. But it showed that there was very minimal change in the arteriovenous oxygen saturation after aflibercept injection at 52 weeks compared with the PRP. In fact, the PRP group had a better high oxygen saturation. That could be because of the complete ablation of the photoreceptors, which reduces the high oxygen requirement in this group. And also these difference in oxygen saturation levels were evident in the PRP group at 52 weeks, because that is a time which take for the oxygen saturation to come back after the effect of PRP. So anti-VEGF actually, whether it causes disease modification is doubtful. Now, studies have also looked at the OCT angiogram and wide field fundus fluorescent angiogram to see what is happening to these capillary non-perfusion areas in this PDR after treatment with anti-VEGF injection. So this is a study which looked at. Herein you can see that the PDR post anti-VEGF injection, it definitely shows regression of neovascularization of the disc, but they could see that there was no change in the areas of capillary non-perfusion. So this shows that the CNP areas are not changing, but it causes some effect on the regression of neovascularization on the disc and elsewhere. So now there are studies which looked at combination of anti-VEGF and PRP. So when it came to anti-VEGF with PRP versus anti-VEGF alone, it was shown that the best corrected visual acuity and the central retinal thickness was almost comparable between these two groups. But the number of injections to achieve the regression of neovascularization was less in the combination group when compared to anti-VEGF alone. Then this Proteus study was the one which looked at combination of anti-VEGF with the PRP and with the PRP alone. So here it showed that when there was an addition of anti-VEGF, that is ranibizumab, to the PRP, the regression of neovascularization was almost 92.7% in these patients when compared to PRP alone. And so hence this study concluded that ranibizumab in combination with the PRP was more effective than PRP monotherapy alone for regression of neovascularization. And it was seen that the complete neovascularization regression occurred earlier in combination group, that is at a time period of 3.6 months, and delayed in that of PRP group. That explains that in those cases where we want a rapid regression of neovascularization, a combination therapy might work better than a PRP alone. And 67% of the eyes in combination group that achieved a total regression of neovascularization had a recurrence of new vessel. So when we used combination therapy, there is a chance of recurrence of neovascularization when compared to that of monotherapy, where we treated the patient only with PRP. This was a study which looked at which should be done first. So they looked at whether intravitreal ranibizumab or a PRP should be done. Then in the study, they had given in the first sitting one group PRP, other group only anti-VEGF. So they concluded that treating a PDR with initial ranibizumab injection and subsequently followed by PRP actually reduces the energy which is required, and also it brings out better visual outcome. So this was one study which looked at the sequence when should we treat. And this was this study looked at actually what is the role of anti-VEGF in those patients with PDR and vitreous hemorrhage. So here they concluded that those patients who were treated with aflibercept monthly injection and compared with that of vitrectomy. So here they showed that among these participants, actually the visual outcome score after the initial treatment versus early vitrectomy with the PRP did not show much of a difference. However, it was not actually powered to detect the benefit of a vitrectomy and PRP. But in this study, what they noticed was recurrent vitreous hemorrhage occurred in patient with aflibercept group in 49%, but in 15% only in those group with vitrectomy. And PPV actually provides faster restoration of vision and reduce the likelihood of recurrent VH. But in some cases where there is an associated DME and there is mild to moderate vitreous hemorrhage, and if you want to avoid PPV, and this is one of the options to treat such patients. But it is important to look at the adherence of patients to this treatment protocol and the medical comorbidities and the need or desire to hasten the visual recovery when considering these two options in patients with vitreous hemorrhage and PDR. Now it was shown that anti-VEGF was having a better improvement or showing a better improvement in the patients with PDR. But what happens if these patients, they don't come for a follow-up? So they looked at those patients who were lost to follow-up on treatment, and it was shown that those patients who had received anti-VEGF monotherapy had worse anatomic and functional outcome when they came for follow-up after they were lost for more than 6 months. And it was shown that in PRP group, the loss in the visual acuity from the last follow-up and after they came back with the last follow-up was not very clinically significant, but it was more worse in those group who had received anti-VEGF alone. And the tractional retinal detachment also was more in those group who received only anti-VEGF, and those group which received PRP did not have much of a worsening. So even in the protocol S, when they looked at those patients in 5-year follow-up, almost 39% were lost to follow-up. And even in studies which looked at diabetic macular edema, almost up to 40% were lost to follow-up. So in case of these, and the few risk factors were younger age, lower income, and all those factors. So even diabetic macular edema worsens when they present later with after loss to follow-up. But we have seen that ETDRS have proven that in those eyes with the PRP, with 42% of them retain 20/20 visual acuity and 84% retain 20/40 visual acuity over a median period of 16.5 years of follow-up. So this is still a time-tested procedure in the management of PDR, and no significant difference after vitrectomy in those eyes who have blood after a PRP, pre and post vitrectomy before the bleed. So in real world practice, there is a risk of worsening outcome when these patients are lost to follow-up, and patients at high risk for loss to follow-up therefore may benefit from prompt laser with or without anti-VEGF treatment compared with anti-VEGF monotherapy. And this PRIDE study was the one which looked at follow-up of a patient for 1 year without any intervention. And here again, it had shown that on discontinuation of anti-VEGF therapy, there was worsening of the PDR evident by the increase of neovascular area and the vision loss. So tight monitoring of disease activity and continued treatment is required to get the benefit of anti-VEGF injection in these groups. And you need to keep in mind one complication which might happen with anti-VEGF in proliferative diabetic retinopathy, which is a crunch syndrome, but the occurrence is very less. And the later analysis of the DRCR 5-year results, it has shown that the crunch phenomenon is not much of an important in many of these cases, as in most of these studies, they have excluded those cases with a severe proliferative detachment. And coming to cost factor, it has a role to treat these patients with anti-VEGF when there is an associated DME actually. But when you treat it with no DME, then you have to look at whether the patient can afford, whether the systemic condition of the patient is stable, or whether they can come for regular checkup. But having said that, if the patient can afford and all these factors are favorable, because of the better outcomes, even in patients with a high risk PDR, with or without DME, anti-VEGF may be considered. So to conclude, when we consider anti-VEGF in PDR, definitely the studies have shown that it shows improvement in BCVA, reduction of diabetic retinopathy severity score, and it reduces the complications like vitreous hemorrhage, DME. And when the patient have associated DME, it is cost effective. And even with the PDR, with mild to moderate vitreous hemorrhage, it can be considered. And it again has a role as an adjunct in a pre-operative case. The trial has shown that aflibercept definitely has a superior over PRP. And the negatives are like when you, if the patient is lost to follow-up, then is a risk that the patient may come back with either a loss in vision because of the worsening of diabetic macular edema or PDR. And the cost factor involved in treating these patients with repeated injection, and also the systemic risk factor. So, and the disease modifying role of anti-VEGF is to be considered. So, definitely anti-VEGF is emerging as one of the new addition in the management of PDR, but we need to keep in mind that it is not actually modifying the disease. Maybe it is either delaying the manifestations, or because VEGF is just one factor. That is the reason why even if you treat these patients with anti-VEGF, you can see that the regression happened maybe in 50 to 60% of the patients maximum. The rest are not responding. So still we need to find out what are the other factors which might help us to have a definite management in these cases. Thank you.
Thank you, Divya. Till protocol as came, all of us were managing PDR with pan-retinal photocoagulation alone. And now anti-VEGF is emerging as a treatment modality. Leave alone the financial considerations. Is there any specific case where you would consider starting a patient on anti-VEGF than a PRP in PDR?
Okay, I do see that in some cases, especially in type 1 diabetics, where you see that the neovascularization is very angry looking and very aggressive, I think definitely we can treat those patients with anti-VEGF first and then treat with a PRP. And if you see that where the neovascularization is very bad with less proliferation, fibrous component, I would say. And again, associated with there is a diabetic macular edema.
Okay, for paucity of time, let us go to the next talk. Thank you, Divya. I invite Dr. Vasumati for her talk on surgical options in PDR. Over to you,
Thank you, Thomas. Thank you, Thomas, and thank you, Kerala Ophthalmic Society, and a very happy Navratri to all of you from Tamil Nadu. So I'll share my slides now. Is my slide visible? Slideshow visible?
Not yet.
Now?
Not yet. It's still Divya's slide.
No, Divya has to stop sharing her presentation.
Dr. Divya should stop.
Please stop sharing.
Has she stopped sharing? Can I share now?
No. Divya, are you around?
Who is the
yeah. Yeah. Divya has stopped sharing.
Okay. Is my slideshow visible now?
Yes.
Okay. So good morning to all. And after a wonderful discussion on the non-surgical management of proliferative diabetic retinopathy, let me talk about the surgical options, what we have in proliferative diabetic retinopathy. My slides are not moving. Just a minute, let me just stop sharing and reshare, please. Is it visible now?
Yes.
It is visible, but not in the slideshow.
Yeah, I'm just putting it into slideshow. Is it now in slideshow?
Yes. Yes.
So good morning all. So let me talk about the surgical options in proliferative diabetic retinopathy. And the surgical options are vitrectomy. And the indications of vitrectomy in proliferative diabetic retinopathy are, of course, media opacity in the form of a severe non-clearing vitreous hemorrhage or a subhyaloid hemorrhage or a premacular hemorrhage, as well as anterior segment neovascularization, NVI or NVG with vitreous hemorrhage. And also tractional defects like TRD, which involves or threatening fovea, especially if there there is a documented progression of the tractional retinal detachment, OCT-based and clinical evaluation-based documentation of a progression of tractional retinal detachment involving or threatening the fovea, and combined REG-TRAC RDs and progressive fibrovascular proliferation despite adequate laser up to the ora, and also epiretinal membrane or opacified vitreous space over the macula, which causes visual loss, and sometimes the TOT post-PVP ILM syndrome. All these are the other tractional defects which are indication for vitrectomy. And previous vitrectomy surgery complication, as well as ghost cell or hemolytic glaucoma, as well as anterior hyaloid fibrovascular proliferation despite adequate laser. These are the broad indications of surgical management of proliferative diabetic retinopathy. This is vitreous hemorrhage. For example, this case one might observe because the macula is not yet involved and there is enough and more space available for laser. But whereas if this is going to be the picture in a patient for more than a month, then it is better to do vitrectomy. And a dense premacular hemorrhage like this with sort of this fibrosis also is an indication for vitrectomy. This sort of dense premacular hemorrhage in diabetic patients, PDR patients, are not very amenable to the hyaloidectomy by laser, in contrast to the subhyaloid hemorrhage which occurs, say, after Valsalva maneuver, as well as in young patients with leukemia or acute myeloid leukemia or acute lymphoblastic leukemia. So the PDR premacular hemorrhage usually fibrosis fast, and it's very difficult to do a hyaloidectomy to drain it, especially if the patient presents 1 or 2 days later. And most of these patients land up generally with needing vitrectomy. And all types of tractions, whether they are active PDR associated tractions, or this is a case of a traction involving just the fovea, or this is a documented progression of traction threatening the fovea, or a predominantly peripapillary traction with vitreopapillary traction, which will go on to involve the macula anyway. So all types of traction need surgical management. And some thoughts about vitrectomy in PDR, it's always better to do an early vitrectomy within 1 to 4 months, which results in better visual acuity. And probably, and this is my experience, and that is what is reported in literature also, we see better results in type 1 diabetic mellitus patients when compared to type 2. Though the type 2 diabetes mellitus patients, the surgery is probably technically easier because of the presence of PVD. And regarding the factors influencing the timing of vitrectomy in PDR, the duration of vitreous hemorrhage, any vitreous hemorrhage which is going to last for more than a month, it's better to operate. And severity of PDR, if it's a very severe proliferative diabetic retinopathy and there is no way we can do laser, it's better to operate. And the type of diabetes mellitus patients also, especially type 1 patients who present with vitreous hemorrhage, I would be more aggressive. And status of the other eye, if the other eye is lost due to unsatisfactory treatment of PDR or due to so many reasons, I would be more aggressive in advising an earlier vitrectomy in the other eye of the patient to save his eye. And also prior laser treatment. Supposing the patient has not had any laser treatment at all for PDR and presents with vitreous hemorrhage, I would probably even advise vitrectomy as early as 1 to 2 weeks following the onset of vitreous hemorrhage. Whereas if a patient presents with vitreous hemorrhage after, say, prior laser, having undergone prior laser treatment, then we can consider waiting before we counsel the patient for vitrectomy in such patients. And there are several favorable prognostic factors in diabetic vitrectomy, especially a preoperative visual acuity of more than 5/200. If there's a prior PRP of at least 1/4 of the fundus, it's definitely a favorable prognostic factor because they don't bleed like anything. And if there are no NVI or no NVG, definitely a better prognostic factor. And the presence of a clear lens. We don't have to sacrifice the lens. We don't have to, do any manipulations involving the blood-retinal barrier. In that case, it's definitely a favorable prognostic factor. And if the macular detachment duration is less than 1 month and the age of the patient is less than 50 years, these patients generally do well following a diabetic vitrectomy. And what are the objectives of pars plana vitrectomy in PDR? We have to remove all the axial opacities, clear the media, relieve all the anteroposterior and tangential traction, sometimes like what we do for ROP, and segmenting or peeling of epiretinal membranes is important, and an adequate endolaser treatment. I do endolaser right up to the periphery to prevent a few future AHPV. And of course, and we need to close all retinal breaks and make sure the homeostasis is very much achieved, and treatment and prophylaxis of all complications. So there are certain caveats. Preoperatively, try to do as much PRP, accessible PRP as possible to prevent, intraoperative troublesome ooze and also a postoperative VH. And anti-VEGFs can be considered if there are not too much, if there's not too much of fibrosis. We don't want a post-anti-VEGF crunch syndrome. And to avoid that, make sure that the vitrectomy is done just 3 to 5 days after the anti-VEGF injection. Don't wait for a longer time, because there can be an angiofibrotic switch even if there is no pre-existing fibrosis, and the fibrosis may lead to worsening of the TRD. And though some people may disagree, I generally ask my patients to stop the antiplatelet drugs, because I have seen many a time that they continue to, we have troublesome ooze, especially from the optic disc, wherein we can't diathermize for obvious reasons. So I ask my patients to stop the antiplatelet drugs about 3 to 5 days prior to vitrectomy. And if the patient is on dialysis, it's better to do the vitrectomy 1 day after the dialysis is done, so that the patient is comfortable on table and your surgery is also comfortable. And I employ a lot of preoperative OCT whenever possible to decide the anatomy of the macular TRD, whether I want to do a unimanual dissection or a bimanual dissection, so that I am well prepared. And intraoperatively, always make sure that the dichotomy is good, and an inside-out dissection is better. And watch out for CRA pulsation always, because most of these patients have compromised optic disc circulation. So we have to guard against hypotonic, and a good endolaser right up to the periphery. Sometimes even with scleral depression, you can go right up to the periphery, and a very good peripheral vitrectomy. And post-operatively, if we have troublesome ooze intraoperatively, I don't advise the patient to have a prone position. I just advise them a heads-up position. And in PDR with neovascular glaucoma, the PRP cryo is important, and it should be extensive. And pre or intraoperative anti-VEGF is of course employed. And a silicone oil tamponade may be a better tool to use to reduce recurrent vitreous hemorrhage, and this may induce the regression of rubiosis. And the instrumentation, of course, we have chandelier illumination, forceps, scissors, big diathermy. But the most important nowadays, thanks to better instrumentation, is the vitreous cutter. We have small gauge instruments with the port very close to the tip. So sometimes, as I'm going to show in my video, with just a vitreous cutter, you can do everything. You don't really need the other things. Of course, you have to have them in hand, but with just a vitreous cutter, you can do things. And some salient points: if there is a posterior vitreous detachment present over the posterior pole, we can create a hole, suck out the blood, and then complete the posterior vitreous detachment. This is provided there's not much of fibrosis. But if there are extensive tractional membranes over the posterior pole, PVD induction must be avoided as far as possible. I mean, a very fast PVD induction must be avoided. And probably, especially in type 2 diabetic patients with a lot of fibrosis, an en bloc dissection would be a better option. And complete removal of the peripheral vitreous. This is very, very important. In contrast to other patients who present, say, with vitreous hemorrhage, like vasculitis patients and all, in diabetic patients, it's important that we remove the peripheral vitreous as much as possible, because there can be a leaching or a washout of the RBCs in the peripheral vitreous, and then you can have troublesome post-operative vitreous cavity hemorrhage. And regarding the membrane dissection, we have segmentation, wherein we cut the membrane, which is a bridging tissue between the foci of the fibrovascular adhesion. This again can be beautifully achieved by just a cutter. And delamination, in which the connections between the posterior hyaloid and the fibrovascular tissue and the ILM are cut using scissors, can also be done by the vitreous cutters. And en bloc technique, in which removal of the vitreous as well as associated the vitreous membranes, everything is done as a single unit. And many times we do employ combination techniques. And what are the complications of diabetic vitrectomy? Of course, intraoperative corneal edema, lens touch, pupillary constriction, intraocular hemorrhage, retinal break or detachment, and subretinal migration of the PFCL or silicone oil. And post-operatively, NBI and NBG, cataract, fibrinoid syndrome, post-operative vitreous cavity hemorrhage, and anterior hyaloidal fibrovascular proliferation. So of these last two alone, I would like to just touch upon. Fibrinoid syndrome is a breakdown of the blood retinal barrier with intraocular fibrin deposition. And there's a massive fibrin formation, which leads to tractional retinal detachment, pupillary block, ciliary body detachment and hypotony, or conversely, the patient may land up with rubeosis iridis and neovascular glaucoma. And AHFBP is the most severe complication of diabetic vitrectomy. In 13% of cases, the growth of the neovascular tissue from the vitreous happens onto the base, the anterior retina, ciliary body, lens capsule, iris as a single unit, and the patient may present with rubeosis, vitreous hemorrhage, peripheral tractional retinal detachment, or hypotony. In such cases, it's better to always use silicone oil tamponade. So finally, let me just show you a video of a 26-year-old male patient, a juvenile diabetic. Best corrected visual acuity was CFCF, sudden loss of vision for the past 1 month. And this was in the COVID situation. Right eye also had PVR. So this is the extensive fibrosis of the posterior pole that you're seeing with a partial posterior vitreous detachment in the pre-existing hole. So I'm just using the cutter and trying to aspirate the fluid and suck out the fluid, the blood through the hole, pre-existing hole. I'm creating a gentle PVD, and this is a type 1 diabetic patient, so I am not so worried about iatrogenic breaks. Removing the PVD blood en masse with the cutter. Diathermizing the bleeders with intraocular diathermy. And with the cutter, the blood usually clots very fast in diabetic patients, so that acts as another membrane, troublesome membrane. So we can peel that also with the cutter. So instead of a forceps, I'm using the cutter alone to peel. So cutter can be used for peeling, dissection, segmentation, en bloc dissection, delamination, everything. And doing peripheral vitrectomy, endo laser. Thank you so much for the opportunity. I look forward to a wonderful discussion. Thank you, Dr. Thomas and KSOS. I'll stop sharing my slides.
Thank you, Vasumati. Since time for panel discussion is very limited, I'll just take 2 issues instead of going through the entire panel discussion. First one is regarding the cases of PDR where there is extensive capillary non-perfusion, the perfusion stopping just 1 or 2 disc diameters short of, this is for all the panelists, the perfusion stopping just 1 or 2 disc diameters temporal to the fovea. Patient with reasonably good vision, maybe 612 or 6/9, would you take up for an anti-VEGF injection or would you take up for a PRP? The question is to Natasha.
Natasha, you're muted.
Hi. Good morning, everyone. Yeah, we have been following combination therapy for some time now. We do both anti-VEGF injection and pan-retinal photocoagulation. Specifically for this case, yes, I would go ahead with both anti-VEGF injection and follow it up with a pan-retinal photocoagulation, specifically covering the CNP areas as well.
Would you go for a anti-VEGF monotherapy? Anyone?
We haven't started anti-VEGF monotherapy yet.
Okay. The second issue is, how frequently do you give anti-VEGF before a proliferative diabetic retinopathy vitrectomy? Because we all started giving it, then came the Avastin crisis, then we came down, then after that, have we gone back to the levels which we were giving earlier? Do we still inject a lot of anti-VEGF before taking up a patient for vitrectomy in PDR, or do you straight away go in? Mahesh?
Thank you, Thomas. I'm audible?
Yes.
Yeah. Okay. That is, as a standard, I give Avastin 4-5 days before surgery when they come for a preparation and medical checkup. This is not in every case. Suppose you can assess whether the patient needs anti-VEGF. Because if you feel that intraoperative oozing can be a problem, sometimes you can see the aggressive, angry looking new cells are there. Those sort of cases, if you directly go in, it will be a bleeding hell. So I give anti-VEGF. But sometimes it is only a vitreous hemorrhage with some focal traction you can easily remove. I may not give. So this is my decision that it's not a standard thing that I give anti-VEGF before surgery. That is that is what I do.
But majority of the cases you give, no, Mahesh?
Mostly. Some cardiac patients, sick and all.
Unless some contraindication.
Yeah, some contraindication I don't. And simple vitreous hemorrhage and all I don't give. Simple vitreous hemorrhage with 1 or 2 focal traction I don't give. But if you see inside and you feel that it is going to be a hell, I give. Because many times now with the advanced instruments, the only thing that prevents us from complete removal of fibrovascular proliferation is bloody oozing. That is what sometimes we will be forced to stop the surgery, whatever you do. So other than that, I think you see beautiful videos. We can almost completely remove the whole membranes and proliferation with the new advanced cutters and other instruments.
I think thanks to anti-VEGF injections, we have almost, the incidence of surgery abandoned will be taken up later has almost become,
very rare. Very rare.
Very amazing adjunct.
Most important, we have to maintain the interval. We shouldn't I've had patients who got the anti-VEGF then thought that they can escape getting the vitrectomy done. They've landed up a month later.
There will be rebound bleeding.
So that's one thing which we have to clearly tell the patients. That they should,
Biju, if you have an option of a PRP versus an anti-VEGF in preoperative PDR, what would you give?
Preoperative, I mean, I didn't get it with you. Can you repeat the question?
In a PDR, you're taking up for a pars plana vitrectomy. If you have an option of the media is sufficiently clear, if you have an option of giving a PRP prior to the surgery or an anti-VEGF, what would be your choice?
Yeah, definitely. If the media is clear enough to permit a PRP, I would do a PRP.
Thomas, you mean we have decided to do vitreous surgery?
Yes, we have decided to do vitreous surgery.
Biju, that is a little different. Decided. Anyway, the patient is having a TRD or something that we need surgery.
Yeah, I mean, so it depends upon the indication of the vitrectomy also. So if they haven't decided already about doing a vitreous surgery, I think probably an anti-VEGF followed by vitrectomy and endolaser.
the only problem with PRP before vitrectomy is we'll have to wait for at least a month for the effect.
Exactly.
So if the patient and you are okay to wait for that long a time, then PRP would definitely be a better preoperative measure when compared to anti-VEGF.
In that situation, I think that maybe we can avoid vitrectomy. That is thinking behind that. Doing a PRP, maybe the blood will just absorb, and maybe a vitrectomy can be avoided. Maybe that is thinking behind that.
Sindhu, how frequently do you use silicone oil in your diabetic vitrectomies? In all cases, or are you selective? Is Sindhu around?
Yes, sir, I'm around. Silicone oil injections I use in the diabetic vitrectomy with complex retinal detachment, combined retinal detachments, PRP involving macula, and vitreous hemorrhage with subhyaloid hemorrhage with lot of fibrous proliferations. I use silicone oil as a routine for all those cases. Orals after a C3FB injection, sometimes these cases come up with recurrent vitreous hemorrhage. So I use for most of these complex cases silicone oil injection. That is combined TRP, then the combined retinal detachments, TRP, small macula, VH subhyaloid with extensive fibrous proliferation.
There's not much of extensive fibrous proliferation, but during your surgery and at the end of the surgery, it keeps on oozing from 1 or 2 points. The question is to Divya, would you prefer silicone oil or just leave it like that with air or gas?
See, if I have done a good laser and if I could complete the laser and there was not much of a traction detachment was there, which prevents me to do a laser. And if the patient is not one-eyed, then I may not put silicone oil in such cases. But I would explain to the patient that there might be little ooze and it might take some more time for the vision to become clearer. So that I would say. So it depends upon the retinal status at the end of the surgery.
Any other opinion from the other panelists? A persistent ooze at the end of surgery, would you inject oil or would you leave it with air or gas?
Any oozing you can stop by one of the methods. Kothari. The only problem is oozing from the disc. You can't do much of a manipulation. So all other areas, flat neovascularization, pain, Kothari is possible. There are a lot of people don't do Kothari, but I give mild Kothari, and around that also little laser I will give all around that wherever I have Kothari. So except at the disc, I think all new cells, all oozing can be stopped by surgery. If the disc is profusely oozing, you will have to think about it. Sometimes your surgery is very clean, still there is some ooze from the disc. I may put air and then put little more Avastin inside at the end of the surgery.
I would be a little wary of putting silicone oil if there's a lot of ooze. If it's a one-eye patient, yes. Because sometimes what happens is this blood accumulates, under the silicone oil, between the silicone oil retina interface, and only when the patient actually we do silicone oil removal can be remove that blood, especially if it clots and becomes thick. Otherwise, gas is just enough. But only thing is we have to explain to the patient that post-operatively he or she will have a post-operative vitreous cavity hemorrhage, and that his vision will take quite some time to clear. We can put gas and then advise bed rest with 2 pillows so that the hemorrhage absorbs.
But in private practice, it's sometimes very difficult to explain to the patient the next day that you have done surgery and then still there is a bleed.
I tell them that their vision will take 2 months to become.
I think we are a bit more aggressive when it comes to silicone oil. Diabetic vitrectomy, especially with extensive tractions in which manipulation has been done.
Just ooze, like what Thomas was doing.
Yeah, extensive traction, everybody uses oil.
What is the concerns on leaving some amount of anti-VEGF, as Mahesh was telling, after the surgery?
Yeah, intra-op anti-VEGF, yes. I do them. I do that quite a lot of time.
We can use it very much, but it will be washed away in a day.
Let it be, but the oozing will stop. It will help. It will help.
On the day
it will not one day. It will wash away in 1 to 2 weeks. 1 to 2 weeks.
May I make a comment, please?
Granted, the pharmacokinetics is much faster in a vitrectomized eye, but
1 to 2 weeks. Dr. Dinesh Talwar's opinion.
Yeah.
I think what you're trying to point out is you have an ooze. Your next day you're going to have a hazy media. The hazy media may continue for a long time, and silicone oil can prevent that. So of course you don't want it continuously oozing when you do the exchange. So you have to try to see, at least at that point of time, it's better to stop that ooze, and the best way for doing that is to let a small clot form on that area. Don't remove that clot. In the end, leave that clot, and then if you put silicone oil, the blood, first of all, it doesn't clot under silicone oil. So that's not true. But the important thing is it will localize it to that area. The visualization will be good later on. You'll get a chance to laser, which will reduce the ooze further. So actually, silicone oil can play a very important role in this situation which you're talking about.
Thank you very much, Talwar sir, for your words of wisdom. Thank you all the panelists and all the speakers. Let me wind up this session and hand it over to the next person, Dr. GopalPillai.
Thank you. Bye.
Thank you very much, Thomas. Welcome you to the last session of the day. Am I audible?
Sure. Yeah.
So we have with us, without any further ado, let us start with the choroidal neovascular membrane. We have 2 star speakers today. One is Dr. Neha Goyal and the other is Dr. Dinesh Talwar. They both don't need any introduction. Neha will talk us about OCT and OCT biomarkers in wet AMD or CNVM. You are taking the whole CNVM?
Yeah.
Okay.
I'm taking a bit of dry AMD also, actually.
All right. And then Dr. Dinesh Talwar will be speaking to us on management measures. And then we will have a short discussion which is by Dr. Sheena Lesmani. She has prepared some case scenarios, which we will discuss very rapidly. Over to you, Neha.
Thank you, Dr. Gopal. Thank you to KSOS for organizing this wonderful CME. I've been hearing since the morning, and it's actually been a kind of a academic feast. Thank you, Dr. Gopal, for that kind introduction and placing me in the same category as Dr. Talwar, which is not probably correct, but then thank you. It's a great honor. So I'll be talking about imaging and biomarkers in AMD and then specifically in CNVM. So what is a biomarker actually? A biomarker is a feature that can identify pathology or a disease process, and it can assist us in accurately monitoring the disease, detecting changes or progression, allowing early, timely intervention or appropriate follow-up. So in the last 2 decades, as we know, the management of AMD has been revolutionized initially with the advent of anti-VEGF therapy, and more recently or rather continuously as we continue to develop an understanding of OCT imaging with new modalities like OCT angiography coming up. So a knowledge of these biomarkers, so as to say, and indicators of disease activity can allow both optimization of follow-up for patients who don't need intervention and also deciding treatment or individualizing treatment for each patient. So just a quick recap, this is the clinical classification of AMD that is currently adopted. There can be no aging changes or normal aging changes, which includes only small drusen and no pigmentary changes. Once the pigmentary changes step in, it becomes early AMD, followed by intermediate AMD if you have large or coalescent drusen, and then finally late AMD, which includes any form of neovascularization and or geographic atrophy. I'll be talking about these 2 consensus meetings, the classification of atrophy meetings and the consensus on neovascular AMD nomenclature meetings, and have adopted their recommendations in the talk and in our clinical practice. So starting with dry AMD, the first thing to identify is drusen, which can be hard. These have steep walls or they can be soft, which is more of an undulating or sloping walls. 2 other subtypes are the cuticular drusen and the reticular pseudodrusen. So cuticular drusen is actually a subtype of drusen, which are much more numerous than hard drusen, and they coalesce, giving a diffuse appearance, the classic starry sky fluorescence seen on angiography. On OCT, they are located beneath the RPE, so they lead to a thinning of the RPE at the apex and a thickening at the base, which is sometimes called the barcode sign. Why is this important? It's a biomarker which has been seen to predate or lead to the formation of RPE clumping, large drusen vitelliform lesions, and even CNV. So when you see this in your patient, counsel accordingly. The next marker on OCT is reticular pseudodrusen or subretinal drusenoid deposits. A lot of talk and literature has been published on them in the recent years. These are basically extracellular accumulations of material internal to the RP under the retina. You can have the isolated discrete dots as you see here, or you can even have the ribbons, the ribbon type and the dot type. And it's important because you see them in patients with thin choroids, and they are risk factors for the development of late AMD, particularly type 2 or 3 CNV, and also for geographic atrophy. So usually they are more numerous superior to the fovea, and the fovea is usually spared, and they become more prominent in blue light or in near infrared photography, as you can see here. Here is the ribbon type, which I told you about. So again, this is a biomarker, and you need to prognosticate the patient. Many times we see these in fellow eyes of patients with RAP and other late AMD changes, and follow up accordingly. The last drusen subtype is the calcified soft drusen. Naturally, they originate from classical drusen, but they have had their colloidal content change into hydroxyapatite over time. Now, these are hyper-reflective. Normally, drusen are hyper-reflective, but calcified drusen have a hypo-reflective center, which is the mineralized hydroxyapatite content. And clinically, you will see that they are much more glistening than the usual drusen. So these, again, suggest a higher rate of GA development. So it's important to recognize them. One feature I'd like to point out here is what is called the drusen ooze. So here you see some hyperreflective foci or intraretinal deposits on the top of this drusenoid PED. And this was the 1-year follow-up where it was actually found to increase. Again, if you see this feature, you must counsel the patient because AREDS2 has shown there's a 5-fold greater risk of progression to GA at the end of 2 years. Now, GA or geographic atrophy is the mainstay of non-neovascular AMD, which we want to prevent or not reach. And here is the classic feature, what we earlier used to call a hyperreflective choroid, but now we just call hypertransmission. So GA actually refers to atrophy of retinal layers, including the photoreceptor layer, the choriocapillaries, the RP, in the setting of extracellular deposits, causing its increased transmission of the OCT signal below the basement membrane. The current nomenclature classifies it as a complete or incomplete RP and outer retinal atrophy, or complete and incomplete only outer retinal atrophy. So for this, the OCT criteria which have been suggested must be present are a region of hypertransmission at least 250 microns in diameter. This should be along with the zone of attenuation or disruption of the RP, again same size, evidence of overlying photoreceptor degeneration, and absence of any signs of a RPE tear or a RPE dip. So these are classic pictures of complete RP and outer retinal atrophy you can see here. And this is the incomplete one or the nascent GA. And similarly, you can have only outer retinal atrophy, which can again be complete or incomplete. And this is the precursor of the corora. Without the RP is the precursor of the atrophy of the RPE as well. These are some clinical pictures, and you can see fundus autofluorescence, as we know, is an important tool in non-neovascular AMD as well. Now, why is it important to remember these somewhat complex terms? Because firstly, for any trials or studies evaluating agents preventing GA, it's important to standardize, and earlier assessment can lead to recruitment of patients. Earlier assessments used to lead to recruitment of patients with already complete GA. Now you can recruit patients with nascent GA or only outer retinal atrophy. And as I said earlier, patients with outer retinal atrophy may precede RP atrophy, and especially in patients with associated reticular pseudodrusen. So this might be a subtype which is high risk and might be amenable to intervention in the future. Another feature on dry on the OCT that I would like to point out is the outer retinal tubulations. These are basically round lesions with a hyporeflective lumen and hyperreflective borders, as you can see here. They have quite a dramatic appearance and are usually seen in advanced AMD with either CNV or GA and are associated with poor visual acuity. But they may also be commonly seen in other degenerative conditions like retinitis pigmentosa, dystrophies such as Stargardt's disease, guided atrophy, cone dystrophy, etc. Now, why is it important to see this feature is because sometimes you might confuse it with intraretinal fluid and offer unnecessary treatment to the patient. Also, it's important to always correlate clinically. See here, you see what might look like an outer retinal tubulation, but if you correlate it with the angiography here, you realize that it's actually a microaneurysm. So multimodal imaging always to the rescue and for the win. Now, another feature which has come up on imaging, and particularly with OCT angiography, is the non-exudative or quiescent CNV, so as to say. So these are type 1 neovascularizations which are detected on OCT angiography with no sign of activity, which means no intraretinal or subretinal exudation on the OCT for at least 6 months. So they've been seen in up to 1/3 of eyes with intermediate AMD. Important to know that they do not meet the criteria for anti-VEGF therapy. And in fact, they may be, there's a hypothesis that they may slow down the progression to GA because the aberrant neovascularization might actually have a nutritive effect on the neurosensory retina at that place. So for instance, this patient with clinical geographic atrophy, pseudophakic in both eyes, this is the right eye OCT. You can see some drusenite PDs, but no fluid. This is the left eye. And angiography, again, just staining. But if you look at the OCT angiography here, you can see a complex of vessels with some flow in the OCT B scan. This is the right eye. And similarly here, in the left eye as well. So this fits into the definition of a non-exudative CNVM, would not treat at this time, but definitely demonstrated to the patient and grill the importance of a regular follow-up. These are his follow-up pictures, and he remained stable despite no intervention. Now, a word of caution, always correlate with the B scan, the flow on the B scan. For instance, here you might be tempted to label this as a non-exudative CNVM, but you look here, there's no flow, and actually you can see this is an area of atrophy. So it is just the underlying vessels which are coming through. Now, another case, let's look at the other end of the spectrum, where you see fluid on OCT along with drusen, and you are tempted to make the diagnosis of a neovascular AMD. So here again, OCT, but there's no avert leakage on FFA. So here again, OCT angiography might help to do the opposite, that is, rule out the presence of a vascularized membrane. So this actually becomes a non-vascularized drusen or drusenoid PD associated with SRF. Again, OCT-A will confirm whether or not a CNVM is present, and if it is not present, then again it does not warrant anti-VEGF therapy, which you might be tempted to offer on the basis of only the OCT. So next, coming to the wet or neovascular AMD, we are all familiar with the types of PD, which can be serous, drusenoid, fibrovascular, or hemorrhagic. Serous has an optically clear space as opposed to the fibrovascular, which will have multiple echoes within from the neovascular complex. And then you have drusenoid, which are more solid looking, and hemorrhagic naturally with shadowing, you know it's a sub-RP hemorrhage. A notched PD is a specific feature which can point towards the presence of a PCV. So here again, to differentiate serous and hemorrhagic, you have a distinct band which is composed by the underlying choroid, whereas in hemorrhagic, because of the shadowing, this band may not be continuous. So the serous and drusenoid types come in the non-neovascular AMD, whereas the fibrovascular, hemorrhagic, and notched come in the come under the category of neovascular AMD. Now, coming to the subtypes of CNVM, first we have the type 1 CNVM, which was earlier classified as occult on FFA. And this is definitely a sub-RP CNVM. Here you can see the double layer sign, and it is said to have a better prognosis. This is as opposed to the type 2 CNVM, earlier known as classic on FFA, which is subretinal, hence more disintegration and disturbance of the photoreceptors and heralds a worse prognosis. Now, look at this hyper autofluorescent lesion on fundus autofluorescence with the kind of thickening of the RP over here, some hyperreflective material again, and a central clearing. So is this a CNVM? No, this is actually a AVL or a acquired vitelliform lesion. And the catch here is that the material is subretinal plus hyper autofluorescent. It may or may not be associated with SRF. Now, this is again very common and may be mistaken for neovascularization with SRF, but you must make this diagnosis to avoid unnecessary anti-VEGF therapy. Next, coming to the type 3 CNVMs, which are the RAP or the retinal angiomatous proliferation, clinically seen in older patients, particularly females. Now, these are extrafoveal accompanied by intraretinal hemorrhages, serous exudation and hard exudates, and retinoretinal anastomosis, which you can pick up rarely. There may be associated soft drusen or reticular pseudodrusen, as we had seen earlier. Some of the OCT features which can help you to think of this entity are a serous vascularized PD with the presence of CME. Now, important to remember that these are bilateral. These are bilateral in almost all cases, and 80% fellow eyes may be affected after 1 year, 100% before 3 years. So this is an important counseling that you need to do for the patient. Just a word about PCV. It's important because many of the AMD we diagnose are actually PCV, and the first investigation, since we do is OCT, we need to know what OCT features could point towards this diagnosis and maybe make us do an ICG angiography in these cases. Of course, overt clinical signs might also be there, but on OCT, if you see a double layer sign, if you see Pachy vessels, if you see a thumb-like or a tall peaked PD, all these might suggest the presence of polyps, and you should do a more appropriate imaging. Finally, coming to an RPE RIP, here we are seeing less of them now, but then it's an entity you must recognize. There's a hypofluorescence where the RPE has rolled over and a hyperfluorescence where the RPE has scrolled away. So there is transmission from the choroid. And here you see it on the OCT. And mind you, you might still have activity along with RPE RIP. So if there is an RPE RIP, it doesn't mean that you stop treatment. It can still be associated with a partially active membrane. So these terms which I discussed are actually from the Conan meeting, and this is what they were earlier called, as I said, and this is what is the new terminology: type 1, 2, 3 CNVM, mixed CNVM, SREM, which I'll just be talking about, the type of fluid which is intraretinal or subretinal, and outer retinal atrophy, as we had seen earlier. So let's look at this patient. This is the ICG you see, and this is the FFA showing some leakage of undetermined source. And here you see the OCT. So what different or what extra do you see on this OCT in addition to the fibrovascular PED and the subretinal fluid? It is this area, this hyperreflective material which you see under the retina and internal to the RPE. And you see it is hypoautofluorescent over here, as opposed to the vitelliform material which I just showed you, which had a similar location but was brightly hyperfluorescent. So this is hypofluorescent material. So this is what is known as the SREM. I'm sorry for this typo here. It's subretinal hyperreflective material, basically, as the name suggests, located subretinally and hyper reflective on the OCT, mind you. On the autofluorescence, it is hypoautofluorescent. It might consist of fluid, fibrin, blood, or scar, or fibrovascular tissue. It's important because it's a harbinger of poor prognosis. It might damage the overlying photoreceptors directly by a toxic effect, or during the course of your anti-VEGF therapy by contraction and disorganization. So it's present in a large number of treatment-naive eyes with neovascular AMD, 75%. And now that you've seen it, you know it, you will look for it and find it. And it may persist in up to 1/3 at the end of 1 year. So like I said, SREM is a surrogate OCT biomarker for poorer prognosis, especially if it involves the fovea. It has well-defined borders. It's more hyperreflective. It has a greater height, width, and area. That means it's larger in size. And if it is persisting with anti-VEGF therapy. Another OCT biomarker is this rather dramatic appearance known as a multi-layered PED. Here you see the sub-RPE component, sub-RPE compartment is seen to have these layers of hyperreflective bands. Now, these are located between the RPE and the Brooks membrane, and they are seen in vascularized PEDs. Commonly chronic fibrovascular PEDs which have received multiple anti-VEGF, intravitreal anti-VEGF injections. This may or may not be accompanied by an optically empty cavity here between the lamellae and between the outwardly bowed Brooks membrane, which is known as a choroidal cleft. So, as I said, it's a dramatic appearance, and if you see it the first time, you might be a bit perplexed. But please remember that multi-layered PED is not an indication that you should stop treatment or that there is poor prognosis. On the other hand, these eyes maintain good visual acuity, probably because, as we discussed earlier, the cicatricial process is confined to the sub-RP space and is not in the subretinal space. And it also confers an advantage in that there is a lower risk of RPE tear. The prechoroidal clefts, which are rarer and also on the contrary herald a worse visual outcome, especially if it has developed early in the course of treatment within 6 months. These, on the other hand, just opposite to multi-layered PED, give a greater risk of RP tear and subretinal hemorrhage, especially in draft. So here you can see this patient with a large hemorrhagic PED, and here is the multi-layered appearance and this choroidal cleft. This was in both eyes. This is the right eye of the patient and this is the left eye. Again, you can see the choroidal cleft over here. So this is another dramatic appearance on OCT where you see it's hyperreflective on the NIR and these needle-like crystals present in the sub-RP space along with the Serous PD. This was present in both eyes. And this is another different entity which is known as the onion sign. And this is basically sub-RP lipid, not to be confused with the multi-layered PD. Last, we come to the type of fluid. So as I showed you, the Conan meeting placed an emphasis on which type of fluid is associated, whether it is intraretinal or subretinal. Now, why is this? So recent studies have asked pertinent questions to gauge treatment outcomes in neovascular AMD. Is it necessary to achieve a complete drying of the macula when treating with anti-EGF agents? Of course, Dr. Talwar will be speaking more about this. If the latter is not possible, what impact does the residual fluid in the macula have on visual outcomes? So the fluid trial actually supported that patients can tolerate a small amount of SRF on OCT with no adverse effect on visual outcome, vis-a-vis residual fluid seen in the form of intraretinal fluid, which correlated with poorer visual outcomes. The last part is a word about OCT angiography, the new kid on the block. So as earlier or even now, FFA is said to be the gold standard for CNV detection, classification, and localization. But we of course know that it is invasive and repeated administration of dye may not be feasible in all patients. Also, if you see anatomy-wise, dye leakage, hemorrhages, media opacity, all these can obscure details. And more importantly, it's not designed for segmentation of the different layers as opposed to OCT angiography. ICG again is invasive, has its own specific indications, and can image sub-RP structures in most scenarios. So OCT, though very good as a OPD tool, but it has limitations in pinpointing the neovascular tissue due to similar reflectivity with drusenoid material and hemorrhages. So keeping in mind all these points, Octa is said to have very high specificity and also good sensitivity in CNV detection. It provides more distinct vascular network patterns and they are quite beautiful, so as to say. It's less obscured by subretinal hemorrhage, and the highest detection rate is for type 2 CNV. However, it does have its own set of caveats. Poor performance on detection of type 1 CNV, especially with a greater PED height, because you get segmentation artifacts and the OCT signal attenuates less with the swept source, but more with the spectral domain Octa. And it may miss low flow components of neovascularization, such as polyps, where we know that it's not the investigation of choice. So basically, this is the outer retinal slab which we are interested in. And as I said, a cross-sectional B scan with the Octa flow overlay is very important to correlate whether what you are seeing is just an artifact or an actual neovascular complex. So here you see just some clinical examples, a patient with FIPED or the flat irregular PD and some SRF, but Octa shows you quite a large, in fact, and prominent network at the level of the outer retina. Similarly, this is the classic medusa-shaped neovascular lesion seen in type 2 CNVMs. Now, this was a patient with, again, type 2 CNVM and some scarring. And here on Octa, you can see it was what we call the glomerulus shaped CNVM, again, a type 2 CNVM. So to summarize, we've talked about imaging, multimodal imaging and biomarkers in dry and wet AMD both. In dry AMD, we looked at the type of drusen, the presence of drusen ooze, outer retinal tubulations, the classification of GA, 2 applications of Octa in dry AMD to detect non-exudative macular neovascularization and to rule out macular neovascularization in non-vascularized drusen or drusenoid PD associated with SRF. Coming to wet AMD, we looked at the types of PD, the classification of CNV, type 1, 2, 3, the type of fluid. All these are features we should look for when we look at a OCT scan or do imaging for a patient with wet AMD. Some other biomarkers such as SREM, multi-layered PDs, choroidal clefts, and finally, just a glimpse of the role of Octa in CNV detection. So to conclude, in vivo imaging by OCT has significantly enhanced our understanding of chorioretinal disorders, including AMD, with respect to early recognition, pathogenesis, disease progression, and treatment paradigms. OCT, if I may say so, is the backbone of AMD practice. Octa is still evolving, its role is becoming larger, and it can provide useful information. Clinical information is paramount for decision-making. And this is the era of multimodal imaging, where we can actually use this to overcome the shortcomings of each diagnostic modality. And this is the one which is the most helpful in management of patients. Thank you.
Thank you, Madam, for such an elaborate presentation, Madam. Madam covered almost all the areas in that CNVM imaging and all. compared to the other previous sessions, now we came to know that AMD session, we came across with a lot of names, lot of types of drusen's, everything. So the importance comes in the predicting the progression and also the predicting the visual outcome and the response to the treatment. So even if it's a small findings in the imaging modalities, it's each one has got its own significance in that's different levels. So once again, I thank Madam for the presentation. And now we will move on to the second talk by Dr. Dinesh Talwar on management of AMD and CNVM. Dr. Dinesh Talwar, sir, has got experience in the vitreoretinal surgeries for last 3 decades. And he is an alumnus of prestigious All India Institute of Medical Sciences and is currently practicing as a senior consultant in Center for Sight in Delhi. And he has pursued a career in research in addition to the clinical pursuits. And Dr. Dinesh sir is a great academician also. Over to you, sir, for the second talk.
Thank you very much for that flattering introduction. I think Neha did a great job of telling us all the various findings, and that's why I'm not going to discuss about, I'm not going to show you any slides on progression, how the changes occur. I'm going to discuss only the principles of management of exudative macular degeneration, and the same principles actually apply for all types of CNVM, with some being more aggressive and some being less aggressive. Most of the other forms of CNVM are less aggressive than exudative age-related macular degeneration. So the same principles will apply there also. This is my disclaimer and a financial disclosure, so not really relevant for this talk. Now, basically exudative ARMD, and we are talking really about subfoveal and juxtafoveal CNVM. It's not a single disease. We all know we have CNVM due to predominantly classic lesions, minimally classic lesions, occult lesions, what you call type 1, type 2, type 3. All these types are different types. And within occult, what is type 1, you have late leakage. If you do a fluorescein angiography, they behave differently. You have late leakage from an unknown source. You have fibrovascular RPE detachments. You have serous RPE detachments. The fact is, at the end of the day, different patients behave differently. We know anti-VEGF agents work. The monthly regime shown by Marina and Anka showed very clearly that anti-VEGFs are the gold treatment for treatment of ARMD, and specifically it was the monthly regime which was validated first. The problem is monthly regimes are extremely exhausting for the patient and doctor, and they're too intensive to carry on for a long-term basis. However, we realize not everybody needs monthly treatment. You will realize that actually this is the sustained study which showed that there are at least 20% patients who require no more treatments than the first 3 doses. And they stay okay after that for the rest of the year. On the other hand, there is another 20% patients who need treatments month after month, otherwise they deteriorate. So, and a lot of patients are in between. So this demonstrates the need to individualize treatment. So first lesson, we need to individualize the treatment. Now, if you want to individualize the treatment, what are the drugs available? You have ranibizumab, bevacizumab, aflibercept, and now brolucizumab. And these are the various names which they have, the trade names that they've been given. Now, when you decide which drug to use, you want to decide this optimal treatment. What all would you keep in mind? You will see the efficacy, you will see the safety, you will see the ease of use, both for the patient and the doctor, and you'll try to increase the intervals between the treatments. Now, when you balance safety with efficacy, keep one thing in mind. Safety is of paramount importance. For those who say efficacy is important, just a simple example, even today, destroying the CNVM with an argon laser is probably the most effective treatment in the world. but you will never do it for a subfoveal CMVM because you lose the vision also. So you've lost the vision, you've destroyed the lesion. You don't want that. You want a lesion, a treatment which is safe. And so safety is the paramount importance when you make a decision. Now, what are the factors that influence visual outcomes? Neha told you about a lot of biomarkers, and we'll just discuss how important various biomarkers are. You have intraretinal fluid, you have subretinal fluid, and you have sub-RPE fluid also. So, you know, this is a post hoc analysis of the VIEW study, which studied aflibercept and ranibizumab both actually as comparative and compared them. And they found that patients who had intraretinal fluid, they had worse outcomes as compared to those who had no intraretinal fluid. So eyes without intraretinal fluid at baseline, only subretinal fluid, that means, showed higher starting visual acuity and also greater gains in BCVA during anti-VEGF treatment. So this is one of the factors that determines how the patient will respond. This is a very important factor. And this is from the EXCITE study, again a post hoc analysis, and it showed that the development of new intraretinal cysts after the initial loading dose, they are associated with a subsequent BCVA decline. So the longer the lesion can be kept dry before a recurrence occurs, the better the chance that the visual outcome will be much better than that. So this is what you see here. This is those patients who got new intraretinal fluid at month 3. They don't have such a great outcome. Or 4, they don't have as great an outcome as compared to those who had the new fluid coming at month 5 or did not get any new fluid. These patients behave better. So this gives you a prognostic indicator that when you're given the loading dose and the patients respond with complete drying and the fluid takes longer to come back, these patients will over the long term also do better. The next thing that you have to, the next thing that is important is, Neha talked about this also, that there's a stage when you sometimes can't remove the fluid. Now, this is the study from Hawk and Harrier. They've done a pooled analysis of all the patients and saw that those who had higher variability, that means fluctuation in the fluid, they had lower visual acuity gains. So you see this is quartile 1, which had less than 27 micron fluctuation. And then you have quartile 4, which had more than 68 micron fluctuation. So the ones who had maximum fluctuation had the poorest visual outcomes. You see that? Just 2.1 letters, as opposed to 10.1, the 10.3 letters in the quartile which had minimum fluctuation. So first thing, we want to dry the lesion. If you can't dry the lesion, you want minimum fluctuation in the lesion. So these studies tell you what are we trying to achieve. Now, what kind of fluid is good, bad, or is every fluid equally bad? So this is an analysis from the CAT study which showed that persistent subretinal fluid did not adversely affect visual outcomes as much during the anti-VEGF treatment. So this is a very important factor, and this is the basis of a lot of decision making going on now. At week 52, the presence of subretinal fluid had no difference, made no effect on the visual. Even at week 104, 2 years later, the vision was not affected. In fact, some people believe it may even be protected. But when you have intraretinal fluid, if it is present, it causes more effect on the vision. Vision outcomes are worse in patients who have persistent foveal fluid, foveal intraretinal fluid. So while the study was not meant to determine this, but these are just facts which came out, and these are pointers towards how you should manage your patient. Now, this is very important. This is what they did. They picked up all the patients in the Hawk and Harrier study, and they took those who had high fluid, that means high disease activity, the 25% of patients who had had higher amount of intraretinal fluid or subretinal fluid or pigment epithelial detachment, and they compared them with the ones who had lower disease activity and saw what is the effect of this fluid on the outcomes. And you see from here, regardless of the type of fluid and regardless of whether it was the Hawk or the Harrier study, intraretinal fluid, subretinal fluid, and pigment epithelial detachments all made a difference to the visual outcomes. They were better when the fluid was less, worse when the fluid was more. Of course, intraretinal fluid makes more of a difference, as you can see here. Subretinal fluid makes less difference. Some difference was there between the PED in Hawk and Harrier, which could be because of maybe the patients who were the Japanese patients had more of PCV and they got included in the Hawk and got better results. And so we need to check that out. But the basic thing is more the fluid, worse the visual outcome. Now, how do you remove this fluid? How do we make sure that we can? There are many ways. You have monthly treatments, which were shown initially. Then you have 2 monthly or quarterly treatments in the PIRE, Excite, View, and Hawk and Harrier. Then you have the PRN and the Treat and Extend. The most important of these are the PRN and Treat and Extend. And regarding the PRN treatment, the one thing that came out after all these studies was that monthly follow-ups are important. And you need very stringent guidelines for retreatment, which includes any loss of visual acuity, any OCT evidence of new fluid or persistent fluid from the last injection, any increase in the fluid, any new macular hemorrhage. Now OCT may be okay and you find at the edge there's a new macular hemorrhage, it's an indication for treatment. Or any subjective evidence of fluid also. If the treating physician says, hey, I think there's some more fluid than before, he can consider that as an indication for treatment. The Treat and Extend approaches which are there. Now here you have what is the Treat and Extend approach? Just to briefly tell that, basically you give the the monthly treatments. Then once the exudation is not there, it dries on OCT, you extend the treatment every 2 weeks. Some do every 4 weeks also, up to 12 to 16 weeks. 12 weeks is for ranibizumab. You can go up to 16 weeks with aflibercept. Now, if there is a recurrence of the subretinal fluid, intraretinal fluid, or any new macular hemorrhage, the interval is now reduced back by 2 to 4 weeks, again till the macula dries or the hemorrhage is stabilized. If they are very severe recurrences, you may even decide to go up to monthly treatment. The treatment interval is not extended if there is persistent but stable fluid in this was used to be the initial thing, but now you may consider, this is the present modification, you may decide that if it's stable fluid, you may consider increasing the interval between the treatments. If there is only a pigment epithelial detachment and it's persisted in the absence of SRF and IRF, especially if you're treating with ranibizumab and aflibercept, you can extend the treatment. Now, this is just to show you how the SRF, our tolerance has increased over time. So what you see here is the Altair study, where their criteria for shortening was if there is persistent or increasing fluid. If there was fluid was decreasing, they would maintain the interval and they would extend the interval only when the lesion became dry. So this is a very intensive kind of treatment. But when the Hawk and Harrier came, it started tolerating some fluid. And you'd see over here that they have at 16 weeks, if you have some SRF but no loss of vision, they wouldn't treat. This is considered as disease activity without vision loss. Even if there was some SRF and the fluid increased by 75 micron, it wouldn't be treated if the vision was the same. So the tolerance for fluid has increased, especially for subretinal fluid over a period of time. So now let's see how should we be treating. My take on this is treat and extend regimes you use more commonly in clinical practice. These are more proactive, but they need greater number of injections. So in our setup, we must be careful. You may end up with a very expensive form of treatment if you go for treat and extend for every patient. But it's a good option for patients who are one-eyed, where you can't take a chance. I'm talking of our setup. Or in patients who become stable and are not dry, and you want to see what is the maximum interval you can extend to which the patient stays stable. And that will decrease the number of injections for these patients. A wait or extend or a monitor and extend is a way of which the form of PRN is more reactive. Basically, there is a risk of recurrence, but if you catch early recurrences, you're not likely to lose vision in these patients. So this is one option. It's a good option for two-eyed patients, and especially in whom once at least you brought the lesion to become dry. Of course, you need to have further evaluation of these in robust trials. Now, what about the efficacy of the drugs? Are they all the same? Now, let me tell you, clinically, I think type 2 CNVMs, even ranibizumab works very well. You don't need to go to very advanced kind of treatments. But type 1 CNVMs, probably aflibercept is better than ranibizumab. Overall, now, if you say, are these the only two drugs? If you're giving monthly treatment, even monthly bevacizumab is almost as good as monthly ranibizumab. But still, the macula dries less quickly and less often. So it's not, if you go through the CAT trial, you realize that. Brolucizumab may be more effective in drying fluid, whether it's subretinal fluid, intraretinal fluid, or RPED. And you can see that over here. This is whether there was intraretinal fluid or subretinal fluid. Week 16, 48, 96. You can see always brolucizumab was better than aflibercept. Similarly, it's also more effective for removal of sub-RPE fluid. So as compared to aflibercept, there's early resolution of sub-RPE fluid, and more patients get that. What about the safety? As far as safety is concerned, ocular safety, both ranibizumab and aflibercept are safe. Bevacizumab, the only problems we've had are episodes of cluster endophthalmitis. So if you're sure of the source of your drug, you could go ahead with that. Brolucizumab has a 1 in 200 risk of an additional 1 in 200 risk of intraocular inflammation and a 1 in 400 risk of an inflammatory vascular occlusion, which has not been seen with the other anti-VEGF agents. And in the presence of systemic events like systemic MI or systemic stroke, the ranibizumab 0.3 milligrams is the only thing which has shown its safety in the Sailor trial. Now, how long can the drug last? Well, the fluid study showed us that the ranibizumab can extend to an average of 7 weeks, Altair to around 12 weeks in 60% of patients, and in 40% of patients up to 16 weeks. And Hawk and Harrier showed that brolucizumab can be taken up to 12 weeks in at least 60%, 50 to 60% of patients. Now let's come to actual treatment. You've got a patient, you've given 3 injections, lesion becomes dry. You have 2 options. You can either put him on a treat and extend option, or you can take him to monthly follow-ups with a PRN when the recurrence occurs. I've already discussed about the treat and extend. Now, if it's dry for the next 3 months, continue your monitor and extend with follow-up intervals progressively increasing to 6 weeks, 8 weeks, 10 weeks, and to a maximum of 3 months. If recurrence occurs, treat it again with PRN treatment. Gauge the treatment intervals for a few months. See how often is the patient requiring the treatment. If you can take him to beyond 8 weeks, great. If you can't, consider an alternative in the form of aflibercept. The second group of patients are those who are not dry at 3 months. They've still got fluid. Continue your monthly treatment. If it dries in the next 3 months, now goes to the same paradigm which I just explained before. If it doesn't, this is where you can consider a treat and extend regime as I've just described. And alternatively, you can always consider aflibercept. Now, after you've given, now we've started giving aflibercept as the initial treatment in patients who've got occult CNVM, that is the type 1 CNVMs, and you follow it up with a treat and extend regime in patients who've become stable but not dry. And you want to see whether you can increase these intervals beyond 8 weeks. If you can't increase the interval beyond 8 weeks, you can actually give a trial to even ranibizumab. So this is just to show you, you have a patient who's dry or stable but not dry. You try treat treat and extend. Aflibercept, you go beyond 8 weeks, continue on this treatment. You don't, give it one trial of ranibizumab. If that helps you to stay beyond 6 weeks, you can do that. And if that's not working, give a trial of brolucizumab. If both aflibercept and ranibizumab are needed 4 to 6 weekly, I would actually prefer ranibizumab. Now, this is what I've just said. Now, when do you switch? If the frequency of treatment with ranibizumab is it's needed more than every 7 weeks, consider aflibercept. If with aflibercept, you are needing to give the injection in every less than 7 weeks, consider a switch to brolucizumab. And the same applies if you've got a stable and dry lesion and you're needing monthly to 6 weekly ranibizumab, try aflibercept. Or you've got a stable and not dry lesion with needing 4 to 6 weekly aflibercept, switch to brolucizumab. Now, you can also switch between brolucizumab and aflibercept if following brolucizumab at 4 weeks you have fluid and you don't want to give brolucizumab again, because we realized giving it monthly can sometimes increase the risk of intraocular inflammations. But this is the most important, and towards the conclusion, remember, regardless of what you do, the long-term outcomes are the same. There's been no difference. This was a study which compared ranibizumab, aflibercept, and bevacizumab, and found that over the long term, no difference in visual outcomes was there, or in the number of injections between the agents used. OCT showed that the amount of decrease in fluid was also similar in all the 3 groups. So the important thing was what? The eyes which gained more were those which got more injections and continued to receive treatment for a longer time. So the most important thing is not whether you gave one or the other. So don't fret if your patients are poorer, can't afford brolucizumab and can only afford bevacizumab. The important thing is to persist with your treatment. The longer the treatment continues, the more the number of injections the patient gets, the better he does. And this is a FIDO study which showed that with ranibizumab, at 7 years, they could maintain better than 20/40 vision in almost half the patients. Now that is great. These results are way beyond everyone else because they gave large number of injections. They continued to give the injections every 4 to 8 weeks, as long as was needed, and the patients have done much better than with the other drugs. So, ladies and gentlemen, the important thing is no tolerance for fluid, and for specifically intraretinal fluid, not tolerated at all, unless it's completely unresponsive. Subretinal fluid, you may tolerate up to 75 to 100 micron, but that also is when you're not getting a dry retina. Sub-RPE fluid does not respond to ranibizumab, so you don't have to run after that. Increase in fluid is not to be tolerated. And this is the last slide, ladies and gentlemen. Aggressive treatment is the key. Monthly follow-ups are essential till the lesion heals, and then 3 monthly treatments for lifelong. Greater the number of injections, more intensive and longer your follow-ups, better the visual outcome. And initial PRN treatment can be converted to later treat and extend treatment once you have an idea how long the patient is able to respond to one treatment. And lastly, have a high index of suspicion for retreatment. I've already said what are the indices for that. Eternal vigil is the price we pay for maintaining vision in patients with CNVMs. That is the concluding message for all of you. Thank you very much, ladies and gentlemen.
Thank you very much, sir. It is completely crystal clear. The patients need to follow up every month. We need to somehow try to reduce the number of injections. But if you reduce the number of injections more, then the visual acuity drops. So it's a clear, decision making that has to be coming in. And shift one activity to the other if the duration of inactivity is increasing. So Thank you very much, sir. Now, very quickly, we will go on to prepared 5 or 6 clinical case situations, which we will discuss, and we will try to bring in whatever was told over the last half an hour into clinical practice. So that's what we will do. Dr. Sheena Lisbani is a vitreoretinal surgeon trained in Shankar Nethralaya. She is currently working in Tony's Eye Hospital, Alua.
Thank you, Dr. Gopal. I'll come share my screen. A second.
I think in the panel we also have Dr. Harshali, who is a dynamic person who is basically anchoring this particular program. Harshali, welcome. Welcome to you also.
Thank you,
Is
sir.
my screen visible?
Yes, yes, yes. Yes.
Okay. Okay, so I'll just quickly run through this choroidal neovascular membranes. I've put in a few cases. So now I'll go to the first case. This is a 52-year-old gentleman who came presented with decreased vision in the left eye. This was his visual acuity. And the fundus picture, fundus examination showed a little bit of fluid superior to the fovea, a few hemorrhages, and an angiogram was done. This was his fluorescein. It showed a typical type 2 membrane, almost 100% classic. And this was his OCT at presentation with subretinal fluid. This particular scan is taken just above the fovea, not the central scan. And that is subretinal hyperreflectivity. So this is how he responded to treatment, did pretty well after 3 doses of ranibizumab. Now, this is another patient, 80-year-old gentleman. The right eye had poor vision. It was always scarred CME. What you see here are the pigmentation. That's not hemorrhage. And the left eye presented with decreased vision in the left eye and showed hemorrhages. There was a cataract also, so the pictures are not very clear, and some amount of fluid. So this was his OCT showing subretinal hyperreflectivity with intraretinal fluid, a little bit of subretinal fluid. We didn't do an angiogram because he was already a single eye patient and didn't want to waste time with the fitness and then calling him another day. So we went straight ahead with the anti-VEGF, and this was how he responded after the first dose, and then after second, there was scarring but still activity, and finally after the 4th dose, he received 4 doses totally. Scarred, a little bit of activity. He also underwent cataract surgery. This was his OCT after the first and after the second. Scarring is there with a little bit of intraretinal fluid. More scarring, but however, vision did not improve. In fact, it worsened after treatment. So to summarize, the first patient was a juxtafoveal membrane with subfoveal fluid, good improvement after the loading dose. The second patient had a juxtafoveal, almost foveal membrane with intraretinal fluid, shallow SRF, dry macula at the end of treatment, but with a poor visual outcome. So the questions that I would like to ask the panelists, anyone can answer. In a typical type 2 CNVM, do I need to do a baseline ICG? The first patient, it was a classic case. So
let's take one question at a time.
Yeah.
All right. I think, Harshali, can you answer that question? A typical type of CNVM, do I need to do a baseline ICG angiography in all patients? What is your opinion?
In a typical CNVM, I don't think I would get a baseline ICG in every case, unless probably he doesn't respond to the anti-VEGF, the initial loading dose. If he doesn't respond, then only I would usually go for a ICGA. Do I need to classify CNVMs being mindful that they would all need? Yeah, I would classify them as type 1 and type 2, mainly because, and type 3, mainly because their prognosis, their long-term vision would depend on the type they are. The type 1 would have a good visual prognosis as compared to type 2, who would scar more, who would have a fibrotic component more with damage to the photoreceptors. So though we're treating all of them with anti-VEGF right now, in terms of how their visual prognosis would be, I would still classify them. Then
the reason I put that down was because most of the time, sometimes we do see very clear-cut cases and there's no confusion. But a lot of the time we see lesions which are mixed. So do you really sit down and you examine the images, and do you really put it down as 1, 2, or 3? That was the reason I put that question.
Yeah, in the sense, in a busy OP, maybe not at the first sitting, but if he's not responding well, the OCTs are of concern, then in any way, generally we would put it as the type he is. Yeah. Also, because we would, patient would ask you, what would be my reading vision after a few years? So I think, yeah, you would put them into at least the type, or at least a mixed type if there is a mixed variety. What is the prognosis? Sorry.
Yeah.
You had something to say?
Yeah, actually, I was wondering about the ICG question because most of the cases I don't even do an angiography, a fluorescent angiography now for CNVNs. I do OCT angiography along with the OCT. So like I said, mostly, and it's decreasing each and every day. I would say I see no indication to do a fundus fluorescent angiography. ICG, as Dr. Harshali said, in non-responders, yes, but then actually, you know, the picture changes with treatment. So your best shot at picking up a RAP lesion or a polyp is actually initially at baseline, and possibly the OCT can give you some markers, you know, in which cases to go for ICG. So baseline is the best time rather than after repeated injections. If you could just go back to the scan, because I quite liked how you compiled the two cases, and you know how you said they both had juxtafoveal membranes. So then why did the second patient not fare good? Could we have predicted this or have prepared him for this? So one thing is that, you know, the other eye had a strong fibrotic response, even though if it was in the absence of treatment. But I have seen that patients who tend to, you know, go into more of the cicatricial or fibrotic process do so in both eyes. I think Dr. Talwar can maybe say more on that. But very dense fibrotic scar in one eye, definitely I will be very cautious in the other eye. The second thing, if you see on the first OCT itself, there is the presence of SREM, which I had just showed, the subretinal hyperreflective material. And this is not the membrane complex, because you see the RP choriocapillaris and Brooks is all intact underneath that. So that hyperreflective lesion you see is SREM, and it has persisted after your first injection as well. So it will not 100% predict, but it will give you an idea. This is a big lesion that this eye in the fellow eye of a patient who has this large scar might scar, and we counsel the patient accordingly that, you know, at least we don't tell him that he might go to 6/6 and then he goes to 3/60. We can very well prepare him for the eventuality that this eye might also scar despite treatment. So this, I think the OCT can help us to see. And then you see after the third injection, when the SREM has kind of disappeared, then the RP choriocapillaris and the Brooks has become disorganized because of the scar. So it has actually given way to that.
In connection with SREM, what would if you were seeing this patient, would you actually kind of tell him that your vision can go drop? And so, I mean, how do you go about that situation?
Yes, I would. And I would show him the other eye picture, because like I said, I have seen, and I think many of us have seen clinically that when one eye has this, the other eye has also a tendency, because there might be a lot of systemic factors. As we know, the response to anti-VEGF, I mean, is both neovascular as well as fibrotic. And so if in one eye that has happened with or without therapy, there's a strong chance it can happen in the other eye. The other thing I couldn't see very clearly is, but the choroid in this case, was it normal or thinner? I could make out in the images.
No, I have access only to a spectral domain, the Serous. So really, don't get good choroidal images.
Yeah.
I'd like to make a point here. See, the
Yes,
thing is, you can have one eye getting into a scar situation because it was ignored, not necessarily because it had a tendency to a severer response in terms of a scarring. As far as counseling is concerned, actually, I counsel all my patients that you have a 70% chance of, 50 to 70% chance of improving. You have a 90%, 95% chance of staying where you are. You won't become better, you won't become worse. But you have a 5% chance of becoming worse. And that's across the board, because that's exactly what the outcomes have been described. And that's exactly what you're going to get. Now, basically, when you have a classic CME, as you showed very beautifully, there are two possible outcomes. Either a patient is going to develop too much of scarring, and that scarring is going to cause a vision loss, or that patient's scarring will be minimal. You know, the membrane which forms will be so fine that the visual acuity will not be affected, and very often the scar just misses the foveal center. So there may be a scar, but the foveal center is missed, and you can have still good vision. I actually have a patient whom I started off with counting finger 1 meter, but just the foveal center was spared, and he finally went off at 6'9". So it can happen.
This patient, actually, I did the scan very carefully, and I thought it was just sparing the fovea. I had a good, I had hopes of him, at least regaining retaining the vision, but unfortunately.
Yeah, but your lesion, actually, if you look at the lesion in your photograph, the first photograph, the 636.
Yeah, that is the first photograph.
If you remove the OCT from there, can we remove only the OCT? Yeah. So you are right. This is just at the edge. But unfortunately, when the scarring occurred, it went beyond the edge. And this is the kind of CNVM which can actually just dissolve. It doesn't have to go into a scar. But sometimes it will form a scar. And when it forms a scar, you lose. Yeah.
There is one thing that we need to also think about. How long after the patient started getting the symptoms or started getting the CNVM did the treatment start? But here is a problem. Because it was not subfoveal, his symptoms started probably a little late when the CNVM became fairly large. And so there will be more mature vessels, and probably the scarring will be more when we treat the angiofibrotic switch of early. Had this been more into the fovea, probably he would have come early, maybe 2 months before. And as Dr. Dinesh Talwar sir said, it may have dissolved. For positive type, can we move to the next case?
So I'm going to deviate a bit to myopic CNVMs. This is a patient, a 62-year-old lady who came with decreased vision in the left eye. This was her fundus picture of the left eye. A little bit of hemorrhage, if one look carefully, and a few hard exudates. This was her OCT taken through the fovea, a small membrane, and this was her fluorescein angiogram, which showed a classic lesion again, and she received a single dose of intravitreal ranibizumab. However, the right eye also, OCT, the angio, so actually I picked it up only when I saw the angio, also had a lesion beneath the fovea, and then I ran my scan and I looked carefully at the scans, and I saw a small membrane corresponding to the fluorescein angiogram. So, however, she was asymptomatic and refused treatment. And then that was just before the pandemic, so she was lost to follow-up for some time. And then she came back after 10 months and she presented with decreased vision in the better eye, the right eye, with 612 N12 and lesion encroaching onto the fovea. And this was her OCT through the center and through the inferior portion of the membrane. And this was her left eye, also showed a little bit of activity in spite of receiving 1 dose of ranibizumab. And then the right eye, she went on to receive 2 injections, and the left eye another 2. So, and that was her final visual acuity. So the questions are.
This is a very interesting thing, and it's a very important thing. In myopic CNVMs, you cannot use OCT as your major factor for diagnosis as well as for decision regarding when to stop treatment. See, what happens is that you look at the OCT and you say, well, okay, now it's scarred. It may not be. It will come back.
So how do
it's
you
important.
decide? Yeah.
Yeah. So I will give the injection and follow it up the next month with both fluorescein angiography and an OCT.
Okay.
The first month I may follow up with OCT as long as I am not sure whether it's healed completely. But before I declare that you healed, I'll do a fluorescein angiography.
So to answer the third question, what is the end point in treating a patient with myopic CNVM would be a repeat FA, which shows no
resolution on the fluorescein angiogram.
What about the role?
And I can tell you, first I used to think that they all respond and they won't go away. No, today I have patients who have come back many times afterwards. They become okay, but they come back. So, and especially in the older group, the younger ones, if you have a young patient, usually it'll go away. If you have an older patient who's high myope and a myopic CNVM, the chances of recurrence is much, much higher.
And once you're happy with FA, your FA that the lesion is quiet, they never come back?
No, they will you still need to follow them up on a 4-weekly basis.
Okay.
But there is one thing, they significantly develop a metamorphopsia and they will understand much better than the AMD patients.
True, they will. But the point is, you can't rely on that alone.
Yeah, that is true. That is true.
Like in your case itself, the other eye, the patient didn't complain, though the lesion was there. So in fact, I will go a stage further. If a patient comes to you with a high myopia and his vision is not 6/6, on the OCT, if you find something, great. But you should do a fluorescein angiography also if there's a doubtful lesion on OCT. That means you find something there. You're not quite sure whether you're dealing with a CNVM. Do both an OCT angio and first I'll do that and then a fluorescein angiography also. Till I've done everything, I will not say this is only because of your high myopia causing your vision loss. So especially patient comes with 6/18 vision. Don't ignore it.
What about the role of Octa in a myopic CNVM?
Again, Octa has a role. Octa has a role, and since these are usually type 2 CNVMs, you can pick it up. But the problem that happens is because of their high myopia, they also have more movement artifacts and you don't get clear vision, clear images. So sometimes you may not get a clear image.
I think even the segmentation may be a problem.
Yeah, so it can become so that's why. So I will do all the things. I won't rely on one alone. And what Gopal said, if the patient's complaining of metamorphopsia, I will definitely keep that in mind. I won't ignore that.
Segmentation and also the RP atrophy makes it a problem in Octa. So, I mean, fluoresceint angiography is the way to go in myopic CNVMs, yes.
But this is something that needs to be really stressed because people don't seem to understand that this is one place where OCT is not the deciding factor. Fluorescein angiography is.
So like even in your case, I mean, a novice might just say that there's no fluid even when you see the OCT scan. But like Dr. Gopal said, most of these are young patients and I rely a lot on their clinical symptoms. And, many a times when they say there is metamorphopsia and I don't even see it on OCT, but would definitely go for an angiogram.
And fluid may not be there.
Yeah, like
you can have an active CNVM
hardly any intraretinal fluid and subretinal. They anyways don't have. It's type 2 CNVM.
Sheera, anything to add?
No. Sheera?
Sheena will go to the next case.
One more question. What about the consensus regarding loading dose in a myopic? How many injections on an average do you give?
I don't give a loading dose, but generally 2 they will end up with.
Yeah, I think I will give 2 and then only do a fluorescein, not 3.
But I won't say anything. I don't say you'll get a loading dose. I don't say you won't get a loading dose. I say we will see as it goes.
I'm going to skip this and I'll move on to the next. Okay, PCV. I'll just show quickly 3 cases. This was on a 75-year-old lady who came with decreased vision in both the eyes. The right eye showed massive exudation with a PED just adjacent to the disc, and again the left eye multiple PEDs. The phenotype was suggestive of PCV. This was her OCT. Unfortunately, I have only the scans taken through the center. I didn't scan the other areas. So the OCT really didn't show any OCT features of PCV. And this is a fluorescein angiogram in both the eyes, mottled hypofluorescence with leakage and irregularly filling PEDs in the left eye. And the ICG finally showed a string of polyps more evident in the left than the right. This was another patient, a younger patient, 52-year-old lady who came with complaints of scotoma. Her vision was pretty good. This was her fundus picture, subretinal fluid with a PED, and her OCT reflected the same thing. Her fluorescein angiogram didn't show anything except the block fluorescence, and likewise ICG. I have access to a flash ICG, not an SLO, so I don't know if that could be the reason. The ICG didn't pick up anything. So anyway, since she had blood under the fovea or next to the fovea, we went ahead and gave an anti-VEGF. This was after the first. There was some resolution, and then area of new hemorrhage comes up, so we went ahead and did the 3 doses, and she improved quite well after 3 doses. She was symptom-free and maintaining vision. This was how her OCTs looked through the 3 injections. And this was another 50-year-old lady who came with, again, not so much, more of metamorphopsia, not so much of vision complaints. Yeah, so she was seen at another center and was told that she needs injection. So I really didn't do an angiogram. I did the OCT, and she was ready to take the injection on the same day. So then anyway, I went ahead and gave her ranibizumab, and this was how she responded after the loading dose. Not much of a difference, almost the same. Vision also maintained. Her OCT showed a resolution in subretinal fluid, but the PED persisted. But after 1 dose of aflibercept, she responded better and she became symptomatically better. Vision, luckily, was still okay. So this was, in summary, the first patient. There's a clinical suspicion of PCV, no OCT features of PCV, and confirmed by ICG. The second, the clinical suspicion of PCV, OCT features was correlating and but inconclusive angiogram, responded well to ranibizumab. And the third patient, clinical suspicion of PCV, OCT features of PCV. Of course, angio was not done. Poor response to ranibizumab and better response to single dose of aflibercept. So these are the questions. Is ICG mandatory for diagnosis of PCV, or will OCT features of PCV suffice to make a diagnosis? Because there's a recent article by Jimmy Cheng et al. Who pointed out the OCT features and how you can conclude with just looking at the OCT that the patient has got a polyp. Yeah, that is the first question. Anyone would like to?
I want a counter question before we answer this question. Would you do laser for an extra foveal polyp?
I don't mind.
So then you need to do an ICG. In fact, your third case, there's a very high chance that you would have had a significantly extra foveal polyp.
Mm-hmm.
So
why do you say that?
Have a look at the knot and that polyp there. That's, yeah. So before this, the first one, yeah. So if you see this one, you see the location of this, the edge of the fovea, most likely somewhere here. Now you see your OCT somewhere around this, the lower part. You have your notch. That's where probably that's where the polyp could have been. There is this orangish lesion here. I wouldn't go in that lesion for doing a focal laser. I would, in today's world, I would stay away at least a disc diameter away from the area where I want to do a laser. So I mean, in this situation, it's worth doing an ICG to check out whether you can. What about the one before? There was another one where the left eye, there was multiple polypoid lesions.
Yes. That was the first patient.
Yes. And
unfortunately, I didn't get to treat her because she went.
Yes. So that's another situation where you could consider. In this patient, your second patient, I wouldn't bother to do an ICG right now because I'm not going to do laser for this. Unless you want to do PDT and you have excess, then it's different. But otherwise, I would not be considering. So then I would go only for anti-VEGF. The first case.
This patient.
Yeah. So you have multiple extrafoveal areas which you can consider for treatment. How often have you seen a rib following laser for a PCV? And that's to you also, Gopal.
Sir, we have the number of lasers that we've done is far, far less than the number of injections that we've done. So I don't think we can make a fair conclusion out of that.
But have you
all
got
those lasers that we have done?
Yeah.
All those lasers we've done, we have basically tried to completely, scar that CNVM if it is an extrafoveal choroidal neoascleral.
No, I'm talking about RPED because these are RPEDs where you will have these polyps.
Yeah.
And some of them can be tense.
Yeah. So if we laser densely in those, we are not bothered whether there is a rip or not. Our basic idea is to try up and we'll jalado.
No, but in an RPED, you don't want to create a rip, no? So I'm just asking, I'm scared about this. I'm asking this question basically because
as
I'm
you
scared.
said,
So usually
we will be doing a laser only 1 diameter, 2 diameter away from the fovea.
Yeah.
So that area, if there's and most of these pigment epithelial detachments are not very large. These are more smaller detachments.
Yeah, the smaller ones you don't mind taking a chance.
Yeah. If it's a large one,
what about
the edge of which is coming near the fovea, I don't do laser because there is a chance of bleed also.
Yeah.
Apart from
Sheena, what about you?
If there's a large PED, no, I wouldn't. I would if it's a small PED, yes, I would. If it's extra.
I think we've become more scared with lasers also. Not that injections can't cause a rip. But,
no, yes.
But
this particular patient, I was actually quite skeptical, but anyway, she responded luckily from yes. Dr. Neha, would you do an ICG for all patients of suspecting or would PCV or would OCT suffice for you?
I think it depends a lot on the availability. So about earlier when I had very easy access to ICG, my threshold was much lower. Now, because I don't have it at my center, I would have to send the patient. So I think a lot, and the IR ICG, I think my decision, a lot of it depends on the availability. If I'm going to a center which has it, I have a lower threshold, and if I have to send the patient and don't gain anything except maybe, for publishing or presenting the case, then I would have a lower threshold. But definitely in the third case, I would have gone for an ICG. The one with the large serous PD. And in the second case, I mean, yes, we say that it penetrates sub-RP blood, but I mean, seeing, at least I wouldn't do it at presentation. Maybe after one injection, when the blood clears up, then I would do an ICG if easily available, just to then see if there is still a remnant polyp or something which might be amenable to laser. But at presentation, there are very less chances that, even ICG would pick up a polyp with that denser hemorrhage. So in fact, I had a very similar case recently where after 3 injections and then I did the ICG and there was still a polyp which I then lasered. So as far as what Dr. Talwar asked, so in PDs, I don't laser, but I shift more towards the use of aflibercept, especially now. And especially if you see the, choroid, you can take a decision as well. Most of them have pachychoroid, so aflibercept might be the first choice. And
So that
like,
answers the second question. Okay.
yeah, and like sir said that rips are pretty common with anti-VEGF also. I mean, I don't remember the figures, but I think equally common, especially with ranibizumab because of the sudden drying and all. So if it's extrafoveal anyway, it does not matter. But in the presence of PD, it's more so because of the hemorrhage that I wouldn't opt for laser. Then PEHCRs like peripheral polyps, we use laser as first line treatment if there's no hemorrhage and it allows it.
This last patient, which I showed you, would you? She had pretty good vision. Would you, wait for whatever length of time for the PED to kind of flatten down before actually giving an anti-VEGF, or do you actually look into those criteria for at-risk at-risk for RIP PEDs before deciding to offer treatment? Or just counsel the patient uniformly?
If there is SRF, you would treat.
No, but a patient who had the SRF had resolved after the loading dose and the PED persisted, 6/9 or 6/12 N6 visual acuity.
Yeah, so that's the situation where because your diagnosis is PCV, I would consider giving another injection. But otherwise, as a routine, I would not be running after PEDs.
So, but then what will be the end point of treatment? Because the PD might very well persist for very long with ranibizumab especially.
So don't see, first of all, if the patient can afford it, this is a better situation for giving aflibercept.
Yeah, aflibercept.
You don't start off with ranibizumab.
Okay.
You know?
So with ranibizumab, the flattening is not that commonly.
It's not going to happen. Then you might as well leave it. See, if the patient is going to be on ranibizumab, you leave it.
So then if there is no SRF,
then you leave it.
Dr. Sheena asked,
But
so then you will not inject.
Yes, but my preferred choice would be aflibercept, and my question would be, would you like to start with brolucizumab? Which is supposed to be better.
But not, I don't know, sir, are you using, or are the other panelists using as first line? I
don't use brolucizumab first line. That's why I'm asking whether anybody in this group would want to use brolucizumab.
I have used, sir, but the numbers are not good enough to, aflibercept is very good.
Yeah, actually, there is
about 50% of cases there will be resolution after 3 injections. The repeat ICG will show that the polyp is completely gone.
Yeah, so
brolucizumab, I don't have that many numbers to comment like that.
Yeah, but I can tell you the data available from the literature also says the differences of some 7-10%. So it's a little more with brolucizumab, but it's not as if aflibercept doesn't work and brolucizumab is the only thing which seems to work. That's not true either.
But like Neha said, sir, with ranibizumab, the flattening is not as good as aflibercept, is what I have also done.
So you don't do it.
But the literature has almost equal flattening of the PED with ranibizumab as well as aflibercept.
No. It's everywhere it says don't try to remove the RPED with ranibizumab.
No, actually, the second patient that I showed, her PED had kind of flattened with ranibizumab.
Yeah, so it's not that nobody will flatten with ranibizumab. It's just that few will. And then if you've got a shallow PED left, please don't follow it up. I mean, don't keep on treating it. It's not going to go away.
It's the large
I mentioned that also in my lecture also. I mentioned that also, that with the ranibizumab, don't run after the PED.
So if there's a very large PD at presentation, then we try to give Eylea, and there is a dramatic resolution in many cases we've seen. And even if we switch later on, let's say for non-response of the intraretinal or subretinal fluid, not just for the PD, you do see that the PD has also flattened out when you've shifted to aflibercept.
So when you see poor response, do you wait for the loading dose or do you switch? I mean, just in case you do give ranibizumab initially and the patient has not opted for Eylea.
You use the excuse of the loading dose, yes.
You do? Okay.
Yes. You're back to AMD, so loading dose is there.
Is there?
It's a form of PC.
Yeah. Do you tweak your treatment based on the patient that you see, patient profile, basically financial?
No, I don't change with the patient in terms of disease profile. Yes, patient profile, no. I'll not say that you're a poor patient, so therefore I will not give you. No. I will offer the same treatment across the board, And I will tell the patient the option. I'll tell them the positive and negatives. I will tell him, for example, that aflibercept is a better drug for you to go. It will be a slightly more expensive drug than taking a biosimilar of ranibizumab. But in this particular situation, this is the better. Like for, I go the other way around also. In type 2 CNVM, I will not offer aflibercept. I will tell the patient, you go for ranibizumab.
Dr. Gopal,
Actually,
Harshali and Sheera, can you, it's now 5 hours after the start of the CME. Should we, yeah, Neha wanted to say something. After that, can Harshali and
what I
Sheera
was
wind it
going
up?
to say. No, I was saying that actually with Bayer's scheme, so Accentrix and Eylea comes to the same cost. So cost doesn't remain an issue then, but only with the biosimilar. Yes, the biosimilar is yes, that's the much lesser.
Yeah.
I was going to say something, but I've totally forgotten. Sorry.
Sir, one small question, sir. Is there any role for steroids, sir, in cases of CNVM non-responders?
No, not in my not in my treatment profile. I don't add steroids. But if I get a patient who has, there are some patients who sometimes get a loss of vision following an anti-VEGF, and I will empirically give them a short course of steroids. Sometimes I don't know whether that makes a difference or whether they would have recovered anyway.
Okay, I was talking about the switch agents, which Dr. Sheena asked. So even after 3 loading doses, like I would usually wait for at least six months before switching an agent, unless there's absolutely no response. So if there is a suboptimal response, then I would still continue with the same agent for, say, at least 6 months, which is what most of the studies also before labeling as a non-responder.
But not with, if you started off with ranibizumab and you have an occult CME, then after 3 injections, it's better to shift.
Yes, but if like there's a PD which is flattening a bit, or the
if it's improving, you can continue.
Yeah. So if it's suboptimal, the response is there, but it's not that much. And also, I don't know, I don't even do the OCT during the loading doses. Maybe just one to see the response and counsel the patient, but after that, straight away after the loading dose. So there's no change in the management before the 3 loading doses are over.
Okay, I believe in monthly follow-up, monthly OCT. The objective is how the eye is behaving. See, whether you get 1 extra month of watching. Like you've seen the effect, you've seen whether after month 2, did you get a further response? Is it suboptimal response or no response? So those things make a difference. So I would prefer to do a monthly OCT as well as a monthly follow-up. Patient can't afford it, I'd rather do it free, but I'll still like to do it.
Follow-up, yes, but OCT at the 2nd month, if there's been a good response at the first, then usually I don't know. Unless the case is
how much is the response?
Academic interest or,
No, it's not academic interest. It's a practical problem. You want to know after each injection, what change is occurring. Otherwise, your only parameter is the response after the first injection.
And the 3rd injection.
Yeah,
so you're only missing the 2nd one.
So you're missing what happened in between. So I don't want to miss
1 injection.
Yeah. In fact, you are able to titrate your treatment much better if you are doing monthly follow-ups with monthly OCTs. So that's a guideline I follow very strictly.
So to answer your question, Sheera, there was one publication from, I think Divya Balakrishnan was also part of it. Systemic steroids for BCB. I think Dr. Subhadra Jalali also has spoken about it. They had some 15 patients which they treated with systemic steroids, and it fastened the resolution of the PED in BCB. Yeah.
I think it was
I have not used that.
Kablani who had talked about something, and I think if I at all want to try it out, I would try it out in patients who have intraretinal cysts, which are not going away, because those could be a component of chronic CME, which is not responding. But I, as a rule, would not like to give a steroid.
Sir, I have seen Mahesh sir giving Osurdex in cases of chronic cases, non-responders, especially with the, as you told, persisting intraretinal fluid and all. And I don't have too much of experience, only few cases I have seen when I was there with sir.
Was there a response? Was it good?
Sir, in that one case which I saw, there was resolution of the intraretinal fluid. I don't know the.
Yeah, so that is the basis. For RPED, no, you don't need to treat RPEDs with steroid. Only intraretinal cyst, there is an indication, but still I would not give it, because most of the time if you're giving aflibercept, it'll be more or less similar in its response. But
Now
yes,
the option of brolucizumab is there. I
so I would rather try that.
have been there.
Yeah.
Maybe.
Can we call it a day, Harshali? Can you do the concluding remarks,
Yes.
Sheila and Harshali? Yeah.
Yes,
This has
sir.
been a TOC, Trivandrum Ophthalmic program along with Kerala Society. So these two are the representatives.
Thank you, sir. Thank you so much. We've had a wonderful discussion, wonderful talk. Teacher like Dr. Dinesh Talwar teaching us. It was an amazing experience sharing the screen. Thank you so much. And I thank all the people who have attended, taken time to attend the CME. Thank you, everybody. Thank you all. I think with this, I will conclude today's CME. Thank you so much.
Thank you. Thank you.
Thank you.
Okay. Okay. Live should end.